a whole new level of academics with traditional harmony and extended hospitality of this pink city, which is the wonderland of culture and heritage brimming with architectural gems. Let me take the honor to please invite Dr. Sandeep Najavan. Sir is the organizing secretary for ISGCon to inaugurate the CME. I would first request that we will be lighting the lamp and beginning this conference. For the same, let me please invite the President ISG, Dr. Mahesh Goenka, Secretary ISG, Dr. Govind Makharia, sir, Local Organizing Secretary, Dr. Sandeep Najavan, Scientific Committee Chairperson, Dr. Sunil Dadich, Vice Organizing Secretary, Dr. Anurag Govil, and Dr. Amit Mathur to please be on the stage. I would also request our local organizing chairman, Dr. R.R. Rai, to please be on the stage. Thank you. Thank you so much. Thank you, sir. We'll be beginning with our first session. Sure, sir. Sure.
Good morning, dear friends. It's indeed a great pleasure for all of us that you have joined us on this academic session, which is the continuing medical education program. You have just seen the lighting of lamp. And now I invite Dr. Mahesh Goenka, our President, Indian Society of Gastroenterology, to speak few words of blessings.
Good morning. Thank you, Professor Rai, and good morning, everybody. I know it's a chilly morning in Jaipur today, and people are gradually getting up, having their breakfast, and coming here. I looked at the program primarily formulated by the local organizing committee. It's a very greedy program, if I can use the word. There are so many good topics, good speakers, and I think they could not take away removing anybody or reducing the number of topics. So we will straightforward go ahead. Once again, welcome you all from the ISG organizing committee. I know that the LOC has worked very, very hard for months, in fact, for a couple of years to make this happen. My best wishes and congratulations to the local organizing committee. Look forward to next 4 days of academic activity. Thank you.
Good morning, everyone. Warm welcome to you all on a chilly morning. Today we have a CME program to start the academic program, and it is started with star-studded speakers, national and international. And we have made a program like it's a 15-minute talk, and there are no question answers because we have very shortage of time. And it is a earnest request to all the speakers that be in time, because we have an inaugural function to have at 6 o'clock. So if we finish in time, we'll be well in time for the inaugural function. Thank you very much.
Thank you so much. For the first session, let me please invite Dr. Mahavir Sharma, Dr. Ashish Joshi, Dr. Rajat Bhargava, Dr. Saket Agarwal, Dr. Nikhil Atolia to please chair this session. Can I also invite Dr. P.K. Agarwal? Sir will be moderating the session. I would also request our adjudicators, Dr. Narayan Agarwal and Dr. Bhushan Pandit, to please be seated. Can I also take the honor to invite Dr. Ajay Kumar for the first session?
Morning, sir. So I think, with the warmth and welcome which we get in Rajasthan, this chilly morning has got no meaning about it. Over to you, sir, to start the session.
Thank you, Mr. Chairman, and thank you, the local organizing committee, to give me this opportunity to be here to be the opening batsman for this stupendous program, academic program of a postgraduate program. The topic assigned to me is what is new in non-variceal upper GI bleed. It's a huge topic, lot of new things over the last decade. I'll try to be brief because the reason is that time allotted is 15 minutes and I have to finish in that. Whenever we talk about management of GI bleed, we are looking at three different compartments, that is the pre-endoscopic, peri-endoscopic and post-endoscopic. I'll take briefly on the pre-endoscopic and then mainly focus on the peri-endoscopic area. And if you are to pre-endoscopic, the issues are on assessment of severity and triaging. The biggest challenge to the doctor seeing a patient in the emergency is where to put the patient in. Whether to patient take in the intensive care unit, whether limited resources, or you go to the ward, or you go to the, or some patients can be sent home. There are current understanding that if the patient has out of all the clinical scores available to us today, Glasgow-Blatchford score is considered to be the most reliable in predicting that which patients can be sent home and can come for endoscopy later on, elective endoscopy within a week or so. That is the Blatchford score of 0 to 1. The challenge is whom to put into the ward and whom to put in the ICU. All patients who are hemodynamically unstable should be moved to the ICU, or those who are on continuously showing hematemesis and so on. And there has been a recent, what is new in that is a machine learning model that outperforms clinical risk scoring systems for upper GI bleed. And there is a gradient boosting machine learning model based on demography, comorbidities, lab parameters and drug history, for which is considered to be better, but of course it needs to be validated in more studies. Just now I was having a talk with Simon that they have done a huge work on that, and which will be published. So this particular paper was in Gastroenterology 2020. Then the second issue, an important issue, is how much to transfuse. There's not too much of new thing, restrictive versus liberal strategy. And here the two major studies in 2013 and 2015, they've shown that the restrictive thing, that is a target hemoglobin of 7 or 8, gives you a better bleeding control and a mortality improvement. So the recommended policy today as it stands is recommended with a transfusion if hemoglobin is less than 7 or 8. And of course, the patients who have associated cardiovascular abnormality, or the patient continue to profusely bleed, please don't blindly follow those parameters of hemoglobin. There you go for a liberal strategy. Now, before we go to the endoscopy, the most important thing that we always keep on debating, what is the best time of endoscopy? If you look at all the international consensus guidelines, the guidelines are very clear: within 24 hours or 4 hours of onset of bleeding. Now, people wonder why not early and why not say. The issues are two: that is it safe? Yes, it is safe. There is no debate on that, and provided you take care. The main thing is that it is useful or not. That this study published by Law et al. In 2020 says that there is no difference in blood transfusions, ICU days, hospital stay, or patients requiring surgery or angioembolization, whether you do early or urgent. So basically, we stick to the policy of a within 24 hours. Exceptions are always there. Early endoscopy may be considered in very high risk, hemodynamically unstable, or patients presenting with massive hematemesis. Those are the two issues that we should keep in mind. So don't be fixed on the simple guidelines. There are always exceptions, and you have to take a decision on the table. There are certain technical issues. They may not be new, but I like to touch upon, because this is for the postgraduates, those who are beginners, that yes, you should be liberal in sedation if required, whether it's a conscious sedation or propofol. And patients with altered sensorium or patients with the increased gastric content, please intubate them. Otherwise, they will expirate and they will end up in a crisis. If available, use a therapeutic scope which has a bigger channel for suction and accessories. The lesions in the duodenal posterior wall or the D2, sometimes duodenoscope may be better than your regular scope. If you have a water jet available, it's always preferred, and you of course have a choice of a bigger channel water jet scope. And this is a technical skill that if you stomach you find is full of blood clots, you are not able to see anything on the area that you are looking at, please turn the patient onto the opposite side. So you will be surprised sometimes when you see a big tumor coming out and showing its face through those blood clots. In the while using therapeutics, sometimes you are helped by using the low profile distal placement cap. The Doppler probe I will talk about a bit later. Now question is, this is something which is not new, which is we all know, that you have a spurter, oozing or a visible vessel, forest A, 1A, 1B and 2A. They go for intervention. And question always remain the debating point, because the incidence of rebleeding reported from a adherent clot is almost range from 12% to 50%. But you see, it is not a single entity. Here the question is that you remove the clot by the smear and see what is underneath that. And that is what will determine whether you need to do endoscopic intervention or not. If it is a clean base ulcer, you don't need it. But if you find a vessel like that, and then you need to clip it. And that's the important thing. But please remember that whenever you are doing that, you have to be equipped with everything. Otherwise, leave that clot alone. Don't smear it if you do not have your full accessories. You do not have the right assistant with you, then you will end up in a mess. Now, as far as the hemostatic devices, traditionally we talk about injection, mechanical and thermal. Injection alone is not to be used. It is a temporizing measure and it has to be combined with a second entity. The main debate comes with the mechanical clips or a heater probe or a bipolar probe. And if you look at that both, there is, as far as the evidence is concerned, there is not much difference between these two modalities. Whatever you are comfortable with, you can use. But one has to look at that certain situations, clip application can be challenging. And that's where it's important. Clip is in the posterior wall of cap or at a lesser curvature, high up in the lesser curvature. Technically, it can be challenging to apply a clip. And same way, if the ulcer is fibrotic, clip will not hold, like in this particular view, the fibrotic ulcer. And so is a large ulcer or a large visible vessel. See, all these modalities, some are user-friendly and some are not. If you look at the injection or you look at the hemospray, they are the most user-friendly. And problem is, most of these bleeders come in the middle of the night. And then you do not have the right accessory or the right assistant, so it can be challenging. So that time when we look for is what is user friendly, and maybe sometime you use that as a temporizing measure and come back next day and do a definitive treatment. Now after we discuss about this, I think I'll focus more on the what is the new modality, what is new in the endoscopy. That's the subject. And let me touch upon the three things and look at the hemospray. See, hemospray came with a bang. It's an FDA approved in the West. Is unfortunately that particular product is not available in India. But in India, what is available here, I've used it few times, but I'm always handicapped by the delivery mechanism is not that perfect and it can fail you at critical times. But please remember that current evidence is of hemospray is a temporizing agent. It's a rescue therapy. And most of the time, you will have to come back after 24 to 48 hours to do a definitive therapy. Otherwise, the recurrence of the bleeding will be there. The challenging evidence has been in the over-the-scope clip, so-called Ovesco. And here, I'm sorry, the video is not working. But this is something, the two trials, STING trial 1 and STING trial 2. The STING study has shown, the first one, that patients who are failed to control bleeding with the standard therapy and have a recurrent bleeding, the hemostasis with the OTSE is better. Further bleeding is less than around 15% as compared to the standard therapy of about 57%. And the STING 2 trial published July 2002 in Gut shows that the clinical success with over the clip is in a de novo ulcer is better, and the persistent bleeding and rebleeding is less. So evidence is evolving, but definitely it is the modality to stay and to look into, and if you have access to it, you must consider that. Doppler probe has been in the field for many years, not very popular, but if you look at this, it's an interesting thing, simple to use, 2.8 millimeter channel. Even if you have a low risk ulcer, if you look at the Doppler, it shows a good signals, then probably it will make a case for an intervention at that stage. And it is a review of 14 studies of more than 900 patients. Risk of rebleeding is higher if the Doppler probe is positive, and the use of Doppler reduce the rebleed as well as it decrease the bleeding related mortality and need for surgery, and it's not that expensive and it's easy to use. A few words about specific, because when we earlier talked about non-variceal upper GI bleed, we basically focus on ulcers, but now we have started seeing more of a tumors bleeding, which is a diffuse. In general, the point that I like to make, when there is a diffuse bleeding, your clips and so-called heater probe or a bipolar are unlikely to work. You need something like a hemospray, which will act diffusely. And so is the vascular lesions. When it comes to the localized lesion like Delafoy's, the same modalities like ulcer, but if you have a diffuse disease like GAVE, you need a thermal like argon plasma coagulation or a laser. And with the advanced frequent use of a third space, development of the third space endoscopy, you see both during and post procedure bleedings, and these are best managed now today by the monopolar coapt Olympus, which is a wonderful modality for the endoscopist to control. And they say because these are fresh ulcers, they are not there's no fibrosis, they're relatively easy to control, and you can just catch the bleeder under vision and coagulate, and bleeding can come under control. So friends, I will the most important for any endoscopic doing any therapeutics, that please, whenever you are doing a procedure, don't be fixed on that. You have a plan B ready. That will make you a good endoscopist. That is the basic lesson that all the students getting into gastroenterology should learn, that your plan B should be ready. That's my last slide to summarize, that we need to integrate the old and the new technologies. And here is a rough algorithmic approach, that if you have a high risk for adverse outcomes, you go for can consider a vascular over the scope clip. But if you have a minor stigmata, you use a regular heater probe or a bipolar gold probe or a clip of any type. And if the Doppler endoscopic probe shows a high signals, one can consider for the over the scope clip. Thank you very much.
Thank you, sir. An excellent talk which one can have, from.
In the stomach, it would be a gastrointestinal stomach tumor, lymphoma, heterotopic pancreas, carcinoids, and in the duodenum, neuroendocrine tumors or carcinoids, heterotopic pancreas, dysplasia, hyperplasia, and some other lesions as well. And there is a huge list of various uncommon or less common esophageal lesions as well. So the question that has been posed to me is when to intervene and how to intervene. So when we look at esophageal lesion that we've seen on what do we look at? We look at the size, we confirm whether it is really esophageal lesion or there is an extraluminal compression. The location of the lesion can give us a pointer, whether it is cystic or solid, and then further on, we will do a diagnostic differentiation, assess if benign or malignant potential, and then plan therapy or follow-up. So this is an algorithmic approach to subepithelial lesions. But presently, I would like you to focus on the first line, which indicates that all these algorithms and these guidelines are for lesions which are more than 1 centimeter, and most lesions under 1 centimeter can often be just followed up with a repeat endoscopy every year. Occasionally, you might want to do a biopsy of mucosa. There is some mucosal irregularity, but that is all. And that is normal, just why these patients are. So, what do we have with us to assess these lesions? We can do ECG or endoscopy. We have endoscopic ultrasound with or without perineal aspiration biopsy, most often nowadays, and imaging in various methods and some specific tests which also are the region dependent. So when we do endoscopy for these lesions, some of these lesions are very problematic. And here you have an umbilicated lesion, you have a carcinate lesion, a molar appearance of the esophageal as a tumor. And this is a classical pillar sign in the lipoma, and we can see viruses and we can identify by location. It's important to identify the location because gliomas are more common in the esophagus and at the gastroesophageal junction, whereas cyst tumors are more common in the stomach. Neuroendocrine tumors would be more proximal in the stochastic body, in the gastric fundus, whereas ectopic pancreas or lipomas are more common in the gastric angioma. On appearance, this is how we can classify these lesions based on the type and whether there is a group or a boundary between them or not. That also can give us a guideline. Based on the color, we can have a differentiation, the one on the left side over here. This very often, this would probably be a myoma or cyst tumor. This most likely is a lipoma, this is a vascular lesion, whereas this is probably a cystic lesion. And similarly, this is probably a cyst tumor, and this is an ectopic pancreas, and this is probably an isolated cyst, and so on and so forth. When we do endoscopy, we've all learned about the rolling pillow signs and the tenting signs. Just a pointer regarding that. This is the rolling sign. We can use a closed biopsy forceps to push the lesion by placing it just proximal to the lesion. And if the lesion rolls over, that means it's not attached to the deeper muscle layer. And similarly, if the lesion is compressible, then probably it's a lipoma or a vascular lesion. And the tenting sign indicates whether the mucosa is involved or not, and that will give us an idea whether the lesion is arising or attached to the muscle, the mucosa or not. Sizing is important, as you already said, because if the lesion is larger than 1 centimeter, there will be further assessment. And we can do that using a tight wire with markers, or we can use the forceps, or we can even use the endoscope to size the lesion. So based on the endoscopic appearance, there is a huge list that we can, which we can make primary differential diagnosis. And on an endoscopic algorithm, if you have a subepithelial lesion, identify the location and on the color. If the Cushing sign is positive or if it is yellowish bluish, then it's probably a cyst, lipoma, or a vascular lesion. And if there is surface erosion or ulceration, or there is a rating sign that is negative, then we should biopsy these. And if the size is more than 1 centimeter, then probably we should proceed to endoscopic ultrasound. So going back to the algorithm again, now we have our lesions which is more than 1 centimeter, and then we can probably perform an endoscopic ultrasound, probably assess for tissue acquisition, and then take on it further. So endoscopic ultrasound is probably the most important tool for identification and differential diagnosis because it gives us information whether the lesion is intra or extramural, the layer of origin, possibility of malignancy and perilesional gallbladder. It also gives us the opportunity to sample this lesion for biopsy. So this is very clearly seen. This is looks like a subepithelial lesion on endoscopy, but where you can see there is a splenic impression over here. And the most important part is the assessment of the layer of origin. We saw this lesion on endoscopy, and on endoscopic ultrasound, we can see that there is a small lesion over here, and the muscularis propria layer is very free. As compared to that, this is a subepithelial lesion again, and here you can see that the muscularis is arising from the muscularis propria. Here we can see that the muscularis propria is played, and the lesion is arising from the muscularis propria. And that gives us a pointer towards the diagnosis as well as to plan the treatment as well. How does this look? Most of them are asymptomatic and no intervention required. They will appear most often as anechoic and EUS when they are easy to diagnose. But duplication cysts or pathogenic cysts are often filled with solid epithelium because of the exfoliated epithelium, and they have a false positive differential diagnosis for a solid lesion. And sometimes we may accidentally sample them for FNA. The clue is that they are avascular in EUS, and the reason is because if we do a FNAC or FNAB, it should be avoided as far as possible because there is a high risk of infection. And if a needle is stuck in, then probably antibiotics are mandatory. The malignant potential is low and treatment only if symptoms. Aberrant pancreas again, a classical aberrant pancreas in the antrum with a small punctum, and on EUS we would see the ductal elements. And again, unless these are symptomatic, the best one can perform an FNAC if FNAB for information of the diagnosis. Coming to the most important lesions, the GIST tumors, they are usually well circumscribed, hypoechoic, relatively homogeneous mass lesions in the second or the fourth layer, often in the fourth layer. And the features suggestive of malignancy, 2 out of 4 features are important. Larger lesions more than 4 centimeters, heterogeneous microtexture, hyperechoic foci, and necrotic zones, irregular bladder, and adjacent lymphadenopathy. And contrast in the EUS would usually have. The other important lesion is neuroendocrine tumors, either in the stomach or in the duodenum. It would usually appear as polypoidal lesions, and EUS indicates that they are arising from the deep mucosa or submucosa. And we have to look at invasion as well as possible in lymphadenopathy. Usually they would occur in the stomach and the upper GI. So the classification of upper GI neuroendocrine tumors, and I know that Dr. Puri is going to address this in his talk. But plastic neuroendocrine lesions are classified into type 1, 2, and 3. And type 3, we need to know that the highest malignant potential, whereas duodenal are either non-functional or gastroneumomas. So based on EUS, this is how we can categorize the lesions, and then we can decide which lesions to sample or not. And how do we sample lesions for tissue diagnosis? FNAC. So EUS, FNAC or FNAB, and this is a single incision needle-like biopsy or mucosal incision, and we can perform de-roofing or tunneling biopsies or endoscopic dissections for smaller lesions as well. And using the currently newer needles that are available with the core biopsies, the sample size is much better. And outcomes have indicated that lesions more than 20 millimeters in diameter provide a 80 to 90% biopsy sample. Similarly, other biopsy techniques as well, lesions more than 20 millimeters provide us with a good sample of around 80 to 90% success rate. So based on the endoscopy and EUS and sampling, the AGA has come out with this clinical practice update, and one can go through this for all the details. Now coming to the resection, I'm just going to touch upon this resection part. Which lesions do we dissect at the end of all this discussion? So lesions without a clear characterization despite attempts at tissue diagnosis may be amenable for resection. Lesions which have shown a malignant potential, those which demonstrate an increase in size and fallout, lesions less than 5 centimeters or more, up to 5 centimeters as per the indicated extended indications, can be available for endoscopic resection, and patient preference and apprehension sometimes does demand lookout. Leiomyoma, GIST, neuroendocrine lesions, and neurogenic tumors are commonly the lesions which come out for resection. And lesions in the mucosa and submucosa would be treated by endoscopic mucosal resection or endoscopic submucosal dissection, but a submucosal lift is mandatory. And deeper lesions can be treated with a full thickness resection or tunneling endoscopic resection, or even a hybrid approach you combine with laparoscopy has been described. Now, I'm not going to run through these videos because of lack of time, but ESD is applicable for lesions mucosal or submucosal, especially neuroendocrine tumors, and smaller lesions under 1 centimeter can be treated by EMR, where the larger ones require ESD. So for neuroendocrine tumors, confirm the diagnosis, and then based on the classification, we can treat them, and if they are highly malignant, treat them with surgery, otherwise endoscopic dissection. Similarly, for duodenal lesions, And coming to the subepithelial lesions like cyst tumors, one can decide based on the appearance. Up to 5 centimeters is the maximum, but usually 3 centimeters. When we do a full thickness resection, there are some challenges of closure and recurrence and seedling. And types of resection are resection followed by closure, as compared to prophylactic closure followed by resection. And these are the entire list of resections. These are the endoscopic and the others are combined hybrid resections. Several techniques have been described for closure, and what is most important is the tunneling resection, which gives us an added area of safety. Laparoscopy assisted techniques have also been described. And comparing endoscopic resection versus surgery, endoscopy is less invasive as compared to surgery, although it is a newer technique. Therefore, to summarize, endoscopy and endoscopic ultrasound are primary modalities to evaluate asymptomatic lesions in the upper GI tract. Characterization using size and location and endoscopic EUS helps us. Lesions less than 1 centimeter usually require no evaluation and only follow-up, whereas larger lesions may require evaluation. Tissue diagnosis can be performed using EUS FNB and on ESD-based various techniques. Tissue yield is very poor for lesions less than 20 millimeters and should be reserved for lesions, larger lesions only. And EUS FNB and other techniques have comparable results. Lesions with malignant potential require resection. EMR and ESD for mucosal lesions and full thickness resection and tunneling resection for deeper lesions, and surgery for lesions with high malignant potential. With this, I would like to thank the organizers once more and thank you for your patient hearing.
Thank you, Dr. Amol. It has been a very nice, exhaustive, lucid lecture. We will be inviting a lot of questions. I think we all can talk to him in between the sessions. May I ask Mr. Wilson to call upon the next speaker?
Moving on to our next talk, I'll invite Dr. Rajesh Bhojwani. He is Director and Head Surgical Services at Santokha Institute of Digestive Surgical Sciences. So he will talk on gastroesophageal junction cancer, its current perspective.
Very good morning, and thank you organizers for this privileged invitation. Carcinoma GE junction still remains a very controversial malignancy to handle amongst all the modalities that are supposed to intervene there. Looking at the classification itself, it started with controversies, and at the moment the current understanding is that anything which is up to 5 centimeters on the oral side or on the aboral side of GE junction, it is classified as a GE junction tumor. Trying to understand the epidemiology of GE junction cancers, if you look at the burden in the East, esophageal cancer has declined, except in Japan and Israel. But the esophageal adenocarcinoma remains stagnant, and it has slightly increased in Japan, Singapore, and Israel. But if you look at the West, between 1970 and 1990s, there was a super increase in the number of adenocarcinomas, almost about 2.5 times. But thereafter, the incidence has stabilized, and there is a significant racial disparity, which might suggest some kind of susceptibility in these individuals. If you look at the incidence in India, just about 9% of the C esophagus is constituted by GE junction adenocarcinomas. And if you look at the GE junction tumors, almost about 80 to 90% of these would be adenocarcinomas, followed by squamous cell carcinomas, and very rarely carcinoma unspecified. Now, trying to understand, because this is important, even today we tend to direct the therapy of GE junction cancers based on their topographical location, based on various classifications like the Siebert classification, initial classification, AJCC classification. But there was an understanding that the type 1, which is on the oral side of the GE junction, is distal esophageal cancer. So type 2 is the true cancer, whereas type 3 is the subcardial cancer. But this was challenged in 1990s by Siebert himself, who came up with this article, which had almost about 1,000 patients. And therefore, at this point of time, we understand the GE junction cancers and we define them as type 1, 2, and 3 based on the epicenter. But the epicenter itself is a controversial issue as to how to identify the epicenter of a malignant lesion that we get to see. We are supposed to do the endoscopy, do the J maneuver, retroflex the scope, and look at the cardiac part of the GE junction tumor. Despite that, just about 70% of the radiology and endoscopy will be able to predict or analyze the epicenter of these tumors in just about 70%. There will still be a confusion, and when you take these specimens out after surgery, you will realize that the epicenter was different. Now, both the systems which are popular, CWERD, which is there in the West, and the Nishi classification, which is there in the Japanese, they use the epicenter for classification, but there's no comment on the proximal or the distal extent, which defines margins and for the treatment, an extent of required lymphadenectomy. And therefore, it is very difficult to predict or understand the epicenter very precisely. So looking at this, the American Society of Cancer, it has classified CWERD 1 and 2 in esophageal cancers and 3 in gastric cancers. And today, if you look at it, there is possibility that it is arising from above the G junction, going down, rising towards the stomach side, going up, and various morphologies that we get to see. And despite that, there have been a lot of studies now at the molecular and genetic level also, and there has been perhaps an opinion which is strongly in favor of GE junction cancers, the adenocarcinomas being gastric cancers, which are migrating proximally rather than esophageal cancers. And this is perhaps because of the change in lifestyle, more of obesity, more of GERD. If you look at the workup of these GE junction cancers, I'll simply highlight only the important features. Upper GI biopsy classifies it as adenocarcinoma or sometimes even squamous cell carcinoma, but mind you, even if it's squamous cell carcinoma at the GE junction, it will be classified and treated as a GE junction carcinoma, depending on the CWERD classification or the NICI classification that we are doing. But if you have a GE junction carcinoma, the next investigation imaging modality based on the availability of various modalities within the institution, we would prefer directly after knowing that the patient is not a very early GE junction cancer or not a metastatic cancer, we'll go ahead with an FDG PET if there's no metastatic disease. And if you're doing the CT, it should include a CT chest, abdomen, and pelvis with contrast. But when you are handling a esophageal cancer, which is in the middle third or the lower third cancer, as opposed to GE junction cancer, you need a CT of the neck, the chest, and the upper abdomen. So mind you, pelvis has to be included because there is a chance for ovarian deposits and pelvic deposits. When you have a metastatic disease, you need to biopsy it and particularly confirm the microsatellite instability and PDL1 and HER2 testings, because there is a role for immunotherapy in these metastatic settings, and there is now some evidence, very conclusive evidence, based on at least 2 trials in GE junction carcinoma, that next generation sequencing may be considered, and I'm going to touch upon it later again. So after doing all these, we have to know the assign CWERD category, do the nutritional assessment, smoking cessation, etc. Why is PET-CT required? Because it tends to upstage the stage of the tumor in about 15% patients, and it can alter the intended treatment plan in almost about 20% of these patients. Very importantly, in these patients who are adenocarcinomas, and particularly for the type 2 and the type 3 GE junction cancers, even before the patient is subjected to neoadjuvant treatments, either in the form of chemotherapy or chemoradiation, or sometimes even upfront surgery, it is important to do a staging laparoscopy. Why staging laparoscopy is important? Because it can actually alter the treatment in about 10 to 15 of such patients, 15% of such patients, because the PET scan does not pick up metastases which are less than 5 millimeters on the peritoneum. And when we do a staging laparoscopy, taking the ascitic fluid cytology is a component, it is an integral component, and it is important to understand that even if there is ascites, but there are no deposits, and the ascites show positive cytology, the patient still has a chance for a curative treatment. as opposed to a patient who has deposits on the liver or the peritoneum, wherein we lose the chances of curative treatment and identify them as metastatic and abandon the operation there and then. As far as the treatment is concerned, controversies do exist. And why controversies exist? Because whatever evidence that we have today, it has been kind of extracted and extrapolated from the studies which were done for the group of esophageal cancers, a holistic group of esophageal cancers. And some of these had just about 5% or 10% of GE junction cancers. And we have tried to extract evidence based on that. It is only in the last 10 years that dedicated GE junction cancer studies in terms of various chemoradiation modalities and surgeries have started, and we are getting evidence in favor of or against one or the other modality. Trying to understand the management, what is the goal of treatment? It is important to understand that to begin with, adenocarcinoma is a disease which has the tendency to metastasize systemically. So it is a systemic disease. It tends to metastasize early as compared to a squamous cell carcinoma, which is by and large a loco-regional disease. And these are two different diseases, and therefore, in all the modern guidelines, you will find that squamous cell carcinomas have a treatment paradigm which is absolutely distinct as compared to the adenocarcinomas, and particularly the GE junction carcinomas. The 5-year survival rate with surgery alone rests at about 25 to 30%. And there has been a significant promise which has been shown by neoadjuvant treatments, either in the form of chemo or chemoradiation in the last 10 years. And almost all the resectable patients now undergo neoadjuvant therapy in one form or the other, depending on various other parameters or attributes that we are going to discuss further on. The aim is to give chemotherapy, abolish the occult micrometastatic disease. The aim is to give radiation or chemotherapy to understand and abolish the loco-regional disease. The further aim is to do the surgery with minimum morbidity and good survival and good outcome, and thereby ensure a good disease-free and overall survival. If you look at the neoadjuvant protocols, I understand it is not our domain, neither on the medical side nor on the surgical side, but there have been a lot of publications and very good high-quality trials. You can see on both the sides, I've tried to list some trials which have gathered some evidence which shows that neoadjuvant chemoradiation and chemotherapy are good. At the moment, there is a kind of an understanding that if this is a type 1 tumor, which is more towards the esophagus, it is perhaps the neoadjuvant chemoradiation which is more helpful because it tends to behave like a squamous cell carcinoma. If it is type 2, it is controversial. Perioperative chemotherapy, meaning chemotherapy before the surgery and chemotherapy after the surgery, is comparable to chemoradiation before surgery. And for type 3, it is chemotherapy followed by a total gastric resection. When we talk about the attributes of surgery, what are the important aspects of the surgical exercise? It is the extent of nodal dissection, margins on either side, access to the organ, whether it is open through the abdomen, through the chest, or through laparoscopic or robotic, and where are we doing the anastomosis, in the neck or in the chest, and how much stomach is to be resected. The surgical principles remain that the tumor histology and location, they define the approach of surgery and the extent of lymphadenectomy. If there is more than 3 centimeters of esophageal involvement, it deserves mediastinal nodal dissection. A gross proximal margin of 4 to 5 centimeters and a distal margin of 3 centimeters is required, and of course with the help of judicial frozen section biopsies to make sure that the margins are negative. Please try to understand that if there is a 3 centimeter margin on a type 3 GE junction cancer, on the lesser curve, it might almost come up to the incisura, and almost all of these type 3 junction cancers may require actually a total gastrectomy with the lower part of the esophagus, with the lymphadenectomy, which is dictated by imaging, the type of histology, and the location. Type 2 remains controversial. The extent of surgery, again, because surgery is also based on the type of CWT classification that the tumor has, it is based on histology also. Type 1 tumors, one can go up and anastomose the esophagus in the cervical esophagus with the pulled up stomach. Type 3, you require a total gastrectomy, and therefore to bridge the gap, you might require a colonic conduit. For type 2, as I've already mentioned, the controversy exists. Now, just giving you a brief glimpse of what are the surgical issues in the mind of the surgeon. These are the lymph nodes. We tend to identify the group of lymph nodes. Of course, there is a nomenclature of 200 as to each lymph node, which category it belongs to. But we tend to identify certain distinct regions of lymphadenopathy, whether seen on PET CT or CT, and address our nodal dissection based on that. This G-junction carcinomas don't metastasize to the cervical lymph nodes, and therefore cervical nodal dissection is not required. This is the kind of nodal dissection. You can see a standard 2-field or a 3-field. Available approaches, as I've already mentioned, it can be through the chest, but mind you that if you try and access these nodes through the hiatus, as was the conventional very popular operation, you won't be address any lymph nodes which are beyond the pericardiac region or the lower esophageal region. You won't be able to address the lymph nodes around the carina or the upper part of the trachea, and therefore transhiatal esophagectomy has its own limitations. So these are the type of approaches. As you can see, these are our own patients. One can actually use the entire abdominal incision, no abdominal incision, no chest incision, just a small abdominal incision, no chest incision, and do the anastomosis. This has been made possible by the modern techniques of minimal access and robotic techniques. Our own technique has been in the prone position for the last almost about 12-13 years now, and these are the pictures wherein we do the abdominal part by the open and do the chest part by the in the prone technique. Just to give you a glimpse, this is the latest technology that we use, ICG. The interventional radiologist injects the intestine in green before the surgery, and we can see the thoracic duct all along during the entire operation so that we can prevent injury to the thoracic duct. You can see the entire abdominal operation has been done. The gastric conduit has been fashioned. It is now being pulled up in the chest. The patient is in the prone position. The tumor is seen, divided, stapled, severed, and then the two ends are brought together and anastomosed like this, and then this anastomosis is hand sewn. So the decision making is based on various factors. As I've already mentioned, the patient, the disease, the available expertise. It has got to be a multidisciplinary discussion, and based on the location and the histology. The future dimensions, importantly, 2 studies have shown that the circulating tumor DNA might be a good biomarker for G-junction cancer, and it might indicate recurrence or a poor prognosis in the patients where you find. And our technique of minimal invasive esophagectomy, for those who are interested, has been published in the textbook of surgical gastroenterology published by Dr. P.K. Mishra. Thank you all very much. That's our team.
Thank you, sir.
Thank you, sir, for your wonderful talk on this topic. Now we move on to the next talk. We will invite Dr. B.S. Ramakrishnan, sir, who is the Director and Senior Consultant at SRM Institute for Medical Sciences, Chennai. He is going to speak on the topic treatment of GERD beyond PPI.
Good morning, everybody. And so I think without further ado, we'll proceed with this. So GERD is, or gastroesophageal reflux, is something that we all see commonly in practice. It's probably one of the most common symptoms that our patients come with. So where does traditional GERD treatment fit? We start them on proton pump inhibitors, or the GP has started them, or the pharmacist has started them on PPI. And when they don't respond to it anymore, they come to a gastroenterologist. What we realize is that maybe 20 to 40% of GERD patients who are on PPI persist to have symptoms even after an adequate trial, 8-week trial of double dose PPI plus lifestyle measures. And if you take suspected GERD, which means that it's a much wider bag, more than a half do not derive benefit from acid suppression. So when we look at the mechanisms of GERD symptomatology, acid reflux is clearly important, but also in many patients, particularly those on PPIs, bile reflux and alkaline reflux might be important. Impaired mucosal integrity is important, and there is this condition called reflux hypersensitivity. And finally, there's functional heartburn, which I have not actually put on here. Listed here are the current non-PPI treatments for GERD. There's lifestyle modification, medical, the whole list, endoluminal therapies, and surgical therapy. So we'll just quickly look at some of these. So beyond PPI, something that's in the news are the potassium competitive acid blockers, or PCABs, of which vonoprazan is the most widely studied. So basically the way it is different from a PPI is that these PPIs tend to bind with the proton pumps which are already on the surface of the cell. Whereas newly surfacing proton pumps will not be inhibited. On the other hand, the potassium competitive acid blockers will block these as well, and so theoretically there is the feeling that they are superior to the regular PPS. So the question of whether vonoprazan is superior to PPI in GERD has been addressed in this meta-analysis of 19 studies with about 7,000 participants, which showed that healing of erosive esophagitis was marginally higher with vonoprazan compared to PPI. It's not that great a difference. So if you look at the relative risk of benefit here is that it's about 1.09, which tells you that it's probably better, but not that much. So coming to other agents which can be used in these patients, there's been a lot of focus on alginate, which is a polysaccharide derived from seaweed. The gastric acid pocket, which is there in the fundus of the stomach after a meal, is considered to be important for postprandial reflux, which is a major issue. So alginate binds water in this acid pocket and forms a viscous gel. And essentially what the claim is that this keeps the acid pocket below the diaphragm in 70% of patients. Now the thing with the alginate preparations, they all have bicarbonate. So bicarbonate has two things. It neutralizes acid, gives them immediate relief. And the second thing is because it neutralizes acid, it forms carbon dioxide. The carbon dioxide bubbles stay within this viscous gel and form a raft which floats on top of the gastric contents. And that's what they call as the raft here. A kind of systematic review of alginate in GERD, there's not too much evidence. Alginate is superior to placebo for the treatment of GERD. It can be used safely in pregnancy, which is an advantage. There was one large randomized controlled trial with more than 1,000 or maybe 1,100 participants, which was cited in this systematic review in 2016, but unfortunately the next year it was withdrawn because they retracted due to significant protocol deviations. So the next consideration is, so we talked about the acid pocket. The next is impaired mucosal integrity, whether that it is important in PPI refractory GERD. So impaired mucosal integrity, which may be due to the acid, it could be due to the bile acids and the proteases, each of which cause mucosal damage. So there is a focus now on reinforcing defensive mechanisms. So this has led people to re-explore the role of molecules like sucralfate, which can reinforce esophageal mucosal defenses. So one is that the sucralfate adheres to injured or ulcerated areas as protective adherence, because negatively charged sucralfate binds to positive charges on exposed proteins. And then it induces fibroblast growth factor, increases prostaglandin in the mucosa, and provides cytoprotection. The third reason is that it binds bile salts, which is useful in bile acid. Unfortunately, we don't have many bile acid binding agents available for clinical use. So this is just an experimental study to show that that you induce ulceration in the esophagus, and show it. This is the HNE stain section, and sucralfate here shown on this fluorescence. And when you overlay it, you see that the ulcerated area is covered with that. So the sucralfate is a role molecule. So all the evidence that we have is very, very old. So 1987, the study, Giro Titkat did this, basically showed that giving sucralfate 4 grams a day compared with 400 milligrams of sucralfate a day, 4 times a day, actually induced much better endoscopic healing than the symptomatic. So in a recent, again, systematic review, sucralfate is better than placebo in relieving symptoms. It's not a meta-analysis. The doses used range from 2 to 4 grams a day. Combination with cimetidine was better than cimetidine alone. The last meta-analysis, as I said, was done many years ago and concluded sucralfate was better than placebo. So recently, there's a multi-center study done in Chennai, Mumbai, and Kolkata, where sucralfate, the addition of sucralfate to PPI was compared to PPI alone, and symptomatic assessment was made using what is called the PAGI-SIM scale. Symptom relief was faster in patients taking PPI and sucralfate compared to those taking PPI alone. So there is an interesting molecule called pre-polymerized sucralfate, which claims to deliver 800% more sucralfate to the surface. And there was positive clinical data from 3 randomized controlled trials, which were reported in the abstract in 2014, but we haven't really heard much since. The third entity, so we talked about mucosal protection. The third entity that we need to think about is reflux hypersensitivity. The Rome 4 criteria defines this as typical reflux symptoms, normal endoscopy, absence of gastroesophageal reflux, of pathologic gastroesophageal reflux, and a positive symptom correlation index. So whenever there's a reflux of contents, it correlates with symptoms. And this, many people feel that this may be due to some issues with the capsaicin receptors which are there in the esophagus. And in this particular condition, neuromodulators like SSRIs, SNRIs, and tricyclics may be useful. GABA analogs are useful in PPI refractory GERD. One of the many conditions that a lot of ENT specialists refer their patients to us is because of chronic cough, and that is due to GER. A lot of this is due to transient relaxations of the lower esophageal sphincter, which again is a concept that we were familiar with many years ago, which is the cause of postprandial reflux symptoms. So GABA receptors play an important role in TLESR, and baclofen, which inhibits TLESR but does not affect the acid pocket, is very effective in GERD in some patients with GERD who are refractory to PPIs. Both baclofen and gabapentin are effective in GERD-induced cough, and I tend to use that a lot in my patients with GERD. So coming to other treatments, so endoscopic treatment, the esophagus or the transoral incisionless fundoplication has become fairly popular, and a significant number of patients has been done on a large number of patients worldwide. So there's a meta-analysis of 10 studies with 564 patients, and essentially there is significant improvement. About 2/3 of patients remain satisfied. 3/4 of patients are off the daily PPI, but they still need to take PPI on and off. Anti-reflux mucosal intervention procedures include 3, which are the mucosectomy, the mucosal ablation, and the band ligation. The pooled clinical success rate for the 3 procedures together is about 75%. And generally, there is a feeling that the band ligation is better than the mucosectomy or the mucosal ablation. What about surgery? So surgery is something that we do consider with patients with refractory GER, especially for those who wish to discontinue chronic medical therapy due to side effects or due to fear or to comorbid illness. A lot of my patients, the nephrologists will, if they have a borderline creatinine, we get an elderly population with GER, the nephrologists are very afraid to give them PPIs because they fear it might push them into a dialyzable state. And so that's very often an indication. Try something else. If there's a large hiatal hernia, if there's prominent regurgitation, if there's abnormal pH despite a maximal PPI dose, and if the symptoms correlate with non-acid reflux while on maximal PPI. So these are candidates for surgical therapy. So finally, just end up with an algorithm for PPI-resistant GERD. Just make sure that they don't have something else. So you do an upper GI endoscopy with biopsy. If there's a biopsy abnormality, you treat the abnormality. If there is no abnormality on this, then you go ahead and do an impedance pH or a pH study of treatment. If there's abnormal reflux, then you have to address issues of compliance, lifestyle modification. You can add sucralfate, alginate, baclofen. All this depends on clinical judgment. Endoscopic treatment is something to be considered in a small number of people, and anti-reflux surgery still remains. So where there is no problem with the impedance pH study or the pH study of treatment, then you consider manometry because they might have a motility abnormality. If so, you treat that, of course, with very difficult results in most patients, but still, that's what you do. If the manometry tends to be normal, then you're dealing with reflux hypersensitivity or functional heartburn. Adding H2RA at night, sucralfate, alginate, and we talked about neuromodulators, psychological intervention including CBT, and if all this fails, you send them off to the homeopaths. Try to unload your patient onto somebody else. And in some of these patients, you will consider endoscopy treatment and anti-reflux surgery. With that, I'll end. Thank you.
Thank you, sir. I hope it had been a great morning start with the stalwarts, the top speakers of the country, stimulating you all. And I think the CME has gone up in a very beautiful manner with a big start and on time. Thank you all.
Thank you. Thank you, Chairperson, and thank you, speakers. For the next session on luminal, can I please invite Dr. Rupesh Pokrama, Dr. Gaurav Gupta, Dr. Prachi Ashti, Dr. Mukesh Jain, Dr. Neeraj Tagaj to please chair this session. Also, can I request Dr. Manu Tandon and Dr. Shrikant Mukevar to please be the moderators for this session. The adjudicators for this session will be Dr. Manish Tandon and Dr. Heminder Bhardwaj. Sir, please.
The IC team, Jaipur, for the hard work they have done, especially for Rai Saab and Sandeep for the excellent evening yesterday also. We start with today's CME. The first topic is GI tuberculosis, diagnosis and management in special situations. May I invite Dr. Rakesh Kulchar. Presently, he is a director of gastroenterology, Fortis Hospital, Mohali, and ex-head of the department, PGI Chandigarh. Rakesh does not need any introduction. Over to you, Rakesh. Please go ahead.
Thank you, Dr. Mukhtiwal and the chairpersons. I'll be talking on a few aspects like drug-resistant tuberculosis, latent tuberculosis, and treatment of tuberculosis in patients with chronic liver disease. Drug-resistant tuberculosis is emerging as a major health problem across the world with over 5 lakh cases being reported every year. Significantly, 1/4 of them are in India. India has a national TB elimination program and there is a special emphasis on detection and treatment of drug-resistant tuberculosis with culture facilities available at the smallest level of dot center and with a very, it is called the programmed approach to treatment of multi-drug-resistant tuberculosis. Drug-resistant tuberculosis could be for single drug, multi-drug or extensive drug. Multi-drug is when there is resistance to both INH and rifampicin with or without resistance to other first-line drugs. XDR is resistance to INH, rifampicin among the first-line drugs, one injectable drug and fluoroquinolones. How common is it in India? Earlier reports had suggested that the incidence of drug resistance in GI tuberculosis may be as high as 5 to 25%, but virtually none for XDR. However, all these studies, particularly from Maharashtra, were using older culture techniques. Recent reports from across the country using gene expert have shown that drug resistance tuberculosis among GI tuberculosis in India is rather uncommon or rare. So how do you use? You use molecular diagnostic tests, which all are available at even the peripheral centers of DOT in India, Gene Expert, TrueNat, line probe assays, and there's one test. This has to be noted that XDR can be detected by a single test against resistance against isoniacs, fluoroquinolones, injectable drugs, and economide in a single test with the report coming in 30 minutes. So when you suspect drug resistance tuberculosis in patients with past history of treatment, contact with MDR, TB patient, HIV, and poor response to ATP. Second line drugs are used for drug resistance tuberculosis. There are three groups, A, B, and C, and accordingly, there are three kinds of courses. One is shorter injectable course for 9 to 11 months, short oral course for 9 to 11 months, and long oral course for 18 to 20 months. So the approach is that if there is a single drug resistance, you use short course oral treatment. If there are multi-drug resistance, then you use longer oral course. If there is failure to either or there is XDR, then you go on to the long oral course. The response after the introduction of bedaquiline is much better compared to 50%, or the response rate is as high as 75%. Coming next to latent tuberculosis and immunosuppression. With the increasing use of biologics in the last 1 decade in India, there is a rise in reactivation of tuberculosis, and it is a matter of concern for all of us. What is latent tuberculosis? When there is exposure to Mycobacterium tuberculosis, 20 to 25% of individuals will get infected. Out of them, 5 to 10% will develop active disease in the next 5 years. A very large number, majority, more than 90%, will have their immune system controlling the replication. The bacteria will lie dormant, and this is the latent phase of tuberculosis. It can get reactivated in conditions like uncontrolled diabetes, HIV, severe malnutrition, or immunosuppressive drugs. So it is defined as persistent immune responsiveness to tubercular antigens in the absence of active disease. Bacterial replication is absent or below some threshold. We do not know that, and with potential to reactivation in future. So how do you diagnose latent tuberculosis? There are three pillars of that. One is clinical history. You take history of recent exposure to a positive patient, past history of tuberculosis in that individual, imaging using chest X-ray or a CT scan of chest, and immune response by tuberculin skin test or interferon gamma release assays. Interferon gamma release assay, IGRA, detects interferon gamma producing T cell response to the antigen. There are two kinds available, quantiferon and T-spot. Both are equally good. It is to be noted that a small percentage may have an indeterminate test with IGRA. That has to be repeated after 8 weeks, or you add the tuberculin skin test to the IGRA. The motto of the tuberculin skin test, you take positive if it is more than 5 mm. In patients with prior BCG in the last 10 years, a reading of more than 10 mm is required to be counted as positive. So which is better? There is a very high concordance between the two tests, and WHO recommends that either of the two could be done. But some guidelines suggest that both should be used to maximize the diagnostic yield, particularly in endemic areas. Chest X-ray has been routinely done, but recent reports have suggested that a CT scan should be added, and two reports from AIIMS Delhi have shown that adding tuberculosis picks up the latent tuberculosis much more than when CT test is not used. So screening for tuberculosis, latent tuberculosis should include history, TST, IGRA, or both, preferably both, chest X-ray and a CT test, particularly in endemic countries. If positive, any of them, if positive, then tubercular prophylaxis is to be given to prevent reactivation before we go on to immunosuppression. In this meta-analysis, it was seen that the risk of tuberculosis was 0.08% on a more than 1 lakh patients given ADA or infliximab. Significant thing is that more than 50% of patients had either extrapulmonary tuberculosis or disseminated tuberculosis. It was also noted that the risk of tuberculosis increases as per the endemicity of tuberculosis. In highly endemic areas like India and China, it is to the tune of 2 to 3%. But the real life experience, I could come across a number of studies from India. The percentage of patients getting tuberculosis after infliximab or ADA was 4 to 13%, a very high percent. So the AIMS has a group led by Vineet Ahuja has published this very interesting paper in which they have added CT scan to the screening test after 2019, and they found that the pickup rate of latent tuberculosis increased from 19.6% before 2019 to 44% after 2019, when a CT test was made mandatory for screening. And patients were treated if any of the tests was positive, and it reduced the overall TB risk from 17% to 1.7%, that is 10 times. So when you screen for latent tuberculosis, it should be done at the time of diagnosis of IBD and before the initiation of immunosuppression with drugs which are more likely to cause latent tuberculosis. If screening has been done more than a year ago, then a repeat screening should be done. The treatment is isoniazid for 6 to 9 months, rifampicin for 4 months, rifampicin and isoniazid for 3 months, and isoniazid and rifampicin once a week for 3 months. So any of these can be used depending on the availability and the compliance issue. So what to do if a patient requires immunosuppressive therapy and turns out to have latent tuberculosis? This is the major question we all have. So if you are going to use anti-TNF therapy, corticosteroids, ustekinumab, JAK inhibitors or CNIs, then ideally latent tuberculosis treatment should be given before starting these immunosuppressants. If it is not possible to wait for 3 months or 4 months, then at least 3 to 4 weeks of treatment should be given with antitubercular treatment should be given before starting immunosuppressants. However, there will be some individuals who will be in imminent need of immunosuppression with severe fulminant disease. Then it is recommended that they could be started together, that is tuberculosis prophylaxis as well as any of these immunosuppressants, giving rifampicin and isoniazid for tubercular prophylaxis. In patients who are given 5-ASAs, thiopurines, methotrexate and bevacizumab, there is very little risk of activation of latent tuberculosis, and patients to be given these drugs need not be screened for latent tuberculosis. Significantly, there are many drug interactions with some of the immunosuppressants, and that has to be taken into account, particularly when rifampicin-based treatment is given. Should latent tuberculosis screening be repeated? Yes. In patients in endemic areas who are on ongoing biological therapies, periodic screening should be done every 6 to 12 months. One may do only a chest X-ray, or one may add TST or IGRA to the screening test. Lastly, coming to how to treat tuberculosis in a patient of cirrhosis. Why is it important? It has been shown by multiple studies that patients with chronic liver disease, underlying chronic liver disease, chronic HPV infection, chronic liver disease have higher risk of drug-induced liver disease. I'll just take you to a couple of observational studies because there are no randomized trials available with the published form. This study from Gagaram Hospital on 67 cirrhotic patients, child A7, child B44 and child C were given antitubercular treatment and the outcome was noted. Child A treatment were given the standard therapy for 2 and 7 months, 2 months intensive and 7 months follow-up. There was no toxicity no increase in liver toxicity as compared to the other patients. However, in childs B and C, hepatotoxicity was seen in 1/3, that is 35% of patients. It was as high as 50% in patients who received rifampicin and isoniazid combination. Significantly, there were no deaths related to Delhi, but otherwise, Delhi was a major problem in patients who received rifampicin and isoniazid. So, it is recommended that patients with childs A can be treated with isoniazid, rifampicin, with or without pyrazinamide for 6 to 9 months. Childs B, one hepatotoxic agent among Isonex or rifampicin can be given. Pyrazinamide should be avoided. Treatment duration should be 9 to 12 months. For child C, no hepatotoxic agent should be given. Only second line drugs have to be given, and the treatment is to be continued for 12 months. Lastly, liver transplant patients having developed tuberculosis, what do? It has been seen once again that giving isoniazid and rifampicin increases their risk of hepatotoxicity, and it is better to avoid them or have a very close surveillance on development of drug-induced liver injury. So, to summarize, ladies and gentlemen, latent tuberculosis screening is needed in India for patients receiving immunosuppressant treatment. All tests, TST, IGRA, chest X-ray, and CT scan should be included in the screening program for latent tuberculosis in an endemic country like India. And probably it is needed that all patients should be screened periodically once they are put on biologicals. Second issue was drug resistance in tuberculosis. In GI, tuberculosis is not a major health problem as yet, but we need to be very careful about it. Surveillance is needed on this account, and patients with cirrhosis and tuberculosis treatments need to be treated at the child's class. Thank you.
Wonderful talk, Rakesh. We've been instructed by the organizing team that it's a tight schedule. All questions will be personally directed to Dr. Rakesh. He'll be available with the audience. That's the instruction that's been given to me. We will move on to the second talk. This is on neuroendocrine tumors. To deliver it is Dr. Amrinder Puri, one of the best teachers we have in our country in the field of gastroenterology. He headed the GB unit for many years and is now the vice chairman of the GI specialties at Vedanta. And Amrinder is a wonderful teacher, and I'm sure he's going to enlighten us all on neuroendocrine tumors. You're on.
Thank you, Manu, for those kind words. I apologize, I have a kind of a sore throat, and I hope I'll try my best not to cough. So, what I was doing was neuroendocrine tumors, what every gastroenterologist should know. And I've tried to condense that into 4 important facts, which will come up periodically in my lecture. The topic was very vast, and as we know that gastro and pancreatic tumors, 2 broad categories. One is the GI nets, referred to as the carcinoids, and the other is the PNET, so the pancreatic neuroendocrine tumors, which I'm not touching at all. So my talk is only on GI nets. And philosophically, I think the neuroendocrine tumors have some similarity with volcanoes, because there are some volcanoes which are extinct, which are only of interest for tourists. And some gastric carcinoids or rectal carcinoids are in the same category. So you live with them, but you don't die because of them. Some are active volcanoes. Now that means that by the time the diagnosis is done, they've already metastasized, the damage is done. There's very little that you can do except control palliative measures. And the essence really is to get hold of dormant volcanoes and see if you can take them out before they erupt. So with that background, I'm going to start. The agenda is going to be a brief introduction. I'm going to spend some time on pathology and grading, the clinical presentation, a rush, and finally diagnosis and management. But let me start with the Indian data. 3 large series from India, and they give you 3 different perspectives. First is the study on your extreme left, This is from AIMS. So this gives you a perspective from the nuclear medicine. The second is from Mumbai, from Kamrapur. That gives you the GI perspective. And the last is also from Mumbai, the Tata Group, Tata Memorial Hospital. So that is the surgical perspective. So let me start because I'm doing the gastric carcinoids. Let's start with the color red. So from a gastroenterologist perspective, red is the ideal carcinoid. So we hardly see them. Where would you see them? In the nuclear medicine. You'd of course see them in the surgery. Let's take the color green. The green is the gastric carcinoid. So as you can see, the largest chunk from the GI perspective is, because that's the bread and butter. We're doing gastroscopies every day. That's why this is the largest, and this is one of the smallest ones, because you don't need to refer them for a rotor scan. And of course, the type 3 would come over here. But from a surgical perspective and from a nuclear medicine perspective, the color is blue, which is the pancreatic, and we're not discussing that. So nuclear medicine will get a lot of pancreatic necks. The surgeons will get a lot of pancreatic necks, but we will also get them, but see the proportion changes quickly. Surprisingly, neuroendocrine tumors is one group of tumors where the epidemiology is like rising. And although I've given the graph only for the gastric neuroendocrine, it's for unknown reasons. It's not only the gastric, the rectal, the small bowel, all carcinoids are right. For gastric, one can say we have better quality scopes. The resolution of the high definition scopes is so good, and that's one of the reasons. But that doesn't explain for the other sites. Let's go to pathology. When you get the report from the pathologist, he or she is going to mention two different facts. One is the differentiation, and the other is the grade. And the two are not synonymous. So let's start and say differentiation is the extent to which the tumor morphology resembles the original cells, which is the ECL. So do they resemble exactly like them? If so, then the pathologist says it's well differentiated. If it's not, doesn't look like those ECL cells, then he or she is going to say it's purely different, poorly different. So as far as differentiation is concerned, only two categories: well differentiated and poorly differentiated. Grades, there'll be three: low grade, intermediate grade, or high grade. Or in other words, they would write the letters G1, G2, and G3. And this is based on the proliferative activity. Is the tumor dividing? So if the tumor is actively dividing, then we base it either on the mitotic index or on the Ki67. And it's important to remember that a tumor which is a very low grade, G1, is hardly dividing, you don't see any mitotic figures, that's the one that may not be picked up on the PET CTs. So this is the WHO classification 3. So you can see that well differentiated G1, G2, and G3, the vast majority would be G1 and G2, and you rarely get a G3. And if so, then this actually starts behaving like a poorly differentiated. So why do they have, if you look at the mitotic count and you look at the Ki67, they're exactly the same. Minor differences. Here it's 2 and 3, here it's 2 and 3, so 2 and 20, and 3 and 20. So if you have a clinical situation where they're not matching with each other, so you have a mitotic count which is less than 2, but a Ki67 5, then you grade it upgraded. So then it will go into G2 category. So this is just a check for the pathologist, like we used to do the math sums. Do you want to add up from top below or from below upwards? The total should be the same. So similarly, if there is discordance, then it goes to the next grade or the higher grade. So what is the take-home message number 1 is, so if you have a patient, post-operative adjuvant therapy is not required in patients who have well differentiated. So these patients, if they go for a resection, whatever be the site, because their mitotic index, because their Ki67 is so low that you really don't need any post-operative clinical presentation. I think from a gastroenterological point of view, most of them are what I call as incidentalomas. whether they occur in the rectum, whether they occur in the stomach, they are all incident in the duodenum. Vast majority are incidentalomas. And the symptomatic, as far as this type 3 refers to the stomach, behaves the symptoms exactly like that of carcinoma stomach, and that would be about less than 5%. And the carcinoid syndrome, which occurs in about 8% of total GI nets, is exclusively almost with ileal, only with carcinoma. So incidentalomas, stomach, very common, duodenum, very common, small intestine and pancreas, not. They are the ones which are symptomatic. Patient has been having pain, not been diagnosed, and that's what. Appendicular, almost always. Let's go to stomach. So I'm going to go stomach, duodenum, and then the small bowel. So that's foregut, midgut, and then finally the rectum or the hindgut. This is, we talk about gastric nets, 3 categories: type 1, type 2, and type 3. So this classification is based on the serum gastrin levels. So type 1 and type 2 is a lot of gastrin flowing around. I'll show you a picture in the next slide. And this is what I say, the bread and butter. So 80% of them, very rarely, 2 years, 3 years, something like that, you see one solid LSM. And type 3 mimics, the symptoms mimic CA stomach, and this is more common than solid LSM. But the point to highlight is that metastasis probably less than 10%. Here could be as high as 50 to 100%. And Zollinger Ellison is basically the tumor potential from the duodenal carcinoid, not so much from the gastric carcinoids that are there. So, so for gastric type 1 and type 2, now if you have to make varas, you have to have a lot of oil. And that oil can be likened to the gastrin. You need a lot of gastrin. And where's the gastrin coming from? It's coming from in atrophic gastritis, from the gastrin-producing cells in the abdomen, and from the neuroendocrine tumor in the duodenum or the gastronoma triangle. That's where you're getting the gastrin. And not only that, if you have to make varas, you have to boil it for a long time. So it is thought that approximately 10 years of gastrin stimulation is required before they start becoming gastric carcinoids. Typical lesion, solitary lesion. So you can see this cannot be type 1, cannot be type 2, and this is the typical lesion that you get in here. Duodenal nets. Perhaps for some reason, last 1 year or so, we're getting more of duodenal nets than gastric nets. And there seems to be a gradient. So they're commonest in the apex D1 and D2, and then as you go distally, they become less common. Almost always in the range of 10 millimeters, 20 millimeters. They're less than in 90% of the cases. And 90% of these are non-functional. Only 10% would you have the Zollinger Ellison. This is the typical appearance. And if you get multiple of them, then you should think of Zollinger Ellison syndrome. I now go on to midgut. The classical presentation is the carcinoid syndrome. This picture was sent to me by one of my residents. It's a classical picture. This lady was thought to be malingering, and her physician thought she used to smear vermilion on her face, because this is what she was before. And now look at this. This is the full bone flush. So the full bone flush occurs, involves the face, the neck, and it lasts for about 5 minutes. And rarely you can have a carcinoid crisis also. So lesson number 2 is this carcinoid crisis can be precipitated by surgery, anesthesia, chemotherapy, and rarely by endoscopic biopsies. The anesthesia, you don't have to tell them; they know it. But you must warn your surgical colleagues that if you are having you have a patient which is common, make sure that he gets a subcutaneous dose of octreotide. And endoscopic biopsies, no risk with rectal carcinoma, no risk with gastric carcinoid. If you're doing endoscopy and you have a ileal biopsy and you're suspecting, that's the time you should be giving that. Rectal nets, for some obscure reason, very, very common in Far East Asia. For example, in Korea and Japan, they account for 90% of all nets. And they're harmless. Tumors are less than 10 millimeters. Complex site is about mid-rectum. And the typical appearance, it looks like this. That's the rectal carcinoids. Now, as far as rectal carcinoids, the malignant potential is related to the size. If it's less than 10 millimeter, which is what we see mostly, you hardly get mets. If it goes between 1 to 2, then Mets in 33%, and if it's more than 2 centimeters, then Mets in the majority. So for a diagnostic algorithm, in the foregut, we would go by endoscopic biopsy, the incidentaloma, and if you get that, then you can go on to serum gastroenterochromography, cross-sectional imaging, only if its size is more than 10 millimeters, and finally you might need to do an EUS to find out what layer and how deep it's going in, and the DOTA scan. This is the DOTA scan concept. This is an artist view of the of a neuroendocrine cells. So you have 5 kinds of receptors, and the sandostatin or the long-acting, that's the one picks up type 2 and type 5. So that was the basis of the Indian label Octoscan that has become obsolete now. This is the DOTA scan that we use, and you can see on your right is the Indian scan, on your left is the DOTA scan, and extensive meds picked up on the DOTA scan versus the Indian scan. The principal, the wonder molecule is the chelator, which is DOTA, because it can bind like a handcuff. The somatostatin, which will bind here, and the gallium-68, which will be picked up by the gamma camera. So number 3, what every gastroenterologist should know, that some of these, the natural history is very indolent, but others can be aggressive. A variable cause means that some of these, you can just leave them alone. So for patients who are asymptomatic, small volume disease, especially in the foregut, age is 75, comorbid diseases, please don't touch them. They're not going to die because of that. However, you have to follow them serially. When should surgery be decided? So the goalpost moves. For gastric, the goalpost is 2 centimeters. For rectal, it becomes 1 centimeter. And ideal, even a 5 millimeter. So you can see the goalpost is moving. So size is the major determinant. Systemic therapy is with the somatostatin analogs. This is Janus 2-phased. Initially, they were designed for hormone secretion to cut down. And then it was found that they actually regressed the tumor. So we don't know why, but obviously it is related to the binding of the cell. And these are the systemic therapy trials. I put about 5 of them over here. And this was the first one, the Promate, which was long-acting octreotide, 85 patients. And the progression-free survival was almost double, 14 versus 6 months. This one was the negative one, but the Radiant 4 and Everolimus, this showed a clear difference, 11 months and 4. And after this, this has become the standard of care. But mind you, all these studies are mid-gut, metastatic, advanced disease. They're not for asymptomatic foregut or rectal. All of them are mid-gut. PRRT, I'll just rush through it. The prerequisite is that it has to be a somatostatin receptors have to be there. That means that rules out G3. You can't do it. With adequate bone marrow reserves and a good renal function, and it has to be inoperable, well differentiated G1 and G2 with good performance scale. This is the basis. So on an average, you would give anywhere between 2 to 10, but 4 sessions are given at 8 weekly. The progression-free survival is 65% versus 11%. Adverse events mainly is renal and myelotoxic. I'm finished. So systemic therapy, this is my last slide practically, that is not to be considered when you have low volume disease, non-progressive, indolent, and on the other hand, if you have high volume, advanced, metastatic, symptomatic disease, that's where it comes in. Prognostication, what you can see is the Manhattan skyline. And this is a crowded slide. This is the overall survival based on the stage and the grade. So the tallest buildings in the Manhattan skyline is the ventricular, which tells you that this is benign. The appendix has the best prognosis, followed by the rectum and then the stomach, whether it's the size or whether it's the stage. So lastly, irrespective of grade or stage, metastatic disease is less than 5 years survival. Grade 3 nets, you hardly touch 5 years. Appendicular carcinoids have the best prognosis amongst GI nets, which are again incidentalomas, and they don't come in the realm of gastroenterologists. The rectal nets are second only to appendix, and the expected survival of G1 and G2 is about 100 months if you leave them alone. So that's 8 years. So this is my last slide where I'm saying there are some unanswered questions. And the most important is not the fact that there's a rising trend, but do we have a mathematical model where we can show that G1 goes to G2 or G2 goes to G3 in so many months or years, because we should know when to act. And lastly, people ask me, why can't we give the long acting even for foregut tumors? And the answer is there's no evidence, and the side effects would greatly outweigh them. Thank you very much for your patience.
I must compliment Dr. Puri for the extensive topic which you really concise and presented in a crisp manner. Since the time is up and no questions, we go on to the next speaker. Let me invite Dr. Vivit Ahuja, who doesn't need any introduction. He is a masterly figure in the field of inflammatory bowel disease, gut microbiome, GI immunology, and abdominal tuberculosis. Vivit, please go ahead.
Thank you, sir.
Pregnancy and IBD.
It's a pleasure to be invited to what appears to be building up to be a truly majestic conference. And I think at the outset only, I would like to thank as well as congratulate Raya, Dr. Goenka, Dr. Javan for this invitation. I'm going to talk about pregnancy and IBD, optimizing treatment. So you have IBD on one hand, on the other hand, if you have a kind of like a physiological typhoon building up like pregnancy, obviously for the patient it seems like double trouble. They feel that, okay, it's a state of hopelessness. There are plenty of questions, there are plenty of doubts, plenty of concerns, starting from whether they should really get pregnant, what the medicines are going to do to the fetus, to them, whether they're going to transmit the disease and all. And it is our job whether we can convert the state of hopelessness and give them a glimmer of hope. So let's see about it. This is a common problem. Well, actually, pregnancy and IBD is a common problem because males and females are equally affected in IBD. And IBD, the commonest age is 20 to 40 or 50 years of age group. That is also the reproductive age group. So if you do a back of envelope calculations, you will find that 1/4 of patients with IBD would actually be going through this process. And so you really need to address this issue and be cognizant about it. The first question which comes to the mind of the patient as well as the physician is, should pregnancy be advised in a patient with IBD or not? Well, it seems that voluntary childlessness is a big problem. If it is 6% in general population, in pregnancy it goes up to the tune of 17 to 30%. Surprisingly, because if you look at the ability to conceive in a patient with IBD is almost similar to general population as long as they have not had a colon surgery or a pelvic surgery, as long as the disease has been in remission. And that is why the knowledge and attitude counseling is extremely important. This is a multi-center study which was led by Australia, which had Hong Kong, India as the centers, which looked at when patients were talked about, a patient with IBD were talked about pregnancy in general clinics, subsequently in IBD clinics, and in dedicated IBD pregnancy clinics, it was seen that pre-conception counseling really changed the knowledge and also changed the attitudes. It had a dramatic difference when it came to pregnancy outcomes. So pre-conception counseling is so important. So what is the first step which you are going to, if you are going to talk to the patient, what is the first step you would like to put across? That is the single most factor which is critical for the successful pregnancy outcome. And I think that is creating a balance between spontaneity as well as planning. Conception, if it done when patient of IBD is in remission versus conception done when the patient is undergoing a flare, there seems to be a dramatic difference. Active disease at conception poses a great risk to pregnancy. It poses a risk to mother and fetus, and IBD symptoms at conception lead to IBD activity most of the time during pregnancy. On the contrary, IBD remission at conception leads to a healthy pregnancy. So this is a fact which most of us know. But yet at the same time, I would like to overemphasize this fact because if you are able to put across to the patient that the single most factor which is critical for a successful outcome is 3 to 6 months of steroid-free remission before conception, then half the battle is won. Most of the things are taken care of. So, at the risk of saying again and again, I would say this is the single most important fact. Next concern is genetic transmission, obviously. That what are the chances of genetic transmission? If you look at data from our country, we have data from Delhi, we have data from Hyderabad, which shows that roughly 2 to 4% of patients with IBD would have a family history. So if you look at chances of genetic transmission, the risk of UC is slightly lower, around 1.6%. Risk of Crohn's disease is up to the tune of 3%. And if both the parents have the disease, then the risk is 16 to 30%. So there's a marginally increased risk if one parent has IBD, obviously a greater risk if both parents have IBD. Is there some redeemable factor, or there is something which we can talk about in counseling which can help, and that is, it has been seen that if infants are breastfed, then the reduction in risk is by around to the tune of 30%. This is so much important that last week only the tropical review on multidisciplinary perinatal care in IBD was taken out by ECMO, and it also stated clearly that breast milk provides ideal nutrition, fine, but it has positive effects on the immune system of the newborn and may protect against development of IBD. This is a very powerful statement, and this is something which needs to be put across to the patient. What about the disease course? We have data from India, which is a North Indian cohort, fairly large cohort, which looked at 597 pregnancies in IBD. And the interesting thing about this data was that it looked at patients who had developed pregnancy before the onset of IBD and also pregnancy after the onset of IBD. What you would realize out here is that abortions, stillterms, preterms, postdated, they were definitely more in patients who had pregnancy after the onset of IBD, and statistically, full term was definitely less in patients with pregnancy after the onset. But what was the factor which was hidden out here? The factor which was hidden out here is that most of these patients who had increased complications were the ones who had conceived when they had increased activity. In fact, data from Dr. Puri's group also shows that another factor which could be important is extent of disease. Extent of disease seems to be a predictor of pregnancy outcomes in patients with ulcerative colitis. Third question which a patient would ask upfront: C-section, cesarean section, is it mandatory? Obviously, I have a colonic disease, I may have a perineal disease, what to do? When we again look at data from North Indian cohort, you would find that C-section, we thought would be, a lot of patients would be undergoing C-section. But what we realize out here is that patients with IBD, even after they had pregnancy after the onset of IBD, 12% of patients with UC had C-section. Crohn's disease around 25%. So yes, marginally increased number of patients had a cesarean section, yet at the same time, not all patients had a cesarean section. So when we advise cesarean section, that is patient having a rectovaginal fistula, patient having a perianal disease, patient having ileal pouch anal anastomosis. Rest of the cases, the indications of cesarean section would remain the same as for any general patient. Question for the physician now: which drugs are safe? Clearly, the principle out here is the benefit of treatment for pregnant patient far outweighs the risk. And the first thing, which is obviously a contentious note between the obstetrician and the gastroenterologist, to give thiopurines or not. You have written azathioprine. The first thing the obstetrician would do is stop azathioprine. Well, there is plenty of data available now which supports that azathioprine can be given in patients with pregnancy. This is data from Piano Registry, which looked at around 1,400 patients who were given azathioprine, given biologicals, given a combination of azathioprine and biologicals, and clearly there was no increase in congenital malformations, spontaneous abortions, preterm birth, or low birth weight. Only if there was increased activity, there were chances of increased spontaneous abortion. Data on this continues to emerge every 2 months. This is data which has just emerged 2 weeks back. This is from the Dutch group, which shows 117,000 exposed pregnancies. Again, no increase in adverse maternal or neonatal outcomes. The only caveat is if a patient is on TNF therapy plus azathioprine, don't give combination therapy, give monotherapy. You can give only one of the agents. Secondly, if a patient goes into relapse and you want to start azathioprine, pregnancy may not be the right time to start azathioprine for the first time because of risk of adverse events, and obviously to take 2 to 3 months for the effect to build up. What about biologics? Whether they are safe in pregnancy or not. We knew that infliximab and adalimumab was safe in pregnancy. What about vedolizumab and ustekinumab? And it seems that data has emerged over the last 3 to 6 months where we can move them towards the safe category. Another interesting thing is that you can continue anti-TNFs all through the 3 trimesters. It is not that you have to stop in the second trimester. You can continue with all the 3 trimesters. It is the last dose should be spaced in such a way that it can be 2 or 3 weeks before the delivery time, and immediately after delivery, the anti-TNFs can be started. This is very recent data suggesting that ustekinumab and vedolizumab, as I told you, data is building. This adds to that, which shows that in pregnancy they will be safe. They are associated with favorable pregnancy and neonatal outcomes. When you give any of the biologicals, be cognizant of the fact that for the neonate, you would not like to give light vaccines like BCG, Rota vaccine, or even MMR you may like to delay, because for 6 to 12 months you may not want to give a light vaccine. What are the drugs which are avoided, I would say? Allopurinol you would not like to give when you add with azathioprine. Cyclosporin, avoid. Tacrolimus, avoid. Drugs which are contraindicated. Methotrexate, stop 3 months before conception. Tofacitinib, 1 month before conception. Filgotinib to be stopped. Ozanimod, 3 months before conception. So these are drugs which are at best avoided. A patient has come with first trimester pregnancy, was on 5 days, azathioprine presents with severe disease exacerbation. What are you going to do? How are you going to monitor? Serum albumin, good to monitor, but again it drops by 1% in pregnancy because of pregnancy. ESRP rise because of pregnancy. CRP is a better, more accurate predictor, but still not so good. Best would be to monitor with fecal calprotectin. That would not be affected by pregnancy. If you want to do a sigmoidoscopy, you can go ahead with unprepared sigmoidoscopy, unsedated sigmoidoscopy. Best to do an unsedated sigmoidoscopy. Even a colonoscopy can be done, provided the patient is in left lateral position. Imaging, ultrasound is fine. MRI without contrast is fine. So in a patient with flare, you can give steroids, you can give topical therapy. If the patient still does not respond, you can give infliximab. Adalimumab is safe, but may not be helpful in this setting if the patient has acute severe ulcerative colitis. Same is true for vedolizumab. Remember that even in case of pregnancy, it is all the more important to give venous thromboembolism prophylaxis. That is, you have to give low molecular weight heparin. If the patient has a CMV infection, ganciclovir you cannot give. Valganclovir you cannot give. If CMV immunoglobulins are available, that is the only choice in that setting. Vancomycin you can easily give to a patient has Clostridium difficile infection, but after surgery. We are also concerned about whether in sometimes you do come across a case, pregnancy with severe ulcerative colitis, again steroids, infliximab, patient is not responding. Would you operate or would you not operate? And just 2 months back came up the largest series of surgery in patients with IBD, only 44 cases, but that explains the extreme complexity of this problem. And what did this data show us? It showed that surgery was done in first trimester, second trimester, third trimester. What are the main indications for surgery? They were either fistulizing Crohn's disease or refractory ulcerative colitis. What was interesting out here? That patients, 80% of patients who underwent surgery in second trimester and 40% of patients who underwent surgery in third trimester were able to complete their pregnancy, and the maternal and neonatal mortality was much lower, although the morbidity was still high. Yet at the same time, in a given case, in good circumstances where you have all the best expertise available, surgery is definitely an option out here. Provocative question: could pregnancy be beneficial for patients with IBD? Well, again, the data from North Indian cohort showed that patients who were pregnant and had IBD, or patients who were pregnant and did not have IBD, when we looked at disease scores, the disease scores in patients with pregnancy certainly had higher levels of remission. The disease was not so severe in those patients. What could be the logic behind it? The logic is obviously increased estrogens, progesterones during pregnancy, and also the polarizing state it occurs with pregnancy and seems to give the benefit to the patient. So that is another thing you can keep it in mind when you're talking of pre-conception counseling. So we have to look at 3 scenarios: pregnancy after IBD, pregnancy before IBD, pregnancy and IBD appearing together, both benign courses if a patient has pregnancy after IBD. Then there are 2 or 3 points which I would like to touch upon, which we tend to ignore. Most important point is nutrition. If it has to be part of a pre-conception counseling, don't ever forget, because nutrition is as important as the disease going into remission. These patients are responsive to IVF in case they do not conceive. Always look at thromboembolic complications. There's an increased risk of VT events. So low molecular weight heparin should be given after cesarean section during any hospital admission for disease flare. If a patient is, let's say, has a flare beyond 37 weeks, there you can think of going in for early delivery rather than thinking of increasing the immunosuppressive therapy. If you have to give an antibiotic, patient has Pancreatitis, best antibiotic to be given is amoxicillin clavulanic acid because metronidazole not good for the breastfeeding part, or in the first trimester there may be issues, ciproflox not good for first trimester. Amoxicillin clavulanic acid would be the best practice. And then we know that it's a multidisciplinary team which takes care of it. But maternal fetal medicine specialists there is a group of specialty which is coming up. So the best practice recommendations, I would say, this is a summary slide, is that all patients with IBD are capable of pregnancy, and a pre-conception counseling is one which makes all the difference. If you want to improve the outcome, clinical endoscopic remission should be achieved before conception. Fecal calprotectin can be checked at pre-conception, every trimester and postpartum. Most of the IBD medications compatible in pregnancy are compatible with lactation. Biologics can be continued through pregnancy, and you can make a schedule adjustment. Methotrexate, ozanimod to be stopped 3 months before. JAK inhibitors, tofacitinib do not use. Most patients can safely undergo vaginal delivery and maintain medications after delivery to minimize postpartum disease. So, if you were talking about all the concerns that the patient has, I would say it's clearly not a situation of hopelessness. It's just a case of maybe some doors are closed, but a lot of windows are open, and that is what hope which you can provide to the patient to really help the patient. Thank you so much.
Thank you, Vineet. As expected, a very lucid talk on a subject which I think some of us are not very aware of. Questions will not be taken from the audience, but I have a very learned chairpersons. Any comments you would like to make? Otherwise, we close the session. In all the three, any of the three.
It was an excellent talk as usual. Thank you.
Thank you, Vineet. Your questions will be taken up personally. Thank you.
Right. Thank you, chairpersons, and thank you, moderators. For the next session on luminal, may I please invite Dr. Ravindra Sharma, Dr. Raj Mani, Dr. Sabir Hussain, Dr. Balvinder Singh to please chair this session. Can I also request Dr. S.P. Mishra and Dr. N. Bhargava to please be the moderator for this session. The adjudicators for this session will be Dr. Amit Sanghi and Dr. Manohar Sharma.
Well, it's my privilege to invite Dr. Uday Ghoshal to deliver a lecture on evolution and management of refractory constipation. Uday is Professor Head of Gastroenterology at the Sanjay Gandhi Postgraduate Institute at Lucknow.
Thank you, chairpersons. I at the beginning like to thank the organizer, the ISG, for giving me this opportunity. I'll be talking about evaluation and management of the refractory constipation. Many of us may have still confusion. What is constipation? Constipation is defined by Rome by a constellation of the symptoms, such as somebody having straining, lumpy or hard stool, sensation of incomplete evacuation, obstruction or blockage, and maneuver to pass stool. Obviously, once upon a time, many of the gastroenterologists and physicians in India thought constipation means infrequent stool. Because many patients of constipation repeatedly go to the toilet. Therefore, we realize that if you go by frequency alone, most of the time you will fail to diagnose constipation. And typically we use Bristol stool chart, which says if 25% of the stool are hard, such as type 1 or type 2, then this is constipation, provided there is no increase in the frequency of user stool to a tune of more than 25%. Remember one thing, in Asia or in India, we say even type 3 stool is constipation. How to manage this patient? Always take a good drug history, because many of the time you realize patient is on antihypertensive, maybe anti-diabetic, maybe other drugs which can cause constipation, and if you overlook this, then probably just giving laxative will not work. You do a detailed history taking and physical examination, And physical examination should include a thorough rectal examination in which you should see whether the puborectal stone is increased even when patient is attempting to defecate. Look at the alarm feature. Alarm feature, if they are absent, then initial treatment should be dependent on the presence of bloating. If bloating is a prominent feature, do not give fiber because fiber increases bloating. Similarly, lactulose increases bloating. If bloating is a predominant feature, give drugs such as polyethylene glycol, milk of magnesia, and so on. Now, also those who have alarm feature, for example, onset of constipation after the age of 45 years, maybe family history of colon cancer and others, always get a colonoscopy done. If colonoscopy does not show any abnormality, then the patient goes to the same part. If there is a good response, follow up, but no response means this is probably a refractory constipation and should go to tertiary care. Many patients of refractory constipation have pathophysiological basis. For example, slow transit constipation, fecal evacuation disorder, only pharmacotherapy is not going to help that. So if I get a patient with refractory constipation, I ask myself sitting in the clinic 3 questions. Is it organic or functional? By standard definition, you think organic means colon cancer or stricture. No, organic may mean the patient has colonic inertia, maybe he has myoneuropathy, maybe there is a more systemic disease, for example, Parkinson's, which is causing constipation, maybe sedentary lifestyle, like yesterday I got a patient of constipation who has polio. For last 2 years is having constipation, but last 2 years he has gone to the wheelchair. So the wheelchair is a major factor causing his constipation. People tend to forget to look at that. What could be the possible causes and what could be the pathophysiology? Because pathophysiology may guide treatment. There are several clinical symptoms which tells you that the patient might be having pathophysiological abnormalities. For example, fecal evacuation disorder. These are prolonged straining, excessive straining, manual maneuver to evacuate, feeling of obstruction, heaviness in the perineum, perineal or vaginal pressure to pass through, unusual posture at the toilet. Many patients will tell, doctor, earlier I used to squat and pass through, now I have to stand and pass through. This is, he or she is doing a maneuver to correct the abnormal anorectal angle, and these are fecal evacuation disorder patients. Multiparous patient who develop the constipation after a childbirth, maybe difficult childbirth. Think about fecal evacuation disorder. Now, those patients we evaluate like this. Refractory constipation, we do 4 tests. These are colon transit study, balloon expulsion test, anorectal manometry, and difficography. Now, let me tell you, if you look at the Western guideline, they go one after another. They will say, do first this. If it is abnormal, don't do anything more, just treat. There is a difference between the Western guideline and the Indian guideline. We like to do all 4 together because the reason is many of our patients have to come from far off places. Many a time these investigations are quite cheap in India than in the West. And third is there could be combination pathophysiology in a given patient. So therefore, the Western guideline may not be the perfect guideline. They have a constraint because the cost of the healthcare and access to the tertiary care is limited there. Whereas in India, it is an open healthcare system. Any patient can come to any setup and get his or her treatment done. There is no strict referral system. So therefore, I'll do all 4 together if possible. Now, if all these are normal, then you are dealing with something else. This is not true constipation. Maybe do a psychological evaluation. On the other hand, if CTT is abnormal, that means it's so slow colon transit. This is a colon transit disorder. I'll treat differently than a fellow who has fecal evacuation disorder, which is like inability to relax the pelvic floor, which will be treated with biofeedback. On the other hand, there could be patients where there are both slow transit and fecal evacuation disorder. So these are the tests that I was talking about. Now let me tell you, many of these tests may not be widely available. But balloon expulsion test can be done by even physician. What you do is that you take a condom, tie this over an infant feeding tube, push into the rectum, and then fill up with water, 60 ml water typically. Patient is in the left lateral position, and then ask the patient to evacuate this condom. Now, if the patient cannot evacuate, keep on adding weight, 50 gram, 100 gram, 200 gram on the infant feeding tube other end. And if the patient requires more than 250 gram added weight to expel the condom, this is suggestive of fecal evacuation disorder with a sensitivity and specificity of as high as 80 to 90%. Also, a good anorectal or rectal examination will be, with a trained finger, will be able to pick up this patient. How is colon transit done? This is the evolution of how colon transit went on. But in India, typically, we use a different protocol. The protocol is give 20 radiopaque marker at 0 hour, 20 at 12 hour, 20, another 20 at 24 hour, then do X-ray at 36 and 60 hour. If at 36 hour, more than 30 markers are there in the X-ray, it is abnormal colon transit. And at 60 hour, if there are more than 14 markers, it is an abnormal colon transit. I have seen many places doing colon transit still with a Western protocol, and when this patient come to us, we have to repeat this test because the protocol, Indian protocol, was not followed. Now, difficography will give you a lot of structural abnormality. As you can see here, there is a big rectocele, and this patient obviously requires a surgical correction of the rectocele and not necessarily giving fiber to treat the patient. Nowadays, we do MR difficography quite often. Now, high resolution anorectal manometry is very, very important. In this, we see when the fellow patient is trying to evacuate, is he or she able to generate enough pressure inside the rectum and relax the anorectal machinery. That means when we evacuate, we have to generate enough pressure in the rectum by rectal motor complex as well as the abdominal muscle contraction. But at the same time, we have to relax the pelvic floor, and if there is a discoordination there, it will cause constipation due to fecal evacuation disorder. This is how fecal evacuation disorder has been subtyped by Satish Rao into 4 groups, but let me tell you, till we are waiting for the clinical importance of this evaluation. So if there is a PT and you want to take up a thesis, this is a good area to take up. That means 4 types of fecal evacuation disorder that Satish Rao devised. Is there a clinical utility of this? We don't know today. So these are the 2 major studies on frequency of fecal evacuation disorder in Indian patients with chronic constipation, and as you can see, as high as 30 to 40% patients have fecal evacuation disorder. And if you treat this patient just by use of Gula husk or any other laxative, they are very, very dissatisfied because there is no improvement. In fact, we have found the most difficult FGIV to treat is chronic constipation, and this is an Asian studies which showed the same, that many of the FGIVs are dissatisfied with the treatment at primary or secondary level, particularly chronic constipation patients are more dissatisfied. So we typically do a pathophysiology guided therapy. So what about is the pathophysiology? If it is slow colon transit, give transit stimulator. What are transit stimulator? Earlier we had cisapride, tegaserod, we have now procalopride. So procalopride is a prokinetic. So therefore, all the other prokinetic, they don't work in the colon. For example, mosapride doesn't, etopride doesn't, but procalopride does. Second is you have a lot of drugs to stimulate motility other than procalopride. For example, you have linaclotide in the West, you have cisapride which is withdrawn, tegaserod is withdrawn. Fecal evacuation disorder is treated by biofilm. Now here is an important study which shows that if you take constipation patient, those who have slow transit versus those who do not have slow transit. Those who do not have slow transit, there if you use procalopride, it is not as effective. Only in slow transit patient it is effective. Now third is, in the slow transit category, if the transit is too slow, that means disease has advanced too much, their focal pride doesn't improve. That is, it is like a diabetic patient. In diabetes, you give only lifestyle measure. Those who have minor diabetes, they will get corrected. But then the other groups which have more severe disease, they will require multiple OHA or overall hypoglycemia. But once there is a secondary OHA failure, you really need insulin. So similarly, among the constipation patients, you have some who have normal transit, their procalopride will not work so well. Some who have moderately slow transit, procalopride will work. And those who have severe transit, they may require colectomy. So, if you have given procalopride and the patient responded, will they respond for long? Look at this study where it showed that during long-term follow-up, like 2 years, many patients tend to fail to respond. That means initially they will show response, then they will fail to respond. Like diabetic patient, initially they will show a response to OHA, then there will be secondary OHA failure, and at that stage, you need something more than procalopride. Now, what about this? What can you give? You give another drug which has a different mechanism of action. For example, high amplitude propagated contraction is important for evacuation and motility, and the stimulator of HA-PCR, bisacodyl, sodium picosulfate, and senna. So in those patients, I combine procalopride along with those agents so that there are two differing mechanisms which are working. This is a study from Michael Camp from UK. Because of shortage of time, I will not be able to elaborate on this study. But in this randomized controlled trial, he showed that bisacodyl was far superior to placebo. We have two studies from India. One is morphine-induced constipation, and other is the Dr. Hari's study on Tegacero. Biofeedback is very, very important for fecal evacuation disorder. Today, we need more centers to do biofeedback in the country. We have limited number of centers. Also, many centers are not doing the way we should be doing. So maybe we need more educational session to uplift our biofeedback center. Now, in those in whom biofeedback fails, what do we do? What we find is a lot of Indian doctors, they don't use the technologies which are very often used in the West. If somebody is having severe constipation, there you have to really do disinfection of the rectum. And this is done typically with the rectal irrigation solution. In the West, these are very often used, but in India, we don't have even a company marketing the rectal irrigation solution. Many of these patients really require rectal irrigation very often evacuated. In patients with difficult to treat fecal evacuation disorder, we give botulinum toxin injection into the puborectals. What we found is the literature shows it is very good, but in fact, in our hand, it is not so good. Maybe our technique is wrong, or maybe the literature has selected those who have good results. Those are reported more often than what are not. Also, sacral stimulation is a method, but typically we use TEMS and stimulate a branch of the sacral in the periphery using percutaneous stimulation. So, Indian consensus of constipation says that we should actually have a top-down approach to treat this patient, because Indian healthcare system is open access healthcare, and therefore you have to satisfy the patient very early in the course to keep them with you. And finally, many of these patients, like look at our series, which is a very old series, where we found that surgery really worked in a good percentage of patients, but selection of the patient is very important. If somebody has a lot of psychological comorbidity, don't do surgery in them. Thank you so much.
Thank you. That was wonderful and precise and concise. May I now invite Dr. Simon Travis to speak on biologics in IBD, the current status. Simon is a professor at the Kennedy Institute and Translation Gastroenterology Unit at University of Oxford, and I think he has an Indian passport too.
Well, it's a great pleasure to be in Rajasthan for the first time, and thank you to the ISG and thank you to the Congress organizers for inviting me to speak on biologics, but also remember those small molecules, what's happening. Multiple conflicts as ever, but it gives information. So first, who are the correct patients? Well, evidence of active inflammation is clearly an essential component if you're going to treat somebody with an anti-inflammatory agent. And you need that evidence, whether that's from fecal calprotectin, endoscopic, or biopsy. But you've also got to remember that the conventional therapy has to be optimized before you move on. And only start on that journey, that biologic journey, if there's a chance of changing the pattern of disease. If somebody has obstructive symptoms from Crohn's disease due to a stricture, don't expect a biologic to help. You can operate before using biologic therapy if there's a stricture, and use biologic therapy afterwards if there's an inflammatory recurrence or to reduce the risk of recurrence. And of course, you've got to be sure that it's safe to start. You've got to screen for infections, you've got to consider whether there's malignancy, and consider the context. And here in India, of course, it is the cost is a dominant feature, and I'm fortunate in the UK where the NHS doesn't constrain our prescribing activity to any great extent at all. But remember the patient, not only talking about the context of their care, but also agreeing on the outcomes. And consider what you're trying to achieve. And what we want to do is to improve safety, reduce delay, control costs, consider the options, and I'm not including the S1P receptor modulators as anamod because they're not yet available here in India, and then briefly touch on our practice in Oxford. So let's start with the anti-TNF and the anti-integrins, and I will simply focus on one, the first head-to-head trial comparing the two, and very clearly the purple bar, the vedolizumab, is more effective than anti-TNF therapy with adalimumab for patients with moderate to severely active ulcerative colitis. That goes not only for clinical remission, but it also goes for histological remission, and perhaps most importantly, it goes for that composite endpoint of endoscopic improvement and histological remission, where histological remission is defined by the absence of neutrophils in the epithelium and mucosa of a colonic mucosal biopsy. The biopsy, the histopathology, is probably the best biomarker of long-term outcome in patients with ulcerative colitis, and we've been ignoring it for 100 years, it seems, and therefore pay attention to what the pathologists actually say. But you can see here that vedolizumab scores over adalimumab in all of these endpoints, and the safety of the anti-integrins, gut-specific, is a great advantage. Perhaps the other aspect is that the biosimilars, which are universally available now for the anti-TNF agents, they're unlikely to become available for vedolizumab. And the reason for that is that Vedo has a very specific IBD market and doesn't have a wider market. Therefore, the biosimilar companies are not going to develop a vedolizumab biosimilar. I may be wrong, but the other factor to remember is that vedolizumab can now be given not only intravenously, but subcutaneously as well. And the fortnightly subcutaneous injections are as effective as the intravenous infusions and probably get a higher level of vedolizumab. So my take on the pros and cons of the anti-integrins and the anti-TNF is that the anti-integrins provide gut-specific immunosuppression. They work for both conditions. Doesn't matter if there's previous malignancy. But of course, they have a relatively slow onset of action. They may not work in patients with extra intestinal manifestations, and therefore, if a patient has an arthropathy associated with colitis, an anti-TNF is to be preferred. Don't seem to work for fistulae, but they carry a high cost. Anti-TNF, on the other hand, have advantages in patients with fistulizing disease, systemic manifestations. But as you heard from Professor Ahuja, then avoid live vaccines if they're used as rescue therapy or if they're used in pregnancy, simply because they predispose to infection in the neonate. Move on to anti-IL-23 therapy, ustekinumab. Here's just a snapshot of ustekinumab efficacy in Crohn's disease. It's a complex slide. The names will are themselves difficult to remember. The Unity 1, 2, and Immunity. The Immunity is the maintenance study, but here you can see in that maintenance study the major secondary endpoints, and notice that there is still this major therapeutic gap of about 50%, in some cases 60%, where we're not meeting those endpoints. And also note that the advantage in the turquoise bars of giving is marginal, of giving the ustekinumab every 8 weeks as opposed to every 12 weeks. But it's a good agent, works for ulcerative colitis just as well. Here's the unifying study demonstrating that you've got corticosteroid-free remission as well as endoscopic improvement, and you've got this concept of sustained remission, which matters so much for the patients where the remission at all time points. Busy slide on safety, but the safety of ustekinumab is good, or even though it offers systemic treatment for patients with ulcerative colitis or Crohn's disease. I've highlighted here the fact that there's no increase in serious adverse events compared to placebo and no increase in the infection rate, but that of course matters to India. And so if with the risks of anti-TNF therapy, which I believe are higher than anti-IL-23 therapy, then the anti-IL-23 therapy has an advantage. I've once again summarized my own personal view of the pros and cons of anti-IL-23 therapy. I mentioned too the fact that the ustekinumab, which targets the P40 component of the IL-23 and therefore involves inhibition of IL-12 as well, that there are just around the corner 3 inhibitors of the P19 IL-23 specific components. But if you look at ustekinumab, I believe it's safe, sustainable, works in patients who've lost a response to anti-TNF therapy. Great if people have also got a spondyloarthropathy, perhaps less good if they've got a peripheral arthropathy. You don't need azathioprine. That's a major advantage. Whereas with anti-TNF therapy, you need an immunomodulator. It's a good choice if people have to travel a large distance, simply because the infrequent subcutaneous injections just lend themselves to less frequent travel. But on the other hand, you don't seem to be able to increase and escalate the dose and recapture, even if a group of, if some patients are treated every 4 weeks. And I suspect that is without evidence, but I suspect that will be replaced by combination therapy with advanced biologics in the future. I'm sorry I'm having to compete with the carpeting, but we'll carry on. The anti-IL-23 P19s, I think the key thing is whether they will offer an advantage over and above the ustekinumab. And they made it. They're certainly the risankizumab, mirikizumab, and gozaltamab will hit the market within the next 12 months, and they are more effective than ustekinumab for psoriasis. But then we know that Crohn's isn't psoriasis of the gut, so we shall see. Janus, the two-faced Roman god of doorways and passages, as Kumar was mentioning, there are 3 JAK inhibitors available. Tofacitinib, very familiar here in India, great choice with as being cost-effective, but doesn't work in Crohn's disease. Filgotinib and upadacitinib around the corner. Here is the TOFA data about week 52. showing that there is clearly an advantage of of not only 5 milligrams twice daily, but also the 10 milligrams twice daily for treating moderate to severely active ulcerative colitis. But there is that threshold, that 30–40% ceiling, which it doesn't seem to be able to broach. It carries its own specific risks of side effects, in particular zoster, and perhaps some nasopharyngitis. There's been much concern about venous thromboembolism, but it's shingles, which is the main issue that affects about 1 in 100 patients so treated. Filgotinib, same applies as far as the risk of shingles is concerned, but it is effective not only in ulcerative colitis, but also in Crohn's disease as well, and we will see that licensed. The real discussion, though, has been around the risk of thrombosis and malignancy and infection, largely derived from the patients with rheumatoid arthritis, not with IBD. And what the echo position statement suggests is that that you shouldn't translate experience from one inflammatory disorder, rheumatoid arthritis, because it affects a much older population, different comorbidity, different systemic manifestations to IBD. Risk factors are different, and because the JAK inhibitors vary in selectivity, you shouldn't lump them all together. That said, European Medicines Agency have indeed lumped them all together, and I propose a simple acronym for deciding about starting JAK inhibitors, the START checks. So mention about shingles, advise about vaccination, consider the risk of thrombosis, especially if they've had a thrombosis in the past, advice on pregnancy, as you heard from Professor Ahuja, they shouldn't give them during pregnancy, should be stopped before at least a month, and reassess after an interval and tailor therapy. Here again are my little summary slides of the pros and the cons. Price is a major advantage, especially here, because it's a small molecule, which is much less expensive than the biologics. It's a good choice if there's coexisting arthritis, and there's no immunogenicity. There's JAK1 specific inhibitors of the advantage of being effective in Crohn's as well. I've not shown you the data, but still have to be avoided in pregnancy, and there is that risk of infection in the elderly. So when you're making these decisions about the choreography of what to take, you've got to consider a whole range of factors, from disease activity, patient's view, the evidence from the trials, and of course the affordability. And what we do in Oxford has been, I just compared from a talk I gave in 2017 to our most recent data, that we massively increased our use of biologic therapy. I can't yet give you the outcomes data, show that that's a cost-effective introduction, but you can see that we've got about, just in ulcerative colitis alone, this is confidential data, Professor Ahuja, before you take a photograph, 42% of our patients with ulcerative colitis are now being treated with an advanced therapy. And that, to my mind, is in the interest of the patients. And I think in making that choice, you have those different factors. There's no simple algorithm that you can follow. You have to relate them to your own individual experiences. But there's one topic on which everyone's agreed, and that is that you don't choose your biologic on the basis of the date that they were first licensed. So the choreography isn't a sequence based on the licensing. You need to discuss the options, consider disease activity, do your pre-flight checks, and then you've got a specialist nurse who helps with the treatment initiation. Monitoring is essential, and to my mind, that includes doing an endoscopy at a defined time point. You've also got to discuss the contingencies, like playing chess, think ahead, because what are you going to do next if there is non-response or loss of response? And then remember to speak to your surgical colleagues, because the newer strokes, the small percentage of patients, will do less to relieve the burden of IBD than improving access to good conventional care for all of our patients. Thank you very much indeed.
Thank you, sir. Thank you, Simon. This was wonderful. May I invite Dr. Shobna Bhatia? She will be speaking on achalasia and evolution. Shobna.
Committee of the Indian Society of Gastroenterology for asking me to speak. I was asked to actually differentiate the three types and limit myself. So I'm going to talk more about the diagnosis and not anything about the management unless when it comes up as part of my talk. So first of all, we all know that achalasia is a disease of unknown etiology, and we also know that there's a loss of normal peristalsis in the smooth muscle, which is present in the distal esophagus. There's a failure of LES relaxation during swallowing, and the third part is actually the original definition, is that the esophageal baseline pressure is higher than the gastric pressure. The etiology is thought to be idiopathic in most cases. Of course, there are studies to show that other factors also contribute, like viral and autoimmune. And the most recent study from Ivan Dellon's group in North Carolina, I think it's South Carolina, sorry, there they looked at more than 6,000 patients of achalasia and about 27,000 controls, found that there was an association with autoimmune conditions, mainly scleroderma and Addison's. In clinical practice, Addison's along with Algrove syndrome also have association with achalasia. And a lot of patients with hypothyroidism also turn out to have achalasia. Viral infections like varicella zoster has the highest association, and only this can be done only in retrospective studies and cannot be thought of as a prospective study. In the pathophysiology, as I mentioned, the normal swallow, there's both the circular as well as the longitudinal muscles contract. When we swallow, the first contraction that occurs is the longitudinal muscle contraction, which causes accommodation in the esophagus. It causes shortening of the esophagus. The LES moves above the diaphragm and relaxes. When the peristalsis starts, it's the circular muscle that pushes the bolus down. In achalasia, there's a loss of inhibitory nitric oxide mediated inhibition. Now, when there is a loss of inhibition, that means there will be increased contractility, and this happens in the LES. Subsequently, the ganglion cells also die and are destroyed, which may be due to immune-related inflammation. And there is therefore an abnormal body peristalsis as well as an abnormal LES relaxation. We look at the pathology. This is the normal esophagus, where you see a normal myelinic plexus and you see a normal ganglion cell. Unfortunately, for early achalasia, there are very few biopsies that can be taken because patients with early achalasia are not going for surgery. A few autopsy studies looked at, found some patients with early achalasia, and that's how we have these biopsies. Where in early achalasia, there is a depleted myotic plexus. You compare this with the first picture here, and there are less myotic plexuses here, and the ganglion cell is inflamed. Whereas in late achalasia, where you can get easy biopsies, because some of these patients undergo surgery, you can have a loss of the myotic plexus as well as a fibrosed ganglion cell. As far as the pathophysiology is concerned, there could be a viral infection or any other etiology, along with a genetic background, where the myotic plexus is inflamed, and then here you get the antineuronal antibodies. There is a loss of myotic neurons. As a result, the LES stops to relax. When it stops to relax initially, it looks like an EGJ outflow obstruction, and subsequently there can be a type 2, which is the early stage, and as the esophagus starts dilating, you get a type 1 and an end stage. On the other side, there can be neuronal enosyntase imbalance, which again gives rise to outflow obstruction. But here, because of the imbalance, some part of the contractility and spasm is still present, giving rise to a type 3 achalasia. So eventually, this is the pathophysiologic picture that I'd like to show you. There has to be a genetic predisposition. There are triggers, probably viral, autoimmune. There's inflammation. When there is agangliomas, hypnosis, and CERVET, there's type 1 and type 2 achalasia. And when there is an imbalance between inhibition and contraction, there's type 3 achalasia. In patients who have a preserved esophageal body function, they behave like an EGJ outlet obstruction. So in short, there is the concept of excitation and circular muscle imbalance. So in the LES, the inhibition is completely lost in all the 3 types of achalasia. In type 1, the LES pressure tends to be normal. Even then, it does not relax as well as normal. And there is excitation of the lower esophageal sphincter. As far as the circular muscle is concerned, the circular muscle inhibitory function is intact in EGJ obstruction, which is why the peristalsis is normal. Whereas in type 3 achalasia, the circular muscle excitatory function is upgraded and therefore there is spasm. Longitudinal muscle also, there is no contraction, there is no peristalsis, and therefore you feel that there is a simultaneous contraction of the entire esophagus. The symptoms we are all familiar with. There's dysphagia to solids and liquids, which is progressive, but not in the way that it is progressive as in malignancy. There may be regurgitation. A lot of patients present like reflux because they say they have only regurgitation and absolutely no sour reflux. Here the regurgitation is bland and contains recently ingested food. Often it is partially digested. It may be slightly sour because the retained food gets fermented and produces lactic acid. There may be chest pain and heartburn, and there may be weight loss, especially in early achalasia, when the dysphagia and chest pain are more prominent. So the investigations that we talk about in general are endoscopy, manometry, with or without impedance, I will come into that, variant swallow, more importantly a timed variant esophagogram, a flip which I do not have experience of, and supported of course are the others. So let's look at the endoscopy. When you're doing the endoscopy in all patients of dysphagia, the first investigation could either be an endoscopy or a variant. Do not jump to manometry just because you clinically think it is achalasia. Because in that way you can go wrong in many ways. Manometry is specific when you know that there is no anatomical or mechanical obstruction during endoscopy. So therefore, what you can see is this normal thickened muscular ring, a rosette formation at the LES, and quite often we talk about a resistance to the GE junction to passage of the scope. The mucosa is usually normal unless there is a lot of candidiasis because of stasis of food. There may be a dilated esophagus, especially in type 1 and occasionally in type 2. There may be excessive secretions, residual food, and occasionally some erythema and ulcers. Once in a while, there may be a malignancy and we've got to be careful. So when do we do the manometry? First is confirmation of diagnosis. Then we do to subclassify the types of achalasia, as has been classified more than 15 years ago. And remember that in a patient who is on opioids, either for medication or for addiction, opioids can mimic type 3 achalasia. So if you get a patient with dysphagia, one of the questions you always ask is, please tell me if you are taking opioids. Stop these drugs at least a few days before the manometry, otherwise you'll be overdiagnosing achalasia. So in a nutshell, because everybody knows about the type of achalasia, and you've seen a lot of pictures, I'm putting this as a one single slide. What the Chicago 4 did is they talked of type 1, type 2 and type 3 achalasias. Normal pattern, you follow this. Can this be seen on the screen? Okay, no, it's not. Can I have a pointer, please? Okay. I thought this was seen on the screen. Okay. So normally, you see that there is a temporal movement of this wave, which is the peristalsis. The LES relaxes, which means that the pressure comes down. This is the normal LES. In type 1, you see that there is absent, there is no pressurization in the body. The esophageal body is so dilated that 5 ml of water that we give does not cause any pressure change in the esophageal lumen. And therefore, there is no change here. The LES does contract. Type 2 achalasia, there is no peristalsis, there is no peristalsis here. There is pressurization, that means this entire unit behaves like one, and there is pressurization here, there is a LES relaxation, and here you see spasm, which means in all three, LES is impaired, and the esophageal body is contracted only in type 2 and type 3 achalasia. In the variant swallow, this is all we are very familiar with. You can see this body appearance, and this is a dilated esophagus of type 1 achalasia. In timed variant, you give variant 200 ml and ask and take multiple pictures at 0, 2 and 5 seconds, and you look at the fluid level at these points. As it empties, you can say whether there is an abnormal empty or not. You might see an X-ray chest where there will be abnormal widening of the mediastinum. As I said, I do not have much experience with FLIP, and FLIP assesses the response to distension. So you distend a balloon in the esophagus, as you can see here, and as you distend the balloon, you get these shapes. At 40 ml, you try and see what is the AGJ as well as the esophageal body. And you can see that in achalasia, pre-dilatation, this is what you get, and post-dilatation, this is what you can see. In eosinophilic esophagitis, the entire esophagus is contracted. Okay. In achalasia subtypes, you can get type 1, you can see this abnormal pressure, but there is no movement in the body. Type 2, type 3, you can see abnormal contractions even during FLIP. EUS is not routinely recommended. However, if the EUS, if a patient has a short history, less than 6 months, severe dysphagia and weight loss, please rule out pseudoachalasia. We recently had a patient where EUS actually showed widening of the diameter, and that entire thing was eosinophilic esophagitis. So in a patient with a short history, please go ahead and do other investigations. So what to do if the diagnosis is unclear? You first look at this chart that was presented after the Chicago classification. This is classic achalasia on the left. If you have a patient with mild peristalsis, or that the LES is partially relaxing, not as much as normal, but not going to the level of 15 millimeters of mercury, as described in the Chicago classification. Do the study in upright as well as lying down position, and also do additional studies. In addition, there's a source of warning here. I've borrowed this slide from Dr. Prakash. So just look at this. If there is a suspicion and you think it is achalasia, ask the patient to do upright swallows in the upright, and you can see that some of these patients actually did not have achalasia. So you do the upright swallows, and you do or you can do a barium at this point, so you can prevent an overdiagnosis of achalasia. Coming to underdiagnosis. So, coming to underdiagnosis, you have a rapid breathing challenge of 100 to 200 ml. This is normal. And in patients with achalasia, you can see that there's a lot of spasm developing here. Okay. Okay. So, and the next thing you can do is assess bolus retention with an impedance pressure topography. You find that you can see this fluid level here, which is equal to the barium, and therefore you can say that there is fluid retention. You don't need to do an barium. You can do that impedance and check the fluid level. I won't be going into the distension contraction plot. But just in conclusion, there is a genetic predisposition, there is an environmental trigger, leading to chronic type 2 achalasia, and then there is imbalance between inhibition and excitement with type 3 achalasia or an EGJ obstruction. And finally, always look at additional diagnostic tools. Do not underdiagnose or overdiagnose achalasia. And provocative measures augment your diagnosis whenever you are in doubt. Thank you.
Thank you, Shobna. We don't have time for any questions. I can see a sniper over there pointing a gun at me. Thank you.
Thank you, thank you.
Thank you, chairpersons, and thank you, speakers. For the next session on hepatology, may I please invite Dr. Mukul Rastogi, Dr. Sudhir Maharishi, Dr. Atul Shinde, Dr. Malika Arjun. For the moderators, can I please invite Dr. Y.K. Chawla and Dr. Subhash Nepalia. The adjudicators for this session will be Dr. Ashish Mehta and Dr. Sandeep Goyal. I would also like to inform that the delegate kits can be kept at the cloakroom. Please feel free to avail this facility. Thank you. Due to the paucity of time, I am also going to be inviting the first speaker, Dr. S.K. Acharya. Can I please have you on the stage? Thank you.
And at the outset, I must convey very happy New Year. We are beginning ISG conference in the New Year, and best wishes for the New Year. I must also convey my deep appreciation and gratitude to Professor Rai, Sandeep, and others to have given me the opportunity to present in such a gala, mega place, right, and a mega conference. Thank you. Now, portal hypertension is a very common event in our day-to-day clinical practice, and many of us indeed encounter cytopenias across the spectrum of portal hypertension. Many times we do bother whether it's to treat, whether it's not. And mostly mild and moderate cytopenias do not bother you, and you try to treat the cause of portal hypertension and other sequelae of portal hypertension. And if you see the various research work also is directed for the management of dangerous sequelae of portal hypertension and etiology. Unfortunately, the cytopenias, even though our clinical headaches, are often ignored as far as research is concerned. However, we all know the definition of cytopenia. I don't want to waste time here. The spleen, any patient who has a spleen, irrespective of the cause, because splenomegaly and cytopenia can occur in various hematological conditions as well. So any splenomegaly with any cytopenia of any three elements in the peripheral blood is defined as hypersplenism with cytopenia. And in patients with portal hypertension, if you have this cytopenia, you call it portal hypertension associated cytopenia. And there is an old definition. Unfortunately, nobody has worked to clearly define why you should call it hypersplenism in portal hypertension. What should be the cutoff? So the cutoff has been used from hematologists. And I provided that, and we use it. And a severe hypersplenism is defined when the, irrespective of the hemoglobin, which is invariably low, when the TLC count falls below 2,000 or platelets fall below 50,000, and that is the time when they become symptomatic. And symptoms of low hemoglobin or low TLC or low platelets are also very well known, which are described. Now, very interestingly, if you see, I've drawn actually histopathological picture of the spleen. And if you can see clearly, this is the right whole, this is called white bulb, and this is called the red bulb. You can get splenomegaly in congestive heart failure, in pericardial effusion, in constrictive pericarditis also. But in that, very finally, histological studies shows the red pulp is increased. But in patients of portal hypertension, if you saw, the white pulp is increased. The white pulp consists of germinal center, where are B cells or lymphoid follicle, surrounded by a mantle zone, surrounded by a marginal zone, where there are macrophages. This is very important. And T cells are along the arterial lymphoid sheath. And this distribution is important. In patients with congestive splenomegaly because of heart, you will find red pulp increases. Have you seen cytopenia in patients prolonged congestive cardiac failure? Can you remember? You don't. Because cytopenia occurs because of increased macrophage functions present in the marginal zone, and they get activated in patients with portal hypertension. And there have been studies of this. And histologically, people have expressed various mRNA of various cytokines, which are summarized in one curve. Right? If you see, in patients with portal hypertension, there is portal congestion, increased splenic artery supply, and there is a peripheral pooling of blood inside the spleen. And the macrophages which are present in the marginal zone get activated, and they cause phagocytosis of the cells. And that is why in portal hypertension you get cytopenia. Why they get activated? Because in cirrhotics, there is continuous, there is necrosis. And we know necrosis liberate various immunogens like high mobility protein. The protein is a chaperone protein for transcription, is very immunogenic and low disease. Right, various dams, right? They, through the splenic artery, can stimulate macrophage, stimulate T cells, stimulate B cells, right? Macrophage eats away blood pools, and the cytokine goes to the circulation through the portal vein to the liver and perpetuate the liver disease. So hypersplenism in portal hypertension perpetuates liver disease, eats away your blood. That is the basis. So therapy for it, what we do is peculiarly fun. So it's what we can do to treat these patients with symptomatic hypersplenism. We have to first thing reduce the congestion of the blood so that macrophage doesn't eat it, or stimulate the marrow. And there are other mechanisms of thrombocytopenia, which is very sinister, particularly in cirrhosis. It is not only, thrombopoietin is not only produced from the kidney or from the marrow, it's also produced from liver. And thrombopoietin decrease causes thrombocytopenia, and there are various other causes of platelet distress. And the symptoms, obviously, are very clear And the frequency of cytopenias in portal hypertension across the study, it's quite frequent. Right? Sometimes you will find in day-to-day clinical practice, you study 1/3 or 40% of cytopenias. And we ignore it because many times you cannot do much about it, you should not do. But what can you do if you have a symptom like that? As the pathologist explained, splenic sequestration is the basic cause. So you can reduce splenic sequestration by various methods or increase bone marrow production. Now, you can reduce splenic sequestration by decreased splenic decongestion and reduce drugs, or you have some intervention like photosystemic salts or tips in patients of both non-cirrhotic and cirrhotic portal hypertension. Or you can reduce splenic site like partial splenic embolization or splenectomy. Or these are the two broad groups, splenic sequestration and bone marrow production. You can use various growth factors, but the evidence is few. And there have been actual cytokines, which are very important. And people are now trying, right, particularly anti-high mobility group protein anti-monoclonals and mTOR inhibitors. Splenic histology has already shown in portal hypertension very increased upregulation of mTOR, which you know very important cause of cell proliferation, induction of pro-inflammatory cytokines, and particularly through JAK-STAT pathways. Now, if you see how can you reduce splenic decongestion, and there is a very interesting study from SGP by Dr. Poddar in pediatric patients for portal hypertension, which is all the form of portal hypertension, chronic liver disease, non-cirrhotic conditions, and they defined portal hypertension to less than, say, 100,000, and TLC less than 4, but hemoglobin 11, they give 4 weeks of beta glucan, reduce heart rate by 25%. And if you see, indeed, all the 3 parameters increased. And even those who defined responders, they say the platelet count should be more than 10 to the power 5, right, per ml. And that's why they describe responder. But if you see responder as well as non-responder, all has improved their peripheral side symptom, beta glucose we use, but we don't assess. People have used thalidomide. Thalidomide is anti-angiogenic and decreases VEGF, and they have been implicated also in splenic sequestration as disease. And if you see the various parameters in cirrhosis as well as hematological condition, over 12 months period, substantially has improved. These are platelet counts, but the TLC count has also increased. And you can reduce splenic sequestration by splenic decongestion by using intervention. These are drugs like tips. And decreased portal hypertension obviously corrects the mechanism which I cited, and these are evidences, multiple studies. So tips indeed improves the cytopenias. Now, photosystemic effect, which you cannot do in cirrhotic, but in non-cirrhotic you can do, and here is the evidence, absolutely. And so there's a percentage increase of TLC over periods of year, and you can see a shunt without a splenectomy, right, can increase the cytopenias. Partial splenic artery embolization has recently been tried, and if you see the partial splenic embolization has improved cytopenias in about 50 to 70% in 4 to 12 weeks. But there's a problem. Post partial splenic embolization, most patients will get pain and fever, and about 10% will develop splenic abscess. Right? You can develop pulmonary complications, renal complications, particularly in cirrhotic. You can have problems if you have sepsis. So this is not very frequently used. People are little cautious in clinical practice, but well, yes, that is better. Now, multiple studies have shown it is successful. But problem is, as I told, that infection, particularly in our setup, I personally must have done in 10 or 12 patients, and 3 patients died because of splenic abscess and infections. I myself scared. Now, splenectomy. And before this were available, there was nothing. Spleen. And this is a study done by me at AIMS when I used to see cirrhotics, and many of them will be HCV or HBV, and you cannot treat with interferon. Those days interferon was the therapy. And well, I did splenectomy in them. None died. Of course, I had an expert portal hypertension surgeon, Professor Tusani, who was very good. And I've shown you the result over 12 months follow-up. What is surprising? I've given you the low functions. And if you see the albumin at the end of 12 months, the child scores it. Ascites has come down for spleen. I could treat half of them effectively, and they are fine. And splenic vein thrombosis occurs in only one patient at 12 months, which is a known complication of splenectomy or partial splenic artery embolisis. So I just discussed about both. Now the growth factors. Now you know for cytopenia, particularly thrombocytopenia, I've listed 4 drugs. The first 2 drugs not used because they are associated with splenic vein thrombosis. But if you see that later 2 drug has been cleared by FDA in 2018 and 19. However, these studies which are quoted here, right, for everthrombopic and lusotrombopic are short-term studies done for procedure, given for 2 to 4 weeks. So we cannot use them at the moment, data or evidence for long-term use, particularly thinking about various venous embolism or venous thrombosis. However, there are potential molecules to use them. And these are 2 multicentric large studies. So avatrombopag is extremely effective in correcting thrombocytopenia without any peripheral vein thrombosis within a short course of therapy. Now, GCC-SASF has been used, right, not in Asia, that's a different story, right, which is a very controversial story. But in cirrhotics with cytopenia, and you find there are multiple studies. There are case reports or case series showing the results, but they have never been used in real cytopenia, like less than 750 neutropenic or 500 neutropenic, which are prone for infections. That we need that. Now, erythropoietin and cirrhotics, people don't use. I don't know, because bone marrow is hypercellular already. Already erythropoietin levels are high. Whether erythropoietin will work or not is questioned. And recently, as I told, based on the cytokines, studies are necessary. This is my last slide. Thank you for telling me that my time is up. So, step 1, I told, in portal hypertension and symptomatic hypersplenism, you can treat etiology and replacement of OP, which I didn't say, which is important and which is relevant, which you do. Second, drugs, beta blockers and thalidomide. Thalidomide is safe. I used to use it for low cats. Third, growth factors. You see, you are not intervening. Just because of lack of knowledge, I have devised this myself. And if this fails, and if you have cirrhosis, you can do this, right? Tips is good if they are decompensated, because they take care of everything, right? Till you get a transplant. Splenectomy or partial splenic embolization, I'll reserve. I'll prefer a test which is widely available. Non-cirrhotic, obviously, splenectomy or shunt is a good option. Thank you very much.
Good morning, everybody. I have pleasure to invite Dr. S.P. Mishra, who needs no introduction in our society. He's a great man, to speak on endoscopy in pregnancy. Dr. Mishra.
Thank you, sir. Well, when they gave me this topic, I thought it's about pregnancy, when and how. So I was going to talk about pregnancy, and I had a very hilarious lecture for you, but unfortunately 2 days back, I was told that I had to speak on a mundane topic like endoscopy in pregnancy. So, you know, the procedures which have to be done in pregnancy can be upper GI endoscopy, endoscopic gastrostomy, big eject, enteroscopy, video capsule enteroscopy, lower GI endoscopy,
especially ERCP, spyscopy or endoscope, and a regional single operator cholangioscopy and sometimes endoscopic ultrasound. I am sure with more expertise and good anesthesia, with more active and very invasive procedures can also be done. So I'll be telling you what is the precautions to be taken. Over sedation has to be avoided at all costs. So mother is, potential mother is, she can tolerate without sedation, that is the best. Because it causes maternal hypotension, it causes maternal hypoxia, and it can also cause fetal hypoxia. So that has to, one thing is to be sure that over sedation has to be avoided. The fetus is exposed to potentially teratogenic drugs, and they have to be avoided. I'll be talking about it. Radiation is one taboo which has to be tackled. When there's gravity uterus, it applies pressure to the inferior vena cava, there's decreased uterine flow, and that can lead more to fetal hypoxia. What are the indications basically? So you have to be very sure. If it is not indicated, please don't do it. Try to avoid it. One is significant or continuous GI bleeding, severe refractory nausea and vomiting and abdominal pain, and that's very common with hyperemesis gravidarum. Dysphagia or rhinophagia, strong suspicion of a colonic mass, severe diarrhea with negative evaluation, biliary pancreatitis, symptomatic choledocholitis or cholangitis. Now these are absolute indications. Biliary or pancreatic ductal injury, especially after surgery. What are the general principles guiding to endoscopy in pregnancy? You have to consult an obstetrician. So you have to have a team, anesthesiologist, obstetricians have to be there. Always have a very strong indication, especially in high-risk pregnancies, otherwise you'll end up with problems. Defer endoscopy to the second trimester whenever it is possible, and most of the time it is possible. Use the lowest effective dose of sedation. Use category B drugs whenever possible. Minimize the procedure time. The patient position has to be left pelvic or left lateral position to avoid vena cava or aortic compression. So these factors are mandatory. The fetal heart rate and uterine contraction have to be monitored. If you have before 24 weeks of fetal gestation, you can use an ultrasound Doppler. After 24 weeks, you can use electronic fetal heart and uterine contraction monitoring can be done. Antibiotics safety during pregnancy has to be ascertained. You have safe antibiotics in pregnancy: penicillin, cephalosporins, clindamycin, and erythromycin, except the steroid. You have to avoid quinolones, streptomycin, and tetracycline. In the first trimester, metronidazole, people have already said about this, has to be avoided. In the third trimester, you have to avoid sulfonamides and nitrofurantoin. These are the category of drugs, and I will not go into the details to save time. About sedation, mepridine you can use. Fentanyl is a C-class drug and you can use it. Propofol is a B-class drug and can be used in pregnant mothers. Midazolam and diazepam have to be avoided. So the most common indication for upper GI endoscopy in a pregnant woman includes upper GI hemorrhage, ongoing bleed, progressive dysphagia with weight loss, suspected upper GI malignancy, refractory nausea and vomiting in hyperemesis gravidarum. The commonest finding, or if you do an endoscopy in these patients, is reflux esophagitis. Naturally, hyperemesis is common, so you get reflux esophagitis. You can also get a peptic ulcer disease. Mallory-Weiss syndrome, we have seen quite a lot of patients because they keep on retching, vomiting, and sometimes they come with bleed having a Mallory-Weiss tear. The diagnostic rate of upper GI endoscopy in bleed is 95%, and that is true for all cases, even otherwise, non-pregnant. Also, it's 95%. Other indications is a bit less. What about H. pylori in pregnancy? More common in pregnant females with hyperemesis gravidarum compared to controls. But do we need to treat them at that time? I don't think so. You can need to treat them later on. GERD is because of this progesterone and estrogen is increased. So at least relaxation is there, the patient can have GERD. Acute non-medicine upper GI bleed in pregnancy is mostly caused by Biologics here. Sometimes you can have peptic ulcer syndrome. Maternal mortality in fetal loss is less than 1% in these causes. Cirrhosis, the patient is cirrhotic, there is a less chance, there is a lecture later on cirrhotics. The person has a less chance of becoming pregnant because of severe dysfunctions and endocrine metabolism is disturbed. And varicose bleeding typically occurs during the second and third trimester due to increased fluid retention and cardiac output in these patients. So second and third trimester, first the patient may not conceive, but if the lady conceives, you have to be very careful in the second and third trimester. Non-cirrhotic portal hypertension, fertility is normal, but there is 45% incidence of varicose bleeding during pregnancy. And the mortality here is very high, 18% to 50%. So again, non-cirrhotic portal hypertension, if a lady conceives, you have to be very careful. The obstetrician has to be roped in very early so that you are safe. Beta blockers in cirrhosis used for first-degree prophylaxis. Safety is controversial. It can induce premature labor, intrauterine growth retardation, neonatal apnea, bradycardia, and hypoglycemia. So there are multiple problems with beta blockers, but they are used. Myometric relaxation of the gravid usage is beta-2 mediated process, and non-selective beta blockers are contraindicated because of this. Therapeutic endoscopic procedures in non-vessel bleed can be injection therapy, epinephrine, closing agent, thrombin, or cyanoacrylate. It can be ablative therapy like electrocoagulation, thermocoagulation, photocoagulation, and APC. You can also have compression because of hemoclips, detachable snares, graspers, and sutures. So you can use all the armamentarium available to you to stop the bleeding. Epinephrine, the class C drug, and can be used and causes a decrease in uterine blood flow. That should be remembered. But the data is limited. Benefit is you can stop the bleeding. Electrocautery is safe, especially if you have a bipolar electrocautery, because the current is limited. What about varicose bleeding? All the modalities that we use for general population can be used. You can have EVF, you can have sclerotherapy, but sclerotherapy is outdated now. Everybody is doing EVF, they are very effective and without any fetal or maternal complications. Tips can be used in emergency. There is refractory upper GI bleeding. What about percutaneous endoscopic gastrostomy? What are the indications basically? The severe refractory cases of impaired nutrition to the mother and the fetus. Hyperemesis gravidarum, the person cannot take good amount of calories. This can be indicated, especially in the third trimester of pregnancy. Especially when other methods are not successful. So if you can't feed the mother, then you have to do a PEG. The limitations are the risk of uterine damage during transabdominal needle insertion, and that can be minimized by demarcating the upper border of the uterus and inserting the needle 5 centimeters cephalic. So, as compared to normal PEG, in a pregnant lady, you go more cephalic towards the cisterna. And the PEG can be converted to PEGJ if needed. What about endoscopy and capsule endoscopy? There are no case reports of endoscopy during pregnancy, and the safety of endoscopy is not known. What about video capsule endoscopy? Is a relative contraindication in pregnancy because the capsule can get stuck up and then you can have problems. Again, there is compression because of the growing gravid uterus on the bowel wall, and so the chances of the capsule getting stuck up is more. GI motility problems also there in pregnancy because of the hormones, and that can lead to a delayed entry. Sigmoidoscopy is safe in pregnancy, and the indication to rectal bleeding, that's the most common indication, chronic diarrhea, abdominal pain, and rectal pain. Sigmoidoscopy during pregnancy does not induce labor or cause congenital malformation. But try to defer it 6-week postpartum if you can. Otherwise, if needed, you can jolly well do it. You can even do a colonoscopy. So insufficient, what about colonoscopy? First trimester colonoscopy can lead to neonatal depression and premature labor. So try to avoid during the first trimester. Second trimester it can be done very easily if there is a strong indication of life-threatening emergency. Colonoscopy may be done the first and third trimester if planning is for urgent surgery. So the basic sign dictum is like the obstetrician, the mother's life is more important than the life of the fetus. So if the mother has pressing problems, you can do any procedure and save the mother. Colonoscopy can be done for if they suspected colon cancers, control single uncontrolled colonic hemorrhage, colonic stricture, or colonic serial obstruction. Patient should be placed in the prone position, especially later pregnancy, and external abdominal pressure should be avoided. Bowel cleansing, PEG is a category C drug but has not been studied in pregnancy. Sodium phosphate enema is again a category C drug. It can cause fluid and electrolyte disturbance and should be avoided during pregnancy. Now, this is the most common indication for getting endoscopic procedures is ERCP. Especially if the patient has cholangitis, symptomatic cholangitis or cholangitis. Pregnancy is associated with increased risk of gallstone formation. You all know about that. So if there is cholangitis and the patient has cholangitis or urgently needs an ERCP, you can do an ERCP. For radiation, the most important thing is limit the radiation. Small amount of radiation is not harmful. But teratogenic of radiation during the first trimester is only more than 0.1 rad. So this should be avoided. So the one important thing which I can tell the postgraduates over here, once you're shielding the mother from and the fetus from the radiation, I have seen even senior gastroenterologists using the wrong way. You have to know where the beam is coming from. If the beam is coming from below, it has to be below the mother. If it's coming from above, it has to be above the mother. So most of the time the beam comes from below. So it has to be below the patient, not above the patient. Secondly, we were the first to do ERCP without colonoscopy. You can aspirate bile and remove stones or place stents very easily. So this can be released sphincterotomy, you can do very easily, no complication, with or without biliary stenting. Simple biliary stenting, balloon sweep, endoscopic papillary balloon dilation, mechanical lithotripsy, pre-cut sphincterotomy, stent placement, cholangitiscopy can be done. And all those procedures have got the indications you know very well. The complications are the same as in the general population. It's not increased. So basically, if you do ERCP, the maternal as well as the fetal complications are not there, and you can jolly well do it. The fetal outcomes are favorable. Perinatal mortality is less than 1% with no congenital anomalies. Rate of prematurity is 1.8% as compared to national average. Fetal distress is less than 1%, similar to the general population. So overall, ERCP in complicated colorectal has more benefits than risk. But mind you, pancreatitis can occur at the same incidence as the general population. Endoscopic spyglass can also be done. Distal single operated cholangioscopy can also be done. It has better imaging. Endoscopic ultrasound is safe, but if this indication is there, we can do it. Cystogastrostomy can be done. There is a pseudopancreatic cyst in these patients, and the complications are not there, either for the fetus or for the mother. So even the intervention endoscopic procedures are safe in expert hands. So summary, whenever possible, it is wise to defer endoscopy in the first trimester and peripartum period. Minimally invasive short duration procedures should be substituted for long invasive procedures. Documentation of fetal heart, sound and pre and post procedure monitoring is mandatory. Perform EGD in the left lateral position to avoid reflux and to avoid abdominal compression. Radiation exposure should be taken into consideration. Thank you very much.
Thank you, Dr. Mishra. Now we have the next talk, which is to be given by Professor Paolo Angeli. Approach to renal dysfunction in cirrhosis. The GI crowd is familiar with Professor Paolo Angeli.
As you know, he's the professor of internal medicine and chief of hepatology at the Department of Medicine, University of Padova, Italy. And he's also the editor-in-chief of Journal of Hepatology. And we are all familiar with his work on ascites and acute kidney injury. He's going to talk to us on an approach to renal dysfunction in cirrhotics. Paul.
Thank you very much for this kind introduction. Let me thank the organizer for this invitation. I'm very proud to be here with you today. I have only 12 minutes, so I will focus on the approach to acute kidney injury. And you all know that the diagnosis of acute kidney injury can be done all the increase in serum creatinine, absolute increase equal or higher than 0.3 milligram DL in less than 48 hours, percent increase in serum creatinine equal or higher than 50% during the last week, or on the basis of the reduction of urinary output below 0.5 ml per kilo body weight per hour for more than 6 hours. You know that there is a staging system based on the amount of the increase of serum creatinine from baseline or on the length of oliguria or anuria. If you have the possibility, please use both the criteria, because of this will increase your ability to make the diagnosis of AKI in cirrhotic patients. The second step in the diagnostic approach to AKI is much more complex. Is the differential diagnosis among the 4 different phenotypes of AKI in patients with cirrhosis, so acute tubular necrosis AKI, ATN AKI, pre-renal AKI, hepatorenal syndrome HRS AKI, and post-renal AKI. So let me say that in most of the cases, pre-renal AKI is solved by plasma volume expansion by the high doses of alcohol, 1 gram per kilo body weight for 2 consecutive days. Post-renal AKI is rare, so the real problem is to differentiate between ATN AKI and HRS AKI. And what we have? We have our own definition of hepatorenal syndrome, according to which we are speaking about a functional renal failure. What does it mean? It means without parenchymal damage. So nowadays, we make the diagnosis of HRS AKI in a patient with increasing serum creatinine when the patient does not respond to the withdrawal of diuretics, does not respond to the plasma volume expansion, has no evidence of shock, is not on treatment with nephrotoxic drug, and there's no evidence of parenchymal damage according to the absence of significant proteinuria, microhematuria, and abnormal renal ultrasonography. The question is, are these criteria the way to rule out the presence of parenchymal damage? The answer is no, because if we use a platform of new biomarkers of parenchymal damage, and particularly of tubular damage, you can see that abnormal values are present not only in patients with ATN AKI, but also in patients with HRS AKI, when compared with those with pre-renal AKI and to those without AKI. The higher number of new biomarkers with abnormal values, the lower probability you have to confirm the initial diagnosis of HRS AKI, and the higher probability to conclude for an ATN AKI. These findings suggest that it is time to move to another definition of hepatorenal syndrome, according to which we are speaking about a type of renal failure that is predominantly functional in nature, but may be associated with some degree of parenchymal damage, putting HRS AKI in a continuum between functional AKI and structural AKI, putting HRS AKI in the middle between pre-renal AKI and ATN AKI. But these findings put several questions. The first one is, can we use these new biomarkers to facilitate the differential diagnosis in between ATN-AKI and HRS-AKI? The answer is yes. This is true for urinary IL-18 and overall for urinary and gall, because you can see that there is no much overlap in values of urinary and gall comparing patient with HRS-AKI and patient with ATN-AKI. The second question, why there is parenchymal damage in patient with HRS-AKI? Because nowadays, nobody thinks anymore that the only driver of HRS-AKI is renal hypoperfusion. There are other powerful drivers that are microvascular dysfunction, direct tubular damage, and overall inflammation and oxidative stress. So, in a patient with HRS-AKI, you can find several types of parenchymal damage, not only excessive vasoconstriction, but microthrombosis in peritubular capillaries, polymorphonuclear cell infiltration of the interstitium, and death of the epithelial cell through every path, so apoptosis, necrosis, and pyroptosis. The most important question, if there is parenchymal damage in patients with HRS-AKI, which is the impact of parenchymal damage on the therapeutic treatment of this condition? And you all know that the therapeutic treatment is teriparatide plus albumin. But let me focus a little bit on this, because initially, teriparatide has been proposed by intravenous bolus. 0.5, 2 milligrams every 4-6 hours. This is not the right way to use teriparatide, because in this way, we cannot assure a continuous lowering effect on portal pressure, as we can do using teriparatide by continuous intravenous infusion. This is why we performed some years ago this controlled clinical trial comparing the two modalities of administration of teriparatide in patients with HRS-AKI. You can see that we were not able to find any significant difference in terms of efficacy. But using teriparatide by continuous intravenous infusion, we reduce it by half the dose of the effective dose of the drug. This means that you can reduce by half the rate of severe adverse effect. So you can treat, and yet you can continue to treat a larger number of patients using teriparatide by continuous intravenous infusion. And this is important because we are speaking about a treatment that is capable to save life in responders, that is capable to change the landscapes in terms of renal function after liver transplantation in responders. But let me go back to the question, which is the impact of parenchymal damage on the efficacy of the therapeutic approach in patients with HRS-AKI. I mentioned urinary and gall. If your patient has a urinary and gall higher than 220 nanograms per ml, the probability to be a responder to the pharmacological treatment is quite low. So low that the urinary and gall was found to be the only independent predictor of lack of response to teriparatide plus albumin. Let me go on. It is not surprising, according to this finding, that in patients with very high urinary level of gall, AKI is so frequently progressive and so frequently associated with a poor outcome. You know, AKI always, often, not always, often occurs in the setting of acute on chronic liver failure. And you know that acute on chronic liver failure is characterized by a very high degree of systemic inflammation and oxidative stress. The higher grade of ACLF, the higher degree of inflammation and oxidative stress. So it is not surprising to observe that when we treat patient with HLS-AKI in the setting of ACLF, for each baseline value of serum creatinine at which you will start the treatment, there is a progressive reduction of the efficacy of the treatment, moving from patient with ACLF grade 1 to patient with ACLF grade 3. So again, it is not surprising that in patient with ACLF grade 2 and grade 3, AKI is so frequently progressive and associated with a poor outcome. But let me go back to this slide, because here the most important message is another one. For increasing values of serum creatinine at which you will start the treatment, there is a dramatic reduction of the rate of efficacy of the pharmacological treatment. So please forget the old distinction of hepatorenal syndrome into type 1 and type 2. Forgot the type 1 HRS diagnosis. Nowadays, we speak about HRS-AKI, and there is no more cutoff of serum creatinine at which you can make the diagnosis and you can start the treatment. Just the last point, which is the evolution of parenchymal damage in patients with AKI, and particularly in patients with HRS-AKI. Let me focus first on transient AKI, because we define responders to the pharmacological treatment on the basis of normalization of serum creatinine. But if we measure GFR, we can realize that the recovery of renal function is only partial, very partial. So let me focus now on persistent or progressive HRS-AKI in spite of the treatment. The evolution here is on the histological ground towards colonic nephrosis or ATM-AKI or both. On the ground of definition, the evolution is towards acute kidney disease or chronic kidney disease with or without the need of renal replacement therapy. So, please remind that the development of acute kidney disease in a patient with cirrhosis is associated with a poor outcome. And these are my take-home messages. In patients with cirrhosis, AKI is frequent. The diagnosis of AKI should be based on the KDIGO criteria. HRS is predominantly functional in nature, but is associated several times with some degree of parenchymal damage. The differential diagnosis in between HRS-AKI and ATM-AKI can be facilitated by the use of the new biomarkers. There is no more cutoff of serum creatinine at which you can do the treatment, this diagnosis of HRS-AKI, and you can start the treatment. The option of terlipressin plus albumin is quite efficacy. And finally, patients with persistent or progressive AKI, in spite of the treatment, develop acute kidney disease or chronic kidney disease with or without the need of renal replacement therapy. Thank you very much for your attention.
Thank you, Professor Paulo, for being well in time and taking us through this. The questions for all the 3 and 4 speakers would be taken up personally. The next person to be invited is Professor Nora Tirol, who is the President-elect of the American Association for Study of Liver. And we are all familiar with her again. She's the Professor of Medicine at the University of California. She's done extensive work on chronic hepatitis, especially hepatitis C, and currently is looking after the transplant. So, Professor Nora, you're going to talk to us on hepatitis B treatment in 2023. Welcome.
Thank you very much. And I want to thank the organizers for the invitation to be here. I always enjoy the opportunity to visit another part of India, so I'm thrilled to be here. Thank you very much. And Happy New Year, everyone. I was asked to talk about HBV management in 2023. And maybe I'll just start by saying we've had a safe and highly effective nucleoside analog therapy for chronic hepatitis B for nearly 2 decades now. and highly effective therapy for at least 10. The preferred drugs currently are entecavir, tenofovir DF, and tenofovir AF. These drugs have a high genetic barrier to resistance, resulting in high rates of suppressed HBV DNA while on therapy, and with very important clinical outcomes. And the unique and very important aspects of these drugs is that they're broadly applicable. They can be used in individuals with cirrhosis, decompensated disease, pregnancy, children, transplant recipients. So it's really transformed our approach to managing hepatitis B, because we can effectively suppress virus in a wide range of patients. The indications for treating chronic hepatitis B have not changed much in recent years. We still are targeting those individuals who are at risk for progressive disease, which is defined by having elevated ALT levels in conjunction with elevated HBV DNA levels and or the presence of advanced fibrosis or cirrhosis. So you can see on the left, the groups that are targeted for treatment with our current guidelines include those that have immune-active hepatitis B, defined as having ALT levels at least 2 times upper limit of normal, and HBV DNA levels either greater than 2,000 if you're E antigen negative and 20,000 if you're E antigen positive, and anyone with advanced fibrosis or cirrhosis, co-infection, and we have some special populations. The groups in which we are currently recommending deferral of treatment because they are not at risk for those progressive complications of liver disease are those that have inactive chronic hepatitis B, and maybe a more controversial group, but still recommended not to be treated of those that are only intolerant. And I could show you many studies that highlight how important these therapies have been in terms of reducing the very real complications of chronic hepatitis B. With use of NA therapy in the populations in which we currently are recommending, we are seeing lower rates of cirrhosis, we're seeing less patients needing liver transplant, we have less liver cancer, and overall improved survival. So we've come a long way. So what I really focus on, since much of that is very well established, is what are the evolving areas as we look to 2023? And I'm going to focus on 3. One is, how do we choose among the available 3 preferred drugs? Because there's been some controversy of whether one might be better than the other. Then I'm going to focus on the so-called gray zone patients, those whose HBV DNA levels or HBV DNA ALT levels don't meet the criteria for treatment but are sort of in between. And then I'll finally talk on this aspect of functional cure, achieving surface antigen loss, because we now have an increased emphasis of achieving that with defined rates of treatment. So first of all, this issue of does the choice of nucleoside analog therapy make a difference? Shown on the left is a large Korean-based health service study that was the first to highlight that in patients that have been on long-term NA therapy, those that were treated with entecavir appear to have higher rates of HCC over time than those that were on tenofovir, suggesting tenofovir had some added benefit in terms of HCC prevention. That has now generated many, many other studies, and shown on the right is a propensity-matched cohort meta-analysis looking at, again, does it make a difference, entecavir versus tenofovir? And what you can see in that study is indeed they confirmed in the meta-analysis that there's a lower rate of cancer in patients who are treated with tenofovir-based therapy. So where does this leave us in 2023? Should we put all our patients on tenofovir? What I'll remind you is that there's no prospective or randomized control data, and the guidance still suggests that there's always the possibility of residual confounding. And so at least at the moment, there's no recommendation to switch patients who are on entecavir currently to tenofovir. We regard tenofovir and entecavir to be excellent first-line therapy. Secondly, the gray zone patients. So these are the patients, as I mentioned to you, whose ALT levels or HBV DNA levels don't quite meet the criteria for treatment or non-treatment. So this is a very large study. It's one of many, but just to highlight that if we look at the population of patients who are presenting with chronic hepatitis B, about 1 in 3 will fall into this gray zone. So it's not an infrequent event. In this very large study from China, you can see that the majority, more than 50% of those gray zone patients, represent patients who are E antigen negative, who have an elevated ALT greater than 2 times upper limit normal, but their HBV DNA levels are less than 2,000. And then the second other big group is the group that's e antigen negative, whose ALT is normal, but their HBV DNA levels are greater than 2,000. So currently by guidelines, we wouldn't treat either of those two groups. The question is, should we? About 75% of these patients, so in total, those e antigen negative patients fall into the gray zone. And then another interesting aspect around the gray zone patients is that they remain in the gray zone. So the guidance suggests that if you have somebody who's in the gray zone, just follow them and monitor them, and eventually they're going to declare themselves as either needing treatment or not. But this study that came from California and Taiwan showed that they followed patients for 5 years that were in the gray zone. In this case, they had 38% of patients who had presentation were in the gray zone. And when they followed them for 5 years, 75% of them still were in the gray zone. So it didn't allow them to make a decision. They remained in that zone. So the question is there any risk to the patients in being in the gray zone or in being in the indeterminate region? So here's two studies I'm going to share with you. The first is one which is looking at HCC incidence in patients who are indeterminate or in the gray zone versus having inactive chronic hepatitis B. And what you can see is that indeed those that had indeterminate chronic hepatitis B had higher rates of cancer, which might lead you to think, why? We should be treating those patients because they have higher rates of cancer than if they have inactive chronic hepatitis B. But what you'll see on the right is when they looked at the predictors of the cancer, it isn't the virus that's predicting cancer, it's the presence of diabetes and older age, suggesting that in these indeterminate groups, maybe they have a second liver condition that's contributing to their risk. So the first thing is if you have somebody in the gray zone is to look for other etiologies of liver disease, such as non-alcoholic fatty liver disease or maybe alcohol that could be contributing. But it is clear that maybe there's a group that should be treated. So this is data that was just presented at the AASLD meeting from the REAL-B study. In the study, what they looked at were individuals who met the definition for being gray zone, but in the study, some were treated and some were untreated. And what they looked at is the outcome, again here focused on cancer over time, and those that went on treatment, those that continued to be monitored in the gray zone. That's 6 years of follow-up. And what you can see is that over time, the group that was put on antiviral therapy had a lower rate of cancer than the group that remained untreated. And in this study, there was a 70% reduction in cancer when the gray zone patients were placed on treatment. So putting all of that together, how should we manage gray zone patients in 2023? Well, I think if you have someone who has a low HBV DNA level and a high ALT level, that suggests that it's not the virus that's driving the process, and I would look for other causes of liver injury, look for concurrent alcohol or non-alcoholic fatty liver disease, or possibly drug-induced liver injury. I'd consider age, because in all of the studies that have looked at the outcome of gray zone or indeterminate patients and their risk for cancer, age is an independent factor. So older patients, perhaps you should have a lower threshold to putting those individuals on therapy. And then finally, pay close attention to the HBV DNA. And if the HBV DNA is high, and it remains high even if the ALT doesn't meet the threshold of treatment, you may have a leaning towards treating those patients based on data now that suggests the risk for liver cancer will be reduced. Now, the last part of my talk, I want to focus on this goal of trying to achieve surface antigen loss, so-called functional cure. We know that surface antigen loss is the best serological marker of immune control and is associated with the lowest rate of liver complications lifelong. So it's highly desirable, but we don't achieve it very often. Shown in this table is the typical rates of surface antigen loss when we use either PEG interferon or the nucleoside-nucleotide analogs. And what you can see is while the rates are higher with PEG interferon, they're still overall around 10% only. And with nucleoside analogs, especially in the e antigen negative patients, very infrequently are losing surface antigen. And when you look across studies, the overall rates of surface antigen loss with treatment are about 1% per year. So that means that most patients who get started on nucleoside analog therapy, if you're going to treat them with functional cure, you're going to leave them on treatment for a very long time. And the question is, can we do anything to enhance the rates of surface antigen loss? And one of the key areas that's been looked at is, can we add PEG interferon? Will that help to manipulate the immune system such that they lose surface antigen? So I'm going to share with you, there's been combinations done and there's been other strategies, but I want to focus on the idea of either switching from a nucleoside analog to PEG or adding PEG interferon, the so-called swish or add strategy. And the reason I wanted to focus on this is there was a very nice study published in the past year called the SWAP study. It's a randomized controlled trial where they took patients that were on nucleoside analog therapy and randomized them to be put on PEG interferon or continue the nuke. And they looked at both E antigen negative and E antigen positive patients. Here I'm showing you the E antigen negative data. So shown on the far left in the bar, you can see that regardless of whether you did a switch, you added PEG interferon or you switched to PEG interferon from the nucleoside analog, that you ended up with the same rate of surface antigen loss, which is around 12%. So the first thing I'll say is that it does mean that this strategy did increase the rates of surface antigen loss, because we know that in E antigen negative patients who remain on nucleoside analogs and don't have PEG interferon, either add or switch, their rates were 0% in this study. So it did increase the rates of surface antigen loss, although it's quite modest. And you can see it didn't matter whether you switch or add, both PEG strategies resulted in high rates of surface antigen loss. But shown on the far right in the arrows are the rates of virological and clinical relapse that occurred when they did the switch or the swap. And what you can see here is that there's higher rates of relapse, in particular clinical relapse and virological relapse, when you do a switch strategy rather than an add-on strategy. So that led them to conclude that if they're going to use PEG interferon, it's better to add than to do switch, because you have less of these relapse or flares that are occurring. And then at the AASLD meeting this year, there was also a very large real-world study that looked at this question of adding PEG interferon to individuals on nucleoside analog therapy, and showed that the longer they're on the PEG interferon, the more proportion of patients that are achieving surface antigen loss. So in this real-world study, more than 20,000 E antigen negative chronic hepatitis B patients had PEG interferon added. And when they followed them so far out to 30 to 48 weeks, they had, of those that have lost surface antigen, you can see that they're progressing with losing it over time. Overall, 16.8% have lost surface antigen with 4 years of follow-up. Again, suggesting this is a strategy to get surface antigen loss. So my takeaways here, before I wrap it, is that the PEG interferon strategy, if you're going to do it, add-on is safer than switch. The best candidates are E antigen negatives, and there's still some uncertainty about sort of exactly what patients are ideally suited for this. And I would remind you that overall the rates of surface antigen loss are still quite low. I want to spend just 1 minute on this idea of withdrawing nukes in patients who've been on long-term therapy, because that's the other strategy that's used to try to get surface antigen loss. This is a meta-analysis that shows that when you take patients who've been on long-term nukes and stop the nuke, that 2% of patients that are Asian and 20% that are Caucasian will achieve surface antigen loss with follow-up periods of 3 to 5 years. And there's been data that shows that the best way to predict who's going to lose surface antigen when you stop the nuke is what their quantitative level of surface antigen is at the time that you stop. And shown in this very nice prospective study, you can see that that threshold differs depending on whether you're Asian or whether you're Caucasian. For Asians, if you want to stop and have a high likelihood of getting surface antigen loss, the right threshold for that is to have a surface antigen level that's less than 100 at the time that you stop the nuke. If they're a Caucasian, that level can be less than 1,000. And then finally, just one very recent data that suggested that quantitative surface antigen, if you're looking at it, if you want to not only get surface antigen loss, but minimize the chance of flares, that low levels of surface antigen are also important for that. In this study, what you can see on the right is that when they withdrew patients who've been on tenofovir for 4 years and then followed to see how many of them got ALT flares, they found that the group that had the lower level of surface antigen also had a lower likelihood of having the ALT flares. So putting all of this together, what's the strategy in terms of stopping nuke therapy? It seems feasible, but note that you do get the ALT flare, so you have to be monitoring patients very carefully. You need highly motivated patients and providers, and you got to be aware that there is some risk. The risk is that you get a flare and there could be some decompensation. And what I would say is that the surface antigen quant is your most important marker to tell you whether you can safely withdraw the nuke. And in individuals of Asian background, that level should be less than 100. The other thing that's been shown in studies is that there are some new biomarkers that I'm sure you'll hear more about at this meeting that can help us to predict who better can come off. And I'll just leave you with this last slide, which I think is very interesting. This is the apostle guidance on stopping nukes. And you'll see that in this guidance, they in fact recommend exactly that you would withdraw the patients who have a surface antigen level less than 100. They also say that on the far left here, that the surface antigen, if it's not under 100, but but under 3,000, that you could use the peg interferon add-on strategy. So they're using both peg interferon add-on and withdrawal strategies to get surface antigen loss. Thank you very much. This is my summary saying that we still have a ways to go. Nucleoside analog therapy is safe and highly effective. I've highlighted some of the emerging areas for 2023 with the gray zone patients and the strategies for functional cure. Thank you.
Thank you, Professor Nora, for a wonderful talk. And with that, we come to the end of this session. I thank my co-chair, Professor Natalia, and the chairpersons for this session.
Thanks. Thank you so much. For the next session on hepatology, may I please invite Dr. Ashok Chanduria, Dr. Paras Shah, Dr. Vijay Shankar, Dr. Amit Soni, and Dr. Vimal Sachdeva to please, Vimal Saradeva, my apologies, to please chair this session. I would also request Dr. Anil Arora and Dr. Dinesh Agarwal to please moderate this session. The adjudicators for this session would be Dr. Pankaj Gupta and Dr. Kapil Sharma. Due to the paucity of the time, I will also take the honor to invite the first speaker, Dr. Y.K. Chawla, to please begin with this session.
Dr. Y.K. Chawla will start the topic, the benign intrahepatic cholestasis clinical approach.
Yes, thank you very much. Thanks, Professor Rai, Sandeep, and the entire team for inviting me. And it's an interesting topic which is not very often covered. So I'm supposed to talk on benign intrahepatic cholestasis, a clinical approach. Yeah, so we know that the definition of cholestasis is whenever there is diminished or impaired bile flow generated by the hepatocytes and cholangiocytes. This results into jaundice, which is, if it is more than 2.5%, is a part of this. Occasionally, it's asymptomatic cholestasis. Pruritus happens depending on the completeness of obstruction. These patients develop fat-soluble vitamin deficiencies, and you can always identify extrahepatic obstruction with the help of imaging, and that basically involves the large bile ducts. But when we talk of intrahepatic cholestasis, it's the medium-sized bile ducts which are not picked up within the liver because of the imaging that we do. And this intrahepatic cholestasis could be either acquired or genetic. And whenever there is prolonged cholestasis, there is downstream damage to the hepatocytes by way of toxic bile salts, as we see in the conditions which I'll come to in a short while. So the pathophysiology of cholestasis, basically it happens in the post-hepatic stage. Pre-hepatic is Gilbert's hemolysis. Hepatic is when you have hepatocellular jaundice, and after that, when the biliary system is affected, that leads to cholestasis. And you have hepatocyte receptors and cholangiocyte receptors, which have transporter proteins governed by the genes within the hepatocytes, which permit the flow of bile into the bile canaliculi. So, as I mentioned, the causes could be acquired when there is inflammation and destructive condition of the bile ducts, and this is usually immune mediated with the presence of increased pro-inflammatory cytokines. We are all familiar with cholestasis that happens in viral hepatitis, and hepatitis A is the commonest that leads to cholestasis, but it can happen with hepatitis E, hepatitis B, and virus. Occasionally and very rarely in immunosuppressed with CMV, EBV, and herpes. But one thing I want the audience to know that viral hepatitis-induced cholestasis, usually on imaging, produces gallbladder wall thickening. and it is always confused by the radiologist as acalculous cholecystitis. And cholestasis either happens in very young or in elderly. The second most important cause of cholestasis is drug-induced liver injury. And when you look at the data of drug-induced liver injury, cholestasis is there in about 23 to 32% of all the deletes. And this could be because of acute or chronic, it could be mild or severe, and it's usually a diagnosis of exclusion. But one important criteria which helps you in diagnosis, if the history is not forthcoming, could be, and you press upon the patient to know about the history of drug-induced, is when you look at the ratio of ALT and alkaline phosphatase taking the upper limits of normal. If it is less than 2 at the peak of liver injury, you're likely to deal with drug-induced liver injury. Usually these injuries are idiosyncratic. These patients may have rash, fever, occurs 2 to 12 weeks after the taking of the drug, and or it can happen even 1 year after medication, and 50% of the patients improve in 4 to 12 weeks. Now, this is a long list of drugs which may lead to cholestasis, but one of the commonest ones that we all practice is amoxicillin clavulanic acid, INH, statins, and complementary and alternative medicine. And recently, we all must have come across, and we at our center have seen a number of patients who take bodybuilding supplements. And when you analyze these supplements, they have anabolic steroids, which is responsible for the cholestasis. But not only is this problem with drug-induced liver injury, when you take the chronic injury, it can lead to either vanishing bile duct syndrome, which may require a liver transplantation, or even sclerosing cholangitis, where you have a picture similar to that of primary sclerosing cholangitis, but only involving the intrahepatic with strictures and dilatations. And the culprits that have been reported in the literature are moxifloxacin, atorvastatin, again herbal and dietary supplements. Now, this intrahepatic cholestasis could also be because of the autoimmune diseases that we come across. Primary biliary cholangitis is not very common, but we certainly do see in clinical practice more often in females. They start with itching and later on develop jaundice, usually in the age range of 40 to 60 years. And we should all be familiar with the criteria that you take for diagnosing this. These patients should be mitochondrial antibody positive with the E2 subunit. But there is about 20 to 30% of PBCs who are AMA negative, for which a liver biopsy is required. Liver biopsy is also required if you want to differentiate PBC with another common condition like NASH, which may coexist. And the drug of choice for these patients is either ursodeoxycholic acid, or if the patient is not responsive, then obeticholic acid after 1 year. But also I want to mention here that if you pick up AMA in a patient with normal LFT but with vague symptoms, on follow-up almost 60% of these patients land up with primary biliary cholangitis. The second autoimmune phenomena that we also come across is primary sclerosing cholangitis. This is more often in males. The SMA, AMA, ANCA, these may be positive only in about 50% of cases. You do an MRCP, the extrahepatic bile ducts are well seen, the intrahepatic ducts may show dilatations, but biopsy would be required for the diagnosis of small duct primary sclerosing cholangitis, which only happens in rare situations in about 5% of cases. And you have classical picture of periductal fibrosis. These patients have to be treated symptomatically, the small bile duct ones, or they may require a liver transplantation if they've gone into a stage of cirrhosis and recurrent cholangitis. Now, overlap syndromes are most common amongst these autoimmune disorders, especially the overlap between autoimmune hepatitis and PBC. And there are different criteria which take into account both autoimmune hepatitis and PBC in combination. Liver biopsy is usually required. These patients have associated autoimmune diseases and they respond to ursodeoxycholic acid and steroids. The next group of overlap syndrome is the autoimmune hepatitis with PSC. Here again, liver biopsy is important and you would require to give these patients ursodeoxycholic acid with immunosuppressants, but ultimately they may require a liver transplantation. An upcoming autoimmune disorder which may lead to intrahepatic cholestasis is IgG4 cholangiopathy. It's uncommon, seen in 6th to 7th decade, but usually it has associated autoimmune pancreatitis. Isolated biliary is only about 10%. You may have retroperitoneal fibrosis, renal lesions, and sialadenitis. But the diagnostic parameter for these patients is IgG4 is more than 135, and a liver biopsy would show intrahepatic thickening of the bile duct wall, and these patients respond very well to steroids. We are familiar with alcoholic liver disease, alcoholic hepatitis. We all come across, but there is a group of alcoholic hepatitis patients who have cholestasis in addition. This happens only in 5%. When you do a biopsy, they have bilirubinostasis, and these are the group of patients which have a worse prognosis. Sepsis, again, is another common condition for cholestasis, where both either the gram-negative or gram-positive bacteria, through their endotoxins, tend to affect the membrane activity, nuclear receptors. Usually the bilirubin is between 2 to 10 milligrams, but occasionally, if it becomes very high, then you have to think of associated hemolysis or trauma. Other rare conditions like sickle cell crisis, hereditary porphyria, sarcoidosis, lymphoma by way of a paraneoplastic syndrome or vanishing bile duct syndrome also may be a presenter to cholestasis in our clinical practice. Amyloidosis, primary or secondary, total parenteral nutrition, more often in neonates, leads to cholestasis. Vanishing bile duct syndrome, seen with a number of drugs, you define whenever on liver biopsy you have portal tracts less than 50% with the bile ducts. That means there is bile ductopenia. These patients are treated with ursodeoxycholic acid and steroids and ultimately may require a liver transplant. And one very cholestatic condition known as fibrosing cholestatic hepatitis, which happens in the post-transplant situation because of hepatitis C, CMV, and hepatitis B virus through a direct viral cytopathic effect is associated with very high mortality, but responds very well to the therapy. You have some genetic disorders also which lead to intrahepatic cholestasis. We are all familiar with intrahepatic cholestasis of pregnancy seen in the 2nd or 3rd trimester, and you make a diagnosis when the bile acids are more than 40 millimoles. It has a good prognosis, except that there is stillbirth and preterm deliveries. A rare condition which again in clinical practice we do see is benign recurrent intrahepatic cholestasis. And this is because of different genes which get affected. You have definite criteria of BRIC, that is 2 episodes of jaundice separated by a symptom-free interval. Laboratory findings suggestive of cholestasis, normal cholangiography, and histology shows bland cholestasis. Progressive familial intrahepatic cholestasis type 3 may be seen in adolescents and adults, and this is another separate group of cholestasis which we are increasingly coming across. These patients have muscle wasting, growth retardation, and may ultimately require an early liver transplant. But in children, you have progressive familial intrahepatic cholestasis 1 and 2, which is associated with liver failure at a very young age. Algili syndrome, again a condition in children, may be seen, and this again requires a liver transplantation. And the other conditions are cystic fibrosis, alpha-1 antitrypsin deficiency, and biliary atresia, cholestasis that need to be thought of in children. So what is the clinical approach for these patients? One needs to rule out extrahepatic obstruction. There should be conjugated hyperbilirubinemia in most of the cases, but whenever the alkaline phosphatase is more than 3 times the upper limit of normal, think of cholestasis. Although the alkaline phosphatase may be from bone and it may cause a little confusion. These patients of cholestasis also have increased cholesterol phospholipids, but the GGTP helps you. The GGTP and alkaline phosphatase rise go hand in hand, but it is also raised in patients with alcoholism. So its specificity is low. 5-nucleotidase also tends to confirm whether the cholestasis is liver related or other conditions. You need to do viral markers, autoimmune markers, and you may resort to a liver biopsy to find out the etiology of cholestasis. We are all familiar with the manifestations like pruritus, increased cholesterol, which leads to xanthomas, xanthelasmas, and different vitamin deficiencies. And you need to treat these symptoms. But I would like to inform the audience that pruritus, which is a common condition, earlier on cholestyramine was considered to be the drug of choice. It is no more the drug of choice, it is rifampicin, which should be started in a dose of 150 to 300 milligrams per day. If there is no relief, stop it within 1 week, but do not exceed for more than 6 weeks if you have to give. Of course, there are a little bit of monitoring which is required. The other drugs which could be used in pruritus are fenofibrate, bezafibrate, naltrexone, UDCA, sertraline, cholestyramine. People have used plasmapheresis, nasobiliary drainage, and liver transplantation also because of the excruciating problems with cholestasis. And recently a new drug which has been tried in Alagille syndrome, maralixibat, which inhibitor, has been shown to be effective in these patients. You need to treat fatigue, hepatic osteodystrophy, hyperlipidemia, and these cholestatic patients are highly susceptible to infections, acute renal failure, hemorrhage, and wound dehiscence. So in conclusion, I would say that we do come across benign intrahepatic cholestasis, often in clinical practice. Imaging tells you how to differentiate it from extrahepatic, but for viral hepatitis related gallbladder wall thickening is something which one needs to look at. And children coming to us with cholestasis should be looked for progressive familial intrahepatic cholestasis, and we need to manage pruritus with rifaximin followed by the other drugs. Thank you very much.
Thank you, sir. Once again, it was a nice talk. Overview of intrahepatic cholestasis. Thank you, sir. Now I invite Dr. Ajay D'Souza for the Dean and NAFLD. Again, a problem of the country. D'Souza, sir.
Good afternoon, everyone. At the outset, my sincere thanks to the ISG Governing Council and the Rajasthan chapter of ISG for giving me this opportunity to be part of this CME. And I bring greetings to all of you from PGI, Chandigarh. So the job I have been asked is to speak on the lean NAFLD. All of us use this terminology, lean NAFLD, but we must understand that it's not NAFLD which is lean. These are the patients who are lean. So I think the better terminology would be to say, NAFLD and lean rather than lean NAFLD. I think that is the first thing. Then the second thing is when we divide these patients into lean, obese, or overweight, I think it's usually based on the BMI cutoffs. And the BMI cutoffs, for the Western are less than 25. And for Asian would be less than 23, would be taken as a lean NAFLD. Some studies do use a terminology called non-obese NAFLD, and non-obese would actually include the normal and the overweight together. And then there's a third terminology which is called the non-lean NAFLD. Non-lean means anything which is not lean, which means both overweight and obese will come into that. So without confusing you, I think as I said, there's some lacunae here. One is that NAFLD and lean would be a better terminology rather than saying lean NAFLD. And then as I said, it takes into account only BMI and doesn't, take into account various other metabolic risk factors, and especially the visceral adiposity, which is the main crux of fatty liver disease. So waist circumference is now taken into consideration. For those of you who are believers of this, new terminology of NAFLD, they say that if somebody is not overweight or obese and is not diabetic, could be called as lean NAFLD, but then they have to qualify 2 out of these 7 metabolic risk factors, and we actually try to look at this in our clinical practice, the applicability of these criteria, and we found that they are poorly applicable. Around 1,000 patients we applied these NAFLD criteria, and what we found is that in clinical practice, there does emerge, a group which is lean, which has fatty liver, but does not fit into this, and it's predominantly because we don't use CRP in our clinical practice, which is part of those NAFLD criteria. HOMA-IR, which is a measure for insulin resistance, is also not done uniformly all over. So I think we thought that probably this is not a good. So now I think this the inaugural guidance paper we'll be discussing more over the next 3 days, which is now available free online now. So there, I think we have now tried to adapt, and we've said that in addition to normal BMI, I think the central obesity should also be taken into consideration before labeling somebody as lean NAFLD. So going ahead, further after the definition, as I said, it's predominantly the issue is the metabolic health. You can have obese people who can be even healthy. You can have lean people who are metabolically unhealthy. So both ways it's possible. You can be lean with metabolically unhealthy, and you can be obese, as I said, and can still be healthy. So I think it's the metabolic health which is very, very important. So the first question, as I said, I will ask 3 questions: the prevalence, and then was the profile, and finally the management. So as far as the prevalence of this lean NAFLD is concerned, there are 3 ways of looking at this, prevalence. One would be people would look at lean NAFLD in general population. Second would be that you take only lean population and then see how many of them have NAFLD. And third would be that you take all fatty liver and then see how many of them are actually lean. So there are various ways, of looking at this, and maybe I'll show you data on all these 3. So this is again, there are lots of studies, and I picked up this meta-analysis which looked at this general population prevalence of lean NAFLD, and which is close to around 11%. But the message here is that of all the, all over the various continents and various countries, when they looked at this, Asians probably had a little higher prevalence when they look at the general population, maybe slightly higher than the Western counterparts. Now, looking at, suppose you choose the lean population. Again, there are studies like that. This is one of the older studies by Zoberi where they looked at a large number of overweight and obese people, and the prevalence of fatty liver is around 28%. And when they looked at only lean, around 5,000 of them, the prevalence of fatty liver was only around 7-8%. I think that's agreeable. So obviously, if somebody is lean, I think he is likely to have lesser chances of fatty liver in comparison to somebody who is overweight and obese. This study, which is, again, well quoted, around 10-12 years back by Abhijit's group from the rural West Bengal. If you look at this, around 2,000 patients, again, predominant inclusion, around 87% of them at the beginning were lean, or for that matter, even 40% were, or 47 were so-called underweight. The BMI less than 18. And when they looked at, fatty liver in them, it was only 8.7%. And that's how it came in that there's a lower prevalence of fatty liver, lean NAFLD, and everything started coming. But when you look at the study, when they started with the study, the group they had chosen was predominantly lean or even underweight, 87%. Now, as I said, this is another data from our, the Croatia group, the gut and obesity in Asia, what we have a consortium. So, there, patients with fatty liver disease were taken, and now I'm telling you about the prevalence of lean group within the fatty liver, and there we defined them as non-obese with a BMI less than 25, and the prevalence was close to around 30%, which is around 1/5 of them, they have a lean NAFLD. From India, they have a large many studies. Again, I think the time doesn't permit me to get into all those, but this is one study which had actually compiled the almost all the data from India, and the prevalence of lean NAFLD is close to around, I would say, 12-13%, but for that, Abhijit study. But the most recent data, again, if there are postgraduates here, I think which we need to know is this is the largest data, which we call the Indian Consortium on NAFLD data, which is an ICON-D data of more than 4,000 patients. And there we had a BMI available for around 3,500 patients. And look at this, the lean figures was close to around 11%. So I think you can just remember the figures of around 11%, which of all NAFLD would be so-called lean or the normal BMI. Now, the second question about their profile or about the severity of the disease, again, a lot many studies which have looked at the differences between the lean individuals and the healthy controls, but the more important would be the difference in severity between the lean NAFLD and those with obese NAFLD. And the overall data says that the patients with those who are lean, they have lesser chances of having histological NASH and its components, lesser fibrosis and liver stiffness measured non-invasively. In general, saying that yes, they have a little milder disease in comparison to their obese counterparts. And this has again been substantiated by lots of studies. The same study which I said, the Croatia group study, which I have just picked up, this is a recent study, which was around 1,800, biopsy-proven patients over around, 12 centers around 9-10 countries. And what we found was that of 20% those who were non-obese, overall, the prevalence of NASH and advanced fibrosis was lower in comparison to the obese group. But mind it, if these patients had metabolic risk factors, they could still have NASH and advanced fibrosis, which means that lean people can also have advanced disease, advanced fibrosis or NASH if their metabolic risk factors worsen over a period of time. But in general, as I said, their severity is lower than the advanced group. Now, what is their outcome, or finally what happens to these patients? I think in general, again, if you compare, there are two kinds of comparisons. One could be that you could compare these lean NAFLD with the general population, and this is one study, and hence data, where more than 5,000 patients, and what they had done was they divided those who did not have NAFLD versus those who had NAFLD. They are all lean. So in comparison to those who did not have fatty liver disease, patients with lean NAFLD, they had higher all-cause mortality, and predominantly cardiovascular mortality was higher in lean NAFLD in comparison to those who are lean but no fatty liver. So just presence of fatty liver puts you at a risk for overall mortality and especially cardiovascular mortality. Again, there is some conflicting data what happens to them over a long-term period, but then again, I think for the sake of time, I'm just showing you this one recent study which is published last year, which also showed that in comparison to again around 1,300 30 biopsy-proven patients with NAFLD, so lean was around 14%, and in comparison to obese, their histological disease was less severe in comparison to the obese. And when they looked at the outcome, the liver-related outcomes in the form of decompensation and HCC, and the extrahepatic events and the survival was no different between the lean and the obese group, which actually tells you that over a period of time, I think these patients can behave, but the outcome is almost similar to the obese NAFLD. Final, I think coming to the management of these patients, which is I think a very important clinical question which is asked day in, day out. So I think what we need to remember is that I think majority of the patients with lean NAFLD, even though their BMI may be normal, you will find them that they would be centrally obese and may have many other metabolic risk factors. So just based on BMI, I think probably it is not right to do that. So we need to take care of any of the risk factors that they have. And if they have NASH Or if they have advanced fibrosis on non-invasive assessment or on histology, they can also become candidates for, pharmacological treatment, I think, which is again not the scope for this talk. But then if you're planning to give them vitamin E or saroglitazar or bio, I think all these drugs can be used based on their entry point if they have NASH or advanced fibrosis or significant fibrosis based on non-invasive assessment. First and the most important, as I said, I think if you look at the pathogenesis in these patients is again, it's the insulin resistance and the visceral adiposity, which is the culprit even in lean effort. So they all have to be advised exercise in the form of, aerobic or anaerobic exercises, and maybe I think 45 minutes to an hour a day or at least 150 minutes a week. So that would improve their insulin sensitivity and would help them. So the last question which comes in that because their body weight is normal, can they be advised body weight reduction? So this has been answered by again few recent studies, and what they say is even though their body weight is normal, and if they reduce a small amount of weight, maybe just 5% of it, I think it's enough to improve their histological activity, and that has been shown to improve their NAS scores. And even, just 5% is probably good enough, and then there's no added benefit if you try to increase, 7% or more in that. So a small amount of weight reduction, even in the lean people, probably could also be encouraging and can improve their histological activity. And the same kind of data has been shown in another study, which looked at the regression and the progression of NAFLD in non-obese and obese people, and amongst the, a slight weight change within the non-obese group actually could improve their, histological activity. So I think a small amount of weight reduction probably could be beneficial in patients with NAFLD. So, ladies and gentlemen, let me summarize what I said in the last, 14 minutes or so, that lean NAFLD is a global phenomenon, but yes, Asians probably have a higher prevalence. And if you ask the prevalence of lean NAFLD in India, within the NAFLD, the largest data, which I said, is the ICON data, which tells you that around 11% of all our NAFLD are so-called lean by the BMI criteria. This is not taken into account the waist circumference of the others. In general, lean people with NAFLD would have a milder histology or a milder severity of liver disease. But in comparison to the normal people without fatty liver disease, they are at a higher risk of cardiovascular mortality and all-cause mortality. Long-term outcome in lean NAFLD is some conflicting data, but looks like that probably it is same as obese NAFLD, whether it's the extrahepatic events, cardiovascular, extrahepatic cancers, or whether these are liver-related events. Probably there is no difference. Once it comes to the treatment, I think it is the improvement of insulin resistance, and the exercise has to be advised in everybody. Small amount of weight reduction, I think maybe just 5%, probably may be good enough. And if you're planning to use pharmacotherapy based on the liver disease assessment, if you think that they have NASH or if they have significant fibrosis, same drugs can be used what you use in obese NAFLD. So thank you very much for your kind attention.
Thanks, sir, for the wonderful presentation on the leanness. It was excellent talk.
Thank you.
The next speaker for this session will be Dr. Anup Sarai on the guttural axis.
Good afternoon, everybody. And at the outset, I would like to thank the organizing team for giving me this opportunity to share my views on gut-liver axis. So what is this gut-liver axis? This is a bidirectional relationship between gut and its microbiota and the liver. And this reciprocal interaction is established by portal vein, which enables transport of gut-derived product directly to the liver, and liver feedback route through bile. The intestinal mucosal and vascular barrier is functional and anatomical structure that serve as a playground for interaction between the gut and liver. So these are the elements of barrier. In the lumen, you have degraded bacterial products, antigen by bile, gastric juice, and pancreatic juice. And in microclimate, you have various commensal bacteria, an unstaired water layer, and mucin. Then a single layer of epithelium followed by lamina and vascular barrier. So what are the key players in gut liver axis? These are intestinal motility, gut microbiome, barrier function, immune function, portal circulation, liver function, and bile acid circulation. So when there is a dysfunction, gut is leaky. What do we mean by leaky gut? There is increased intestinal permeability. So this dysfunction in CLD is multifactorial and depends on alcohol intake, portal hypertension, SIBO, infections, endotoxemia, immunological disturbances, medication, and dietary components. Whether intestinal barrier dysfunction is accompanied by functional or structural changes, this is poorly understood. Whenever there is alteration, then what happens? There is delayed orocecal transit time. So there is small intestinal dysmotility. This is more remarkable in cirrhotics with history of SBP, and this is more marked in advanced cirrhosis, that is in decompensated cirrhosis. And primary role of prolonged small intestinal transit is bacterial translocation in liver cirrhosis, and it is preceded by the appearance of bacterial DNA in serum and ascites. Colon transit time is shorter in cirrhotics, so they may have diarrhea. Then there is SIBO. This is also an important component. Then these bacteria that translocate in the small gut, the colonic bacteria, gastric acid, intestinal peristalsis, mucosal immunity, and biliopancreatic juice, they inhibit the occurrence of SIBO in healthy individuals. And delayed small bowel transit reported in cirrhotic with SIBO, which is related to abdominal pain and diarrhea. Antibiotics can shorten this prolonged orocecal transit time, and enhancement of orocecal transit time by taking cisapride is associated with inhibition of bacterial overgrowth in most patients. This is the normal gut barrier function. In fact, the outermost layer is mucus followed by a single layer of epithelium. Then there is area below this, that is submucosa, where you find many immune cells, and then the vascular barrier, which is breached in chronic liver disease. So what is gut microbiota and what is the role of it? It contributes to host homeostasis and modulate immune response, generate many metabolites. Depending on the diversity of human health depending on the diversity of this microbiota, the human health is affected by composition and function of this microbiome. If it is symbiotic, we have a different course of the disease. If there is dysbiosis, that leads to increased permeability, decreased mucus-associated defense, altered gut immune response, and then these bacteria and components, these metabolites, they reach to the liver, which acts as the second filter. And apart from metabolism, it is an important immune system also, having Kupffer cells, natural killer cells, T and B lymphocyte, stromal cell, and stellate cell. This lead to activation of these cells, lead to release of cytokines, chemokines, and matrix modulation, and ultimately to fibrosis. So how immune system is controlled by this microbiota? The first line of defense is, as I have said, is intraepithelial cells. They release cytokines expressing antimicrobial peptides, and then there are phagocytes. They send tryptophan to the lumen. They sense the antigen, and they carry and they convey this antigen to the antigen-presenting cells, which has a tolerogenic effect. And then they can identify between the self and means the normal food, which doesn't contain any harmful peptide, from those which contain harmful peptide, and mount a response. The second line of defense is lamina propria. It also has lymphocytes having CD4 cells. Some of them, they have Th17 type, and some are Treg cells. Treg cells, they recognize self-antigen and food antigen. And when there are certain cells which are harmful, then these red cells, they tone down the immune response by affecting CD4 and CD8 cells. So, intestinal barrier function is formed in response to microbiota, and the bacterial products like PAM, TEM, LPS can activate pro and anti-inflammatory cascade, and hepatic antigen presenting cells are central to tolerogenic nature of liver preferentially, and suppressing adaptive immunity by killing or inactivating T cells, inducing maturation of naive T cells into red cells, which inhibit CD4 and CD8 cells. So when the gut microbiota is altered, then what happens? This is the cornerstone of changes in the gut liver axis leading to disruption of barrier function, and this is commonly seen in chronic liver disease. Ethanol and high-fat diet have a direct effect on gut microbiota composition in alcoholic liver disease and non-alcoholic fatty liver disease. Elevated secondary bile acids, they lead to reduced intestinal FXR signaling, which compromise mucus and antimicrobial peptide synthesis and gut vascular barrier integrity. Ethanol also directly impairs synthesis of AMPs, and abnormality in intestinal microbiota impair the availability of energy substrate for epithelial cells, such as short-chain fatty acids. Consequences are loosening of epithelial cell junctions or tight junctions, mucus layer thinning, and reduced synthesis of AMPs, which results in intestinal inflammation featuring a Th1 type of pattern of immune injury. This is what we have observed, that in NAFLD and in alcoholic liver disease, microbiome is altered. There is increased number of barbiturates and decreased bacteriides in patients with alcoholic and non-alcoholic fatty liver disease. And there is also reduced alpha diversity. These are the microbiome composition and cirrhosis which we see. There are certain bacteria which are decreased and few are increased. Here I have listed these in this slide. The Proteobacter, Streptococci, Enterobacteriaceae is increased, and these are harmful bacteria. And Bifidobacterium, Lactobacillus and Pneumococci, these are decreased. So this is the list. In fact, various dysbiotic features which we noticed in various liver diseases. I have just mentioned this in the slide. When there are certain metabolites which are associated with chronic liver disease and liver cancer, these are also secreted or affected by the gut microbiome, like secondary bile acid, deoxycholic acid. It induces gut permeability by acting as a detergent and producing oxidative stress. It has a tumor promoting effect. Alcohol is also a gut microbial metabolite, and this is produced by certain bacteria, and around 3% of alcohol is produced by gut bacteria, and that can be an important cause of non-alcoholic fatty liver disease associated changes in the liver, especially fat deposition. Like short-chain fatty acids, a fermented product of dietary fiber, acetate, propionate, and glutarate. These are also having an effect on certain cells in the body. However, the too much production of short-chain fatty acid promote HCC through the early onset of cholestasis and hepatocyte death. TMA is again a gut microbial metabolite which is converted into liver into TMAO. This is an oxidized product which lead to folate deficiency and associated with lipid accumulation in the liver. So we measure intestinal permeability by various methods, and we have done this in cases of NAFLD and alcoholic liver disease by lactulose mannitol ratio, and we have seen that gut permeability is altered, intestinal permeability is altered in patients with NAFLD and alcoholic cirrhosis. These are the tight junction proteins which are there in the site of epithelial cells. So we have scaffolding protein, that is zonulin, and there are sealing proteins and pore-forming proteins like chlordin, oclidin, gem, and tricellulins. What we have seen that the expression of Claudin 3 is reduced in both NAFLD and ALD, and zonulin 1 expression is reduced in NAFLD. And then how this migration takes place? When there is dysbiosis, tight junction proteins are altered, expression of tight junction protein is altered, so that can lead to paracellular movement of bacterial product. There may be dysmotility, bacterial overgrowth, and that can lead to transmigration of these bacteria. So, translocation of bacteria and the product from leaky lumen has been recognized as major contributor to systemic inflammation in advanced cirrhosis and ACLF. And bacterial overgrowth challenges a hyperpermeable intestinal barrier with an overload of PAM and metabolites such as TMN in NAFLD and elicit liver inflammation. An extreme severity of intestinal barrier disruption is reached in advanced end-stage liver disease, that is decomposed cirrhosis. And at this stage, profound abnormality in microbiota on top of markedly damaged physical, immune, and vascular barriers lead to massive passage of not only PAM but also bacterial products causing systemic and liver inflammation. This is endotoxemia. Endotoxemia is also high. This is what we have shown. Then coming to alcohol-related disease, there is a direct toxic effect of liver parenchymal cell, and there is change in microbiota when a person is taking alcohol. There is decreased bacteriides and firmicutes along with lactobacilli. There is loss of intestinal barrier function. Zonulin expression is less, and Claudin 1 is also decreased. So, in alcoholic liver disease, the candida overgrowth is also seen, and B-glucan translocation can lead to activation of TLR on liver immune cells. So, tight junction mediated permeability may be regulated by local expression of pro and anti-inflammatory interleukins such as interferon gamma 6 and TNF alpha. This is the pictorial presentation of these stages which we have already discussed in NAFLD and in cirrhosis. So, during acute bleed, this is what we have shown, that even the gut barrier function is disturbed after the bleed, and more chances of transmigration of gut bacteria, and gut is leaky. These are the changes we have seen in gut barrier dysfunction after varicose bleed. IFABP is increased, and zonulin 1 is the expression is diminished. These are the histological means immunohistochemistry where we have shown Claudin 4 and Claudin 2 expression in patients with after bleed. Coming to role of bile acids, again, bile acids, they act through FXR receptors, and when FXR activation is inhibited, then there is increased bacterial overgrowth, translocation, and inflammation, which can lead to, and in liver, if FXR is inhibited, that leads to less synthesis of bile acids also. So, in nutshell, this is actually summary slide where I have summarized all the changes what we have discussed so far. There is change in gut microbiome, intestinal bacterial overgrowth, intestinal permeability is increased, intestinal antimicrobial proteins are also inhibited or decreased, the expression is decreased. Bile acid pool is also decreased, and secondary bile acids are seen more often. Intestinal bacterial metabolites, again, long chain and short chain fatty acids are decreased, and there is more translocation of bacteria and bacterial product in all conditions, including alcoholic liver disease, non-alcoholic fatty liver disease, and cirrhosis. I think I still have some time left. Okay, so we can target gut liver axis at various places, as we have seen that. Okay, thank you.
Thank you, sir. With this, we conclude the session and go for the next session. Thank you, sir.
Thank you, sir. And thank you, Chairperson. So, for the next session on gallbladder and biliary tract, can I please invite Dr. Satish Kulkarni, Dr. Sunil Gupta, Dr. Vidyadhar, Dr. Sushil Palodia, and Dr. Pankaj Shrimal to please chair this session. Can I also invite Dr. Amit Medio and Dr. Abhinav Sharma to please be the moderators for this session. The adjudicators for the session are Dr. Nitil Mehl and Dr. Kapil Gupta. Due to the paucity of the time, I will be inviting the first speaker, Dr. Anil Agarwal. So,
good afternoon. Yes, sir. Yeah. It's a pleasure to be here, and thank you, the organizing committee, for giving me this opportunity. And my brief is to talk about gallbladder cancer that have been improved in terms of the outcome in gallbladder cancer and what is the way forward. So I think we know that it comes in these different varieties. That is, when it is diagnosed after a cholecystectomy for a benign disease has been done for a suspected benign, or gallbladder cancer which is limited to the gallbladder. And then there is the advanced gallbladder cancer which infiltrates into the adjacent viscera. That may be the liver or the duodenum colon and the bile duct, leading to obstructive jaundice and vascular involvement. And what we need to, because I'm just setting the stage for that to rule out the metastatic disease, and with better understanding, we know that it is not just the distant metastatic sites, but distant metastasis also includes like interaortic lymph nodes, which would connote that probably it might not be worthwhile to resect these patients. So I think from the time when the gallbladder cancer itself meant nothing can be done, what have been the developments which has led to improvement in survival? That is, one is that early detection and accurate staging of the disease, and this has been partly also because the ultrasound is now everywhere, and probably in some of the cases you pick up early, and more accurate staging of the disease because of the improvement in the cross-sectional imaging, and it helps to detect metastatic disease, and proper patient selection and surgical planning. Because if you scan the previous literature, you realize that the results were dismal because some of the patients which were actually already metastatic were resected, and so obviously they had an early recurrence. And I think so it helped as we went along to identify that which are the patients which will not be benefited with resection and which are the ones we should take up for resection. And so detect metastatic disease in that interaortic lymph node and locoregional advanced disease, and avoiding non-therapeutic laparotomy by doing a staging laparoscopy and extended laparoscopic staging. And also there have been developments or advancement in the surgical techniques. I think as we understood it better, the lymph node clearance was better, extent of surgical resection was tailored to the disease stage, and making sure that it's oncologically adequate, but you don't do what is not required, which may add to the morbidity but may not have a benefit in terms of the outcome. So I think in that regard, I would just talk about the limited gastroduodenal resection rather than doing a pancreatic duodenectomy with a radical cholecystectomy, preserving segment 4A, which gives extra liver tissue, especially in obstructive jaundice, and also because now there are techniques to increase the future remnant liver, and resection of locoregionally advanced disease can be done with advancement in the techniques and postoperative care. And of course, the neoadjuvant and systemic chemotherapy, adjuvant chemotherapy has led to improvement in survival. So I think if we look at this paper, which was an analysis, I mean, it came out in 2009, Japanese literature, and if you see that even though this was the earlier staging, but even in T4 stage, there was 14.1 and 19.2% 5-year survival. And I think what we have to look at is gallbladder cancer. Every time people were talking about 5-year survival, I think this is one disease which was thought of as a very dismal disease. So even a meaningful 3-year survival was reasonable. And actually, if you see, there was a realistic approach towards gallbladder cancer because we operate a CA pancreas and do a Whipple's, with accepting a 15 to 20% 5-year survival. But I think in gallbladder cancer, somehow that nihilism was there. And even if you see the lymph node positivity, even with distant lymph nodes, there was a reasonable survival. And not only that, that even stage 4, which was advanced gallbladder cancer, you realize that there was improvement in survival. That may not be as much as for limited disease, but there was. And so I think just coming to the protocol which is there and diagnostic laparoscopy, I would focus on the diagnostic laparoscopy and interaortic lymph node in this. And earlier studies the pickup rate of diagnostic laparoscopy was very high, and that was because those studies were conducted at the time when the imaging was not that advanced. And actually now in the recent past, if you see, the yield is 20% or so, because earlier, because otherwise if you look at the previous studies, it was even more than the resectability rate. So this is one of the papers that we analyzed our 409 patients, and we realized that the yield was more higher in locally advanced tumors, but it was also there in early gallbladder cancer, so you could avoid doing a non-therapeutic phlebotomy. And this is a paper that we talked about in the interaortic lymph node. This was the time when we were doing open resections, and we realized that about 18% of patients we could have avoided had we done had we known beforehand that interaortic lymph node was positive. And so what we started doing was that we started doing staging laparoscopy. We included doing the interaortic lymph node. That is the area from where the interaortic lymph node, just below the renal vein and between the aorta and the cava. And subsequently, with the help of earlier with Dr. Pramod Garg at Allergy Institute, we started doing EUS assessment of the interaortic lymph node, and subsequently by Dr. Puri, Dr. P.C. Sharma, Dr. Siddharth and their team at our center. And we realized that we could access this region and be sure even before taking up this patient. So you could actually, instead of, you could avoid even a laparoscopy in some of these patients. So I think as we understood better in the gallbladder cancer, limited to the gallbladder and advanced resection, it was made better advancement led to the, like this concept of venous drainage of the gallbladder made one realize that what segment 4B5 would also probably address the issue of micrometastasis. And so you do a segment 4B5 resection and lymphadenectomy. Again, this better understanding led to us to realize that interaortic lymph node and to the left of celiac would be advanced. And earlier on, some people thought that retropancreatic also probably should be put in the same basket. But the Japanese literature showed us long-term survival in that group. So I think you take care of all these groups of lymph nodes, and this is what you should have after the resection. And also you realize that though some centers advocated that excising the bile duct as part of the radical cholecystectomy, but it was realized from various centers that it adds to the morbidity but does not improve survival. So it is limited more to some of such cases, like, you know, as you can see in the bottom, this one, the choledochal cyst, or there is a papillary tumor inside the bile duct. So I think, what about the adjacent viscera? And in that, as when I showed you in the previous slides, that you could do a limited resection which was oncologically adequate, but with limited morbidity. And so, like, if there was a limited involvement of the duodenum, you could do a sleeve resection, or what was distal gastrectomy and D1 resection rather than doing an HPD. And this is one of our papers in which we talked about with duodenal infiltration when we started doing a limited resection with reasonable survival. And colonic involvement, you can do the same with a segmental resection or even a sleeve resection. And when both are involved, like in this patient, and this patient survived about 3 years, and he did not take adjuvant treatment which he was advised. This was a young person. And you can also extend that resection to adjacent diaphragm, colon, and duodenal resection. So HPD, this Kondo group showed that whether you do a limited pancreatic resection or you do an HPD, the results are comparable, because most of the time it is the upper outer portion of the pancreas which is involved and which is not infiltrating into the ampullary region, so you could get away by doing a limited resection. And in some cases you will need a more extensive resection, either because of involvement or with the tumor or because of vascular involvement. Of course, we take the help of our endoscopy colleagues and the radiologists to bring down the bilirubin, increase the FLR, and then take up these patients for resection. And this is one of our patients this was probably the second patient that we operated, resected, and which survived about 12 years. And so you have to tailor the approach. You can do a limited resection as a segment 4B5 even with jaundice, or you can do an extended right. And as you can see in this slide, you have retained the 4A, which adds that extra liver tissue, which reduces the liver failure risk. So this is a paper that we had published, that when we analyzed our 14 patients, this patient was included in that group, and we realized that one can resect in these patients and leads to a meaningful survival. And subsequently, there was a larger series from Professor Nagino group, and in which you can see that they had a pretty reasonable, though this paper, that 70, and they wrote it as gallbladder cancer involving extrahepatic bile duct is worthy of resection. And I think this is now settled that you should operate and resect whatever is resectable, even in gallbladder cancer with jaundice. And you can see in this table also within reasonable morbidity and mortality. And similarly, for vascular involvement, you can either do a vascular reconstruction or do an extended resection of extended right hepatectomy, which is modified to preserve the segment 4A. And just to take you through one of our studies that we analyzed our experience from 2006 to 2012, and 327 patients underwent curative resection in this, and this is the breakup of the various resections which were done and the demographic data. And just to show you that in our study, 57.5% was the resectability rate. But if you had not gone ahead to do an adjacent visceral resection, that would have dropped down to 37.6%. And actually, the other notable thing is that not many of them, not in all of them was there a transmural involvement, and they would behave similar to if they were not involved. So I think the bottom line was that if you can do the resection within reasonable morbidity mortality. And in this, we had shown that, yes, certainly the extrahepatic organs, if there were 2 or more involved, the survival reduced, but with no lymph node involvement, it is comparable. So this 2, 3, and 5 year survival, as you can see, was 81, 24, and 10%. And this is comparison with the bile duct versus duodenum versus colon involvement, and the survival was 85, 27, and 9%. And just, I think I'm running out of time, so I'll just take you through that. Is the same thing possible by minimal access approach? Because now I think the world literature talks about that you can have a meaningful good survival in gallbladder cancer with open approach. And the concerns were because one of the things was the port site metastasis, which prevented this progress of minimal invasive surgery in gallbladder cancer. And this is one of my dear friend, Professor Han from Korea, who showed to the world that the port site metastasis did not occur in their follow-up. And this series paved the way for the world centers to take up to gallbladder cancer to be operated by minimal access approach. And this is one of the consensus statement in 2016. And almost all centers which had done at that time more than 10 radical cholecystectomy laparoscopic were part of that. And you can see that you can do the same. This is one of our patients, segment 4B5 resection and lymphadenectomy. The same way can be done. And if you see, actually scan the literature, there are some series like the Shirobe series. In fact, more than 10 years ago, they had been doing that, and with a long-term survival, which is pretty feasible. And Professor Han again in the 10-year follow-up had shown this good survival. And this very nice paper of meta-analysis laparoscopy surgery, one of our papers is there in that, with early gallbladder and a systematic review. And so operative time was higher, but retrieved lymph nodes, recurrence rate was comparable, and overall survival was also the same. And if you see this tabular form, 30 to 80 patients in various series, and one of the meta-analysis of 235, we have compared it with our present study of 173 patients, which was some time ago. And now it is 210 patients. This is in a tabular form, 179 patients which we operated. And out of this, 5 patients were robotic radical cholecystectomy, and the others were laparoscopic radical cholecystectomy with reasonable, no port site recurrence and reasonable survival. So this is to the extreme left is now an 11-year survival of our laparoscopic radical cholecystectomy. And Professor Han again showed that oncological equivalence is there from various studies in the world literature. And besides that, in the oncological advantage, there's other advantages are well to see. You would not have a patient standing like this on day 1 post-op. And same thing can be done for adjacent viscera. This is a small series that we published, and I think this is probably the largest series of adjacent viscera being dissected by minimal access approach. This had only 11 patients at that time. So I think the 5-year overall survival based on AJCC 8 is also reasonable, and we hope that in times to come with advancement in not only the surgical techniques and the care, and also probably the adjuvant treatment and targeted therapy, this is just a representative slide. Probably we can have improvement in outcomes. So I think we just finishing time. Thank you very much.
So thank you, Dr. Agarwal. I think we'll have question and answers if any time is left at the end of 3 lectures. So if the next 2 speakers make up for some time, I think we will let some time. So I'd like to invite Dr. Randir Sood to talk to us on a very important topic, that is prevention and management of post-ERCP cholangitis, which is one of the most dreaded complications of ERCP.
Thank you, Amit, and first of all, I must thank the organizers of ISG Con for inviting me here. Well, we often discuss post-ERCP pancreatitis and post-sphincterotomy bleed. Hardly ever we discuss post-ERCP cholangitis. As Amit mentioned, it is a very important aspect and we often ignore it. The transient bacteremia happens in almost 1/4 of the patients where we do ERCP, particularly in jaundice patients. But cholangitis happens in less than 1%. And this was a large retrospective analysis of nearly 17,000 patients where cholangitis incidence was noted to be 1.4%. So it's not very common. It's somewhere equivalent to where the risk of bleed is. But incomplete biliary drainage is the most important risk factor when we talk of post-ERCP cholangitis. And a prospective study of 242 patients finding the incidence of cholangitis clearly showed that if you have done the incomplete drainage, almost 75% of the patients will develop cholangitis. On the other hand, only 3% patients after complete drainage will have cholangitis. So this is extremely important thing which we must keep in mind. And patients who are immune suppressed, like patients of liver transplant or patients who have other immunological disorders, they are taking immunosuppressants, will develop cholangitis even after complete drainage. There are certain technical issues like the occlusion cholangiograms and overfilling the ducts, which you should avoid in these patients because there's a cholangiovenous and cholangiolymphatic refluxes which happen, which cause septicemia. And commonest bacteria grown are E. coli, Klebsiella, Ephesium, and Pseudomonas, and Enterococcus. There are endomorphs grown, but possibly they are not responsible for cholangitis. They are, they simply occur along with the other coliform bugs and get treated with a regular medication. Now, why does it happen? See, normal mechanism to keep the biles dry is mechanical barrier provided by nature, which is sphincteropodi, and continuous flushing by the bile, which is a mechanical action. And bile acids themselves have bacteriostatic action. There is also secretory IgA and biliary mucin, which prevents bacterial adhesions to the native bile duct. Problem is that when we interfere with that nature-given physiology, and so we do sphincterotomy, we break the mechanical barrier, we put in transdural stents, so we put in foreign bodies, and this promotes duodenal-biliary reflux. And these polymer stents actually promote bacterial adhesion and biofilm formation inside the lumen, and that leads to proliferation of bacteria inside the stents. And biliary obstruction per se causes raised intraductal pressure, and this leads to certain physiological changes. This is cholangiopapillary and cholangiolymphatic reflux. Along with that, even the Kupffer cell dysfunction happens. The secretory IgA inhibition happens, and the bile flushing, of course, becomes ineffective. Now, before I go on to ERCP-induced cholangitis, because this is a postgraduate course, you should get familiar with the Tokyo guidelines for diagnosis of acute cholangitis. You know, in 2007, there was a group of experts who met and formed guidelines for diagnosis, for establishing severity of cholangitis, and certain guidelines for treatment of cholangitis. And this was reviewed in 2013 and then now in 2018. So the diagnostic guidelines are 3 factors: systemic inflammation as evidenced by presence of fever with chills, lab markers indicating either leukocytosis of more than 10,000 or less than 4,000 leukopenia, or CRP more than 1 milligram. Features of cholestasis on like jaundice of bilirubin more than 2 or lab markers showing a rise in ALP, gamma GT, AST, ALT of more than 1.5 times the upper limit of normal. And of course, substantiated by evidence of bile duct dilatation and evidence of resection by stone or tumor on various imaging techniques. And Tokyo classification of severity, which shows the mild acute cholangitis, is that if none of the moderate and severe factors are there. So what is the moderate severe acute cholangitis? Cholangitis with this evidence of at least 2 of the following criteria. Either there is leukocytosis or leukopenia, fever more than 39 degrees, if patient is elderly, patient has jaundice more than 5 milligrams or bilirubin of less than 2.5 grams per deciliter or 2.25 grams per liter. Severe acute cholangitis is when this is acute cholangitis is associated with organ failure, like shock requiring vasopressors and clouding of consciousness, pulmonary failure, renal failure, hepatic failure, or coagular failure. Now, in clinical scenarios, we diagnose cholangitis with the classic Charcot's tract, which is pain, fever, and jaundice. And if there is mental confusion and hypertension, then we call it Raynaud's pentair. The typical tract, unfortunately, happens only in about 20% to 50% of the patients and is not universal. Fever is the most common feature, which happens in 90%, and pain in 70% of patients, and jaundice in nearly 60% patients. So don't ever think that patient does not have cholangitis if there is no jaundice. Particularly in post-ERCP cholangitis, if there is a new onset of upper abdominal pain, there is new onset fever after the procedure, leukocytosis, and increase in jaundice, consider that it is cholangitis. Some patients, particularly who are elderly or immune suppressed, will merely present with falling BP and drowsiness. Consider that it is cholangitis unless proven otherwise. The risk factors for post-ERCP cholangitis are combined percutaneous and endoscopic technique, which is the endo procedures, stenting in malignant obstructions, particularly hilar blocks, the presence of deep jaundice of more than 10 milligrams. Primary sclerosing cholangitis is a unique situation where, because of the multiple strictures in the intrahepatic ducts, there is a risk of cholangitis very high because of during the procedure, almost 17%. I'll come to that. Low case volumes in a center, and incomplete or failed biliary drainage. I am not mentioning, of course, the scope hygiene and the use of reuse of devices. Post liver transplant patients where ERCP is done are particularly at high risk. Now, Peter Gordon's study is published is that of 11,484 ERCPs over 11 years. This was a retrospective analysis, and there was a decrease in incidence of cholangitis in the first half of that study period to second half because of improvement in scope, reprocessing techniques and single-use devices. And of these, majority of the cholangitis were mild, and only 2 were severe. And again, risk factors identified were post-liver transplant patients, previous biliary interventions, and hilar strictures. So, two group of patients, liver transplant and hilar strictures, are evident in all the studies. Unfortunately, in India, the incidence of cholangitis is very high. Overall, was 17%, and Mohandas did a survey, and in malignant blocks where ERCPs were done, the cholangitis was more than 30%. And this was definitely related to scope hygiene, the use of devices, skill and awareness levels, and malnutrition. In fact, there was a time I remember that when I used to say that doing a ERCP in a hilar block is like inviting cholangitis, and we were looking for strategies how can we reduce it, and whether now can we prevent cholangitis in this group. Prophylactic antibiotics, this was the commonest intervention. This is the analysis of Peter Gordon's group itself, where they showed that whether you give antibiotics or not give antibiotics did make a very little difference in routine ERCPs. And antibiotic prophylaxis expected to work. 2 meta-analyses failed to show advantage of routine antibiotic prophylaxis before ERCP. And one Cochrane review in 2010 showed that in routine antibiotic prophylaxis, given in patients with normal risk does nothing and should be reserved only for high risk individuals. And we usually give it to patients with hydro blocks or patients of liver transplant, or where we anticipate patient to undergo ductal lithotripsy, whether mechanical or endoscopic, so that because we think that irrigation and repeated filling of the duct does lead to increased risk of cholangitis. ASG recommendations in 2021 are antibiotic prophylaxis should be considered before an ERCP in patients with known or suspected biliary obstruction in which there is a possibility that complete drainage may not be achieved at the ERCP, such as in patients with high stricture, primary sclerosis and liver transplantation. The hydral drops I have already mentioned, and this is one area we should be very wary of, that this impacts significant decrease in overall quality of life in these patients develop cholangitis, because you will need drainage by ERCP or PTBD route, and this will prolong their hospital stay and antibiotic use and cost of treatment. And not only that, that will either delay or definitely make them unfit for definitive treatment. This is one of the studies done in 1998, the CHANG, which was a retrospective study of 141 patients, where they divided them into three groups. Group A, where one segment of the liver was opacified and drained, where there was survival was 145 days, cholangitis incidence was 6.3 days, 3%. Group B, which was 225 days survival with no cholangitis, with both the lobes were opacified and drained, and Group C, where there was filling was done with both the lobes, but only one could be drained. So if you leave undrained segment, this is very bad. And what we actually did in 2000, from 2005 onwards, we started using air or carbon dioxide instead of contrast to opacify bile ducts, and we showed the success of this strategy in our paper in 2010, and this is how we did it. And now we have got 2 randomized controlled trials and 2 retrospective studies which show low risk of cholangitis with air or carbon dioxide use instead of IV containing contrast while doing therapy in hydro blocks. Post ERCP cholangitis and PSC, again, as I told you, is the incidence of 30-day cholangitis odds ratio was 3.26. So definitely a high risk population. In liver transplant patient, like this patient, after LDLT, you see that there are multiple segment strictures which you need to drain all, unless otherwise you will get cholangitis. There is a meta-analysis of 14 studies of more than 3,000 patients in a DDLT situation where there is no increased risk of cholangitis. However, in LDLT, where nearly 446 patients, there was 8.3% incidence of cholangitis. So this is a group of post-liver transplant patients where we have to be very careful. There is another strategy which can be used to decrease the incidence of cholangitis. This is the intraductal placement of plastic stents, where the other end is left inside the CBD without any phlebotomy. And Japanese do it very often for their patients of liver transplant. And we have started using it by using a lasso at the rear end and using a shorter stent. And this leads to much less incidence of cholangitis and prolonged patency of the plastic stents. Now, how do you manage? It is basically supportive treatment by hydration, vasopressors, correction of coagulopathy, antibiotics, and antibiotics initially in the beginning, you will have to use broad spectrum, particularly carbapenems and vancomycin, or tazobactam piperacillin plus vancomycin, and narrow it down when the culture reports are available. Always before you intervene, take a bile culture. And bile biliary decompression is very important for source control. And CBD store disease, you have to decide whether you should drain or just to do a complete CBD clearance. ASG guidelines say it is preferable to clear the CBD rather than just stenting it. Decompression alone is in coagulopathic patients or on antithrombotics, or those who will need anticoagulants immediately after the procedure. You can do only decompression and do the completion later on. Need to leave a stent or not after clearing the CBD? There is no answer. but we do it in case we are not sure that we have cleared the CP. Do not do occlusion angiogram if patient has cholangitis or patient had earlier intervention. In distal blocks on plastic stents, change from to fully covered metal stents to self-expanding metal stents depending on the etiology, and partially drained hilar blocks do either ERCP guided drainage or preferably PTPD if the segment is certain segments are undrained. There will be 5 to 10% mortality and depends on the severity of cholangitis, and factors influencing the outcome will be early diagnosis, response to antibiotics, underlying biliary disease, and comorbidity. Bad prognostics are if patient presents with hypertension, AKI, cholangitis, or the basic disease, or patient has organ failure. Thank you very much.
Thank you so much, sir, for enlightening us. For next session, I invite the DS Chandrasekhar sir for a very vital topic, post-cholecystectomy biliary stricture. He is a versatile person going to help us in how to overcome these challenges.
Take a quick 1 minute. We will be having the working lunch, so I would request the support team to please begin the distribution of the lunch. Thank you.
Dear moderators, Pramit and Abhinav and Chairperson, thanks for the invitation. It's a great honor to be a faculty in the ISG call, and I bring warm greetings from Chennai. Management of post-cholecystectomy biliary is such an important topic, and I predominantly deal with the leak. I'm mindful of the lunch. People are waiting here to listen. You know why? It is a leading source of malpractice claims against surgeons and endoscopists. In the early 90s, laparoscopy was very popular cholecystectomy, and I used to get almost 2-3 cases a week. I used to see that the moment I demonstrate the continuity of the bile duct, I used to see the tears in the eyes of the surgeon as I demonstrate bile in the intestine. And any surgeon, best of surgeon, around 34 to 49% of the surgeons are expected to cause such an injury during their career. That's what famous legendary Sachin Tendulkar said. I scored a century and one innings, and next inning I may not score anything. So each ball has to be treated with concern, concentration, and comfort. So every case, otherwise it increases the morbidity and mortality. And such an important topic as suggested, reduce long-term survival if you do not manage properly and quality of the life also. Now, it can be as simple as a low-grade cystic duct stump leak, which you can manage easily. It can be high-grade cystic duct stump leak, or it can be associated stone which you need to remove it and block the seam, or can be devastating like complete transection. You had it. Or there can be a chronic stricture developing ischemic stricture, the common hepatic duct stricture. So far, so good is all very common. But what you don't understand sometimes is right hepatic radical bile. You keep doing procedures, nothing happens, keep on leaking, or it can be a duct burst. So that means you need to have a thorough knowledge about the anatomy, anatomical variation, and it can be detected intraoperatively in 25% of the cases, post-operatively 78% of the cases. Let's look into the intraoperatively. You have a great surgeon who really identified and in injury recognized. There are two options. If it's a liver transplant surgeon, liver resection surgeon, and he identifies it, he can be primary repair. The word of caution is high incidence of failure can happen. Percutaneous or endoscopic balloon dilatation may be needed. Or you allow them to heal, put a drain and primary and safety. It's a highly surgical, but if you have a combined medical surgical unit, really the management becomes much better. If it is post-operative, most of the endoscopists in the audience, and no urgent laboratory. Biliary reconstruction in the presence of peritonitis results in statistically worse outcome. I think many of you manage post-operative leak, biliary leak. You have to save the patient, protect the surgeon, and bring the results very good. And reconstruction of the biliary tract is best performed electively after an interval. They want some dilatation of the duct before anastomosis, and the inflammation, scar formation, development of fibrosis takes several weeks to subside. Now, most important, you just see this slide, you will know that as a kind of bustling activity like T20 cricket match. At one time, you have to see the hemodynamically, you have to establish the patient antibiotic and ultrasound guided biliary drainage, the xylem or drainage. All this you need to be carried out immediately, otherwise you may lose a patient. Stabilize, resuscitate, all this things done, blood transfusion is needed, otherwise ERCP cannulation can be very difficult. So this is just to show that how important pre-operative. The moment you start cannulating, and if this biloma is there, can be compressing, cannulation can be difficult. Now, I just draw the attention of this. One thing should be on the table top is there are so many classifications. The Strasberg classification, the one which will identify you that the leak from the cystic. Most of us are very familiar. You are lucky, surgeon is lucky, patient is lucky. But like from the smaller ducts also okay. But if you have the aberrant posterior hepatic duct, you need to have the very, very clear anatomy, then start leaking or get stenosis, then B and C, and lateral injury of the common bile duct. And if this A and D can be managed endoscopy, it should be very, very clear what type of what type of injury has happened in a given patient. This is like akin to that beyond 2 centimeters there is an injury, transection, or within 2 centimeters, confluence, and all this is almost like dismal malignant classification. This is classical classification. If you do not apply this classification, you will be all cases you will be doing endoscopy, or all surgeons will be operating all type of cases. So which one needs to be? I just want to tell you the criteria of this classical classification. The one in the pink color is the one under for endoscopic treatment. Rest of them may do endoscopy to save the patient, to buy time, and to reduce the cholangitis. Then you have to submit it to the surgery, mostly to the surgical. So we need to have that. Now, how to establish the concept of this topic is, I'm going to tell you some case snippets, which would really tell you that the case snippet of low output cystic duct leak, high output cystic duct leak, CBD lateral duct injury, and CBD stricture or common hepatic duct stricture. There are most important thing is to identify the rare presentation. I recently had 2 cases where right posterior duct anomaly and very low insertion of the cystic almost coming to the level of the ampulla of Vetter and duct of Bushra. Let's do the common presentation. This patient had biliary ascites, peritonitis, septicemia. We controlled it, and there was a low bleed. We placed the stent, and he was comfortable. He went home happily, and there's no problem. This is how most of us will come across. And another patient, continuous high put bile leak was there. As usual, we placed a plastic stent. And the patient continued to have 300 plus ml even after a week. Then what we placed the fully covered metallic stent that also will be no leak following the fully covered stents. This is another presentation, you may get it. So when you have very high output leak, better to go for the fully covered. And there are other minor leak can be managed with glue injection. I have not tried this angiographic coil, combination of glue and coil, and can do either a ERCP or percutaneous. Now this is the pattern. If you get it, if it is beyond in the type 1, there is a injury there, we can place multiple plastic stent or maybe fully covered. I will not go into a debate which is better, but both works out very good. But if you want only one intervention, then I'll go for the fully covered one. And this is a devastating, total transection. Boom. So you go for the PTBD and demonstrate this, and the patient goes for the early surgical intervention before the patient develops biliary cirrhosis. Very important. Make sure that enough dilatation, the surgeon is comfortable. Now coming to the rarer presentation.
This one thing should be on your tabletop. I just want to follow you this to this. This is right posted that arises from the right that comes like that, and 5 and this is 6 and 7 segment, and right anterior that is 5 and 8 segment. You have to be very, very thorough. Anyone doing biliary intervention, surgeon, endoscopies or radiology should be very clear about this. And this is segment 3, 2 and 4 and 1. Okay, this is what cystic does. This is what is normally in 85% of the patients. Type 2, the right posterior arising the bifurcation, and right posterior duct is the only anomaly. It arises in the left duct, and 3B is arising the common hepatitis duct, and you see the 3C right posterior duct is arising from the cystic duct, and this is very devastating. Whole entire right duct system is arising from the cystic duct. If I happen to touch here, then you have it. This is what I think. This is the very nice by the Korean authorities. This one case recently we had, you just see this occlusion cholangiogram. Initial stenting did not improve the patient, and you see this in the left, right anterior duct, right posterior duct, segment 6 and 7. It is draining from the cystic duct. The surgeon had injured this area, so it has got the tendency to have this. This patient went into stenosis of initial stenting. This patient did improve from cholangitis, but because of the continuous inflammatory activity, went into stenosis, and whole cholangitic abscess happened in the right area, right lobe. She had to undergo hepatectomy, right side hepatectomy, right hepatectomy, had to undergo. And very low insertion at the level of ampulla, the patient started having a biliary leak after the cholecystectomy. Plastic stenting was done. But what happened, plastic stent, because of the duodenal contraction, used to have a more amount of drainage into the duodenal fluid started coming. So what we did is replace the metallic stent fully covered. The patient improved a lot and went home. So this is where I just wanted to tell you that the rarer presentation also. This is just to show that video how we managed to do this. And this is the very low insertion. Low insertion up almost level of the ampulla operator. So and we placed the metallic stent. The patient did beautifully. After we failed with the plastic stent. So this is to impress upon you that you need to know that anatomy, anatomical variation of the a ducts of Dushka, a small ducts originate from the right hepatic lobe, posting along the gallbladder fossa and usually drain in the extrahepatic biliary duct. And injuries to this, the second most common cause of post-polycystic biliary. And I will not go to the details. This is all very type 1, type 2, type 3 type. Second, I just want to tell you that duct of Dushka, the damage can be the second important cause, and mostly it is managed with drainage or ERCP symptotomy. Rarely you may need a real laparoscopy, and simple drainage with a low volume leak will be very good. So this is about, having said about that, what is the point to be done? Resuscitation is the key, control the sepsis. Biloma drainage quickens the recovery, categorize the type of biliary injury, identify the site, level, type, and magnitude of the leak. Very important. Where is the site? What is it? And multidisciplinary management of leak is very important. You need to have a team gastroenterologist, radiologist, surgeon. And the most important thing is if you have a mismanagement, lifelong disability and biliary cripple. And I've seen patients with being and biliary cripple also results of operative repair excellent in this specialty center. You must call that thing. And this is very important. You should recall now. Type A ERCP symptotomy and stenting. Type B also restorative, mostly surgical, and beware of congenital variants and complex biliary anatomy. More extensive damage, you must have licensed surgeon to manage this. I thank you very much for this wonderful opportunity. Thank you.
So thank you so much, Dr. Chandrasekhar. Excellent talk. Very nice 3 lectures. I'm told by the organizers that there are no question and answers in the CME program. Thank you so much to all the chairpersons for embracing the occasion and being here. And let's go on to the next session.
Thank you, sir. For the next session on pancreas, may I please invite Dr. Rohit Gupta, Dr. Gursevat Singh, Dr. Nimesh Tarbai, Dr. Rahul Jain, and Dr. Dinesh Singla to please chair this session. Can I please also request Dr. Mahesh Goenka and Dr. Harsh Rawat to please moderate this session. And for the adjudicators, we have Dr. Mohan Babu Goyal and Dr. Kandar Saxena to please attend the session. I would also invite the next speaker, Dr. Anil Arora. Can I please request you? I would also request all the speakers to wind up their talk in 12 to 13 minutes as we are running a little late. Thank you.
Good morning, everybody, and I'm extremely thankful to ISG Con Jaipur for giving me this opportunity. The topic which has been allotted to me is first 72 hours in acute pancreatitis, do's and don'ts. As compared to the practice of cardiology and the practice of neurology, where God has given us only limited time to recoup either the acute MI or the stroke, we in gastroenterology are lucky to have 72 hours to fiddle around with our armamentarium so that we try to prognosticate our patients better. So as soon as the patient is wheeled into the casualty, it is the duty of a gastroenterologist to make an attempt to try to characterize the pancreatitis as either mild, moderate or severe. But the problem is, how do we assess the severity right at the time when the patient ends up in the casualty? We do have cumbersome and difficult to memorize these scoring systems called Apache 2 and ransoms. So I put it specifically that we don't use them in casualty. Ransoms will require typically 48 hours for assessment. So the tool which is left to the clinician is availability of BUN and hematocrit, which guides you to the presence of this moderate or severe pancreatitis. So a combination of simple to major tools like BUN, hematocrit and BISAP will give you an excellent information about the type of pancreatitis which you are going to handle. But all said and done, ultimately it boils down to astute clinicians, and I'm sure this hall is full of these astute clinicians who, even without batting an eyelid, will be able to tell you this is the guy who's going to have a bad prognosis. So what this entails is a combination of the SUS, a high hematocrit, raised BUN, and concomitant morbidities like advancing age, pleural effusion, multiple comorbidities, etc. So if this patient has any of these, then you do not look at the prognostic criteria like Apache or ransoms. All clinicians know that this is the patient who is going to land up a problem. Typically, we do not do CT in the first 72 hours because unless the patient has a diagnosis which is in doubt, or if the patient's condition clinically fails to improve after 72 hours of stabilization. In the casualty itself, we need to have a look at the etiology. Is it gallstone related, alcohol or hypertriglyceridemia related? Because some of these may have implication in terms of management. Because we know if the patient has a stone in the common bile duct, we may have to do ERCP. I'll come into the indication for ERCP in acute pancreatitis soon. Suffice it to say, only if the patient has evidence of cholangitis which does not improve after stabilization should one go in for ERCP. Just because there happens to be a stone in a patient who is hemodynamically unstable, we don't need to rush up for doing an ERCP. Stabilize the patient and then do an ERCP. And there are 5-6 acronyms of the word called pancreas which are important for managing acute pancreatitis in various aspects of the illness. These include perfusion of the patient, anesthesia, nutrition, clinical assessment of the patient, type of radiology which is needed, endoscopy in patients with the CVD obstruction or CVD stone, and the role of antibiotics. But before we embark on to understanding what type of management we need to take of the patient and the patient lands up in the ICU, we have to understand the basic pathophysiology of pancreatitis. What happens is there is a premature activation of the trypsin and the proteolytic enzyme within the parenchyma of the pancreas that leads to local inflammation. This local inflammation leads to the release of the cytokines and oxidative stress. A combination of the pro-inflammatory cytokines in the form of IL-6, IL-1 and TNF-alpha lead to a culmination of the event which produce cellular dysfunction, local and systemic microvascular dysfunction, leading to something called capillary leak syndrome. So the initiation of the pancreatitis which had began in the pancreas because of the autoactivation of the trypsin somehow leads to a process which is characterized by inflammation as well as the recruitment of the inflammatory cells, which leads to capillary syndrome resulting in third space sequestration of the fluid, hypovolemia, and a cascade of events resulting in hypovolemic shock and multi-organ failure. Why is it that we always talk of perfusion or fluid replacement as the harbinger of management in acute pancreatitis? Most of the patients, in fact all the patients with moderate to severe acute pancreatitis are volume depleted because they have been having vomiting, they have low intake of the fluid, there is a vascular leakage, and there is a shift of the fluid into the interstitium. This, in addition to the fact that cytokines and the chemokines tend to damage the vascular endothelium, which leads to sequestration of the fluid into the interstitium. So there is an increasing hypovolemia that leads to hypotension. Hypotension will lead to lack of tissue perfusion, which will lead to organ dysfunction, and this is a event which will keep on happening till the patient ends up into the multi-organ failure. But as of now, we do not know that is it that the mild pancreatitis will evolve into severe pancreatitis, or all severe pancreatitis by default or by destiny are severe to begin with. That answer needs to be is still not available. So what do we do in fluid management? We have to know how much of the fluid has been lost and how much do we need to replace. Now the degree of loss will depend on whether you have a mild, moderate or severe pancreatitis. How much we need to replace will depend on whether you want to give aggressive therapy or you want to give targeted or non-targeted therapy. Problem is, all this is a theoretical assumption. Do we have objective parameters to assess this? Unfortunately, there is no way of looking how much of the fluid is cell in the intravascular component, how much is in the interstitium, and how much is in the intravascular component. We in fact depend on the surrogate markers like hematocrit, BUN, serum creatinine, heart rate, and mean arterial pressure. That is the reason there are a lot of disagreements in fluid management in patients with acute pancreatitis. Do we need to give them aggressive versus non-aggressive therapy, targeted versus non-targeted therapy, what type of fluid, what rate of infusion, how long to monitor, how to monitor. These are still controversies and there are no definite guidelines. Suffice it to say that in patients with mild pancreatitis, you still have preserved neurohormonal axis. So even if you tend to give the fluid, it will try to undo the basic pathology because there is no capillary leak and it will prevent the organ dysfunction. And hence, by default, in mild pancreatitis, you can go ahead with something called aggressive therapy. But if the patient, as I said, has already come to you with severe acute pancreatitis, so what has happened in severe acute pancreatitis is because of the inflammation, you have a release of the pro-inflammatory cytokines and damage-associated molecular pattern, which will cause sequestration of the fluid away from the intravascular component to the interstitium. So if there is a leaky capillary syndrome, the more in fluid you keep on giving, the more tends to seep into the interstitium, the more of it is going to land up in the vital organs. An increasing amount of the fluid in the interstitium of the lung, heart and the kidney is only going to produce more and more problems. And hence aggressive therapy is a thumb down. It is not indicated in patients with severe acute pancreatitis. What is the difference between acute, aggressive and non-aggressive therapies? As mentioned recently, anything more than 3 ml per kg per hour is aggressive therapy. Non-aggressive therapy is something less than that. So we should be very clear, if you have diagnosed the patient who has severe acute pancreatitis, giving aggressive therapy, that means anything more than 3 ml per kg per hour is going to be detrimental because this is going to lead to hypoxia, raised GBP and alteration in the kidney functions. So when we are giving fluid therapy, we have two goals in acute pancreatitis. We have to ensure end organ perfusion. So if you perfuse your pancreas well, possibly the ongoing necrosis may get halted. At the same time, do not try to over-infuse, because with over-infusion of the fluid, you are going to land up with pulmonary edema, cardiac overload, abdominal compartment syndrome, and AKI, which is only going to worsen the outcome. So how do we assess what we are giving? There are non-invasive markers and invasive markers, but unfortunately there is no marker at the moment which can tell us where is the fluid getting sequestrated. That is the biggest limitation for the type of therapy we give. Second important contentious issue is which type of fluid. Do we need to give ringer lactate or normal saline? Some basic difference between the ringer lactate and the normal saline is important to understand that by default, lactated ringer or ringer lactate has low sodium and low chloride as compared to normal saline. It has a pH which is more physiological than the acidic pH of normal saline. In addition, it gives you calcium which is not present in the normal saline. So a normal physiological pH with low chloride load with normal low sodium load is much better as an infusion agent in patients with acute pancreatitis, because it has been shown in experimental studies that it also tries to decrease the stimulation of the inflammatory cascade, and whereas normal saline tends to increase the hyperchloremic metabolic acidosis, promoting inflammation in the gut. So what type of therapy we should give, targeted or non-targeted? As of now, almost all guidelines suggest that you go by heart rate, urine output, vein arterial pressure to go and assess the patient for type of therapy. Non-targeted therapy at the moment is not recommended. So this is something called ROSE acronym. You resuscitate the patient, optimize the patient, stabilize the patient, and then evaluate what needs to be done. Analgesia can be given in the standard format. There is a new concept of giving something like ropivacaine and fentanyl as a continuous infusion in patient with the continuing pain. Nutrition will be talked about by will be given and presented by Dr. Anup Saraya. Suffice it to say that the controversies regarding the type of the feeding have been persistently put to rest. What is recommended is an early feeding as soon as the patient is able to tolerate. Parenteral feeding by default should be avoided. Earlier you start to give the enteral feeding, the better is the concept of maintaining the gut integrity. The so-called rest of the pancreas by now is an obsolete theory, and you do not try to delay your feeding. So as soon as the patient is able to have a nasojejunal feed in, you should start the therapy. So these are the do's and don'ts about the enteral feeding. Start as early as possible. NJ and NG controversy has been, again, there was a trial by Dr. Anup Saraya looked at it. Most of us still prefer to use NG, nasojejunal tube rather than nasogastric tube, but theoretically both of them are equal. Parenteral feed should be preferably avoided, and there is absolutely no role of giving immuno-enhanced therapies like omega-3 acid or glutamine supplementation. Content of the feeding is typical. It is a hypercatabolic state. You have to give enough calories and 1.2 to 1.5 gram of the feed. Parenteral nutrition is needed only if there is a prolonged IBS, there is abdominal compartment syndrome, or complex pancreatic fistulas. Antibiotics by default should not be given in the first 7 days because most of the inflammatory parameters are because of the SUS, not because of the superimposed infection. While choosing antibiotics, it is important to remember the antibiotics which have a good penetration into the pancreas. So metronidazole, carbamazepine, and piperacillin tazobactam. These are the drugs which have an excellent penetration into the pancreas, and hence these are the preferred drugs. Try not to overuse these drugs because of the degree of the resistance. So this is the summary of what we do in patients with the acute pancreatitis. Try to treat them with bolus dose and try to give them the therapy which is mostly targeted therapy. All said and done, we still have big unmet needs for management of patients in the first 72 hours. There are no non-invasive parameters to assess what is the degree of the fluid overload and where is the fluid overload getting into the body. There are no clinical, radiological, biochemical and surrogate markers for capillary leak, and we do not know whether acute pancreatitis is mild or not or severe. Are they different entities or they are continuing of one entity another? To sum up, ladies and gentlemen, this is a summary of do's and don'ts of first 72 hours of management of acute pancreatitis. In casualty itself, a simple score of PU and hematocrit gives you maximum information whether the patient has mild or severe pancreatitis. When you are trying to resuscitate the fluid, better do it with the ringer lactate. I'm just finishing. Better do it with the ringer lactate. Aggressive therapy should be avoided if you suspect that the patient has severe pancreatitis. Prophylactic antibiotics have no role. Absolutely in management of acute pancreatitis in the 7 days. Pain management, opioid, which was supposed to be contraindicated, is no more true. You can safely use it. Early ERCP should be done only if you have evidence of persistent cholangitis or if the patient does not improve on antibiotics. Thank you.
Thank you, sir, for this excellent talk. Next, I invite Dr. Pramod Garg. He'll be speaking on nutritional management in pancreatitis. Dr. Pramod Garg, please.
I'd like to thank the organizers for this opportunity and Dr. Arora for having done some of the work with regard to nutrition and acute pancreatitis. And I think it's the right time everybody is having lunch or so to talk about nutrition and acute pancreatitis. There are two major dilemmas when we talk about nutritional therapy in acute pancreatitis. One is that if you feed these patients, it will stimulate pancreatic secretion because feeding is the most important stimulus for that. And when you do that, there would be more activated trypsin within the SNR cells, and that would lead to more cellular injury and more fluid collections. Like this, you have fluid collections coming in, and that is why the concept of pancreatic rest came in. That is one part of it. The second is, if you keep them fasting or don't feed them, then it will lead to gut mucosal atrophy and increased intestinal permeability. And there is one important concept that intestinal alkaline phosphatase is one very important enzyme which maintains gut permeability. So if you fast these patients, then there may be more permeability. Also, in patients with acute pancreatitis, there is release of multiple cytokines, and these cytokines also lead to increased permeability. And this increased permeability may lead to secondary infections and sepsis. And a couple of studies from our department, Dr. Sarai had performed, has shown that there is indeed increased intestinal permeability in patients with acute pancreatitis. So whether to feed them or fast them is the dilemma. So what happens in these patients once they have these collections? They also have what is called as compensatory anti-inflammatory response syndrome following SARS and organ dysfunction, increased intestinal permeability, that they develop infected necrosis. And of course, that again leads to more morbidity and mortality in these patients. So the nutritional problems in these patients arise from pain, from IBS, vomiting, fear of eating, and delayed eating. Other problems include SARS, organ dysfunction, which require high energy demand. Infected necrosis by itself is a major catabolic state, and that is why malnutrition ensues quickly, and this also leads to some kind of immune suppression. And that is why the nutritional therapy is of utmost importance in patients with acute pancreatitis. So what are the management issues with that? When to start feeding, how to start feeding, do you give oral or tube feeding, NG versus NJ feeding, how much to give, whether give enteral or sometimes parenteral, and what to give, normal, elemental or special. So this is a typical case scenario of a patient who comes in with acute pancreatitis, pain for 2 days, severe pain with vomiting, amylase is high, gallstone present, diagnosis acute biliary pancreatitis. But see here, heart rate is 86, respiratory is 18, there is no SARS, abdomen is soft, bowel sounds are present, and you diagnose acute pancreatitis day 2, mild severity, no major comorbidity, and BMI is 24. Standard patient, mild disease, right? The CT shows no necrosis, maybe small foot corrections. What do? You start feeding as the patient tolerates. There is no hurry, by the way, to start. Whenever we discuss about nutrition, say day 1, day 2, day 3, whenever you feel it is appropriate, when the patient is feeling like eating, you can start your oral feeds right away. Day 2, day 3, day 4, doesn't really matter. As soon as tolerable, preferably pain is decreasing, or you have to do analgesia. And oral is good enough. In fact, I'm not really concerned about nutrition therapy in such patients. And fortunately, 80% of our patients have mild disease. So we're not concerned about the nutrition therapy in general. So somebody could ask, why are you concerned? So there is a nutrition assessment tool also that you can use, but practically speaking, it is not used. I mean, it depends on the age, the severity of the disease, whether the patient is ICU or hospital or normal ward, what are comorbid conditions, and of course some influence markers. But practically speaking, this is not something that we use on a day-to-day basis. So in mild acute pancreatitis, not necessary to wait until the pain or likeness completely resolves. That's important because this is many people ask us. One randomized trial showed that immediate oral feeding with a normal diet is safe in mild pancreatitis. It's a shorter hospital stay, and feeding can be started with a full solid diet without the need for going with gradually from liquid to semi-solid and then solid diet. More recent data suggests that you can right away go with a solid diet on day 2, day 3. We generally gradually start them on semi-solid or solid diet. The next case scenario is a patient who comes in with acute alcoholic pancreatitis. CT shows 50% necrosis, fluid collections are present, cirrhosis is present, there is grade 2 respiratory failure, abdominal pain, albumin is already down to 3.2. So this is a patient who has got day 3 predicted severe or maybe severe acute pancreatitis, and there are major concerns here. When do you start? How do you start? What do you get? Oral versus tube, NG versus NG. So the recommendations, these are recommendations based on International Association of Pancreatology guidelines. Enteral tube feeding should be the primary therapy in patients with predicted severe acute pancreatitis. Grade 1E, strong agreement. 2, now actually there are a couple of more meta-analyses show that enteral nutrition compared with parenteral decreases infection rates, multi-organ failure, need for surgery, and mortality. So there is by and large consensus across pancreatologists that enteral nutrition is preferred. How do you give it? Enteral feeding is the preferred modality. You can give it by NG or NJ. And Dr. Arora also alluded to that NG is easier to place. The only question is that some patients, it may not be tolerated by the patient, those who have got persistent vomitings, and there is a little bit of altered sensorium also. So NJ is generally preferred over NG, although I would recommend that you try NG first. A randomized trial of 60 patients with severe acute pancreatitis showed that enteral tube feeding starting within 48 hours had a better outcome compared to those in whom you wait for 7 days or longer. That trial published a few years ago showed no benefit of immediate means within 24 hours of hospitalization of tube feeding in severe acute pancreatitis. And that's why I'm saying, when we say early, you don't have to really do that on day 1, day 2, day 3, but surely don't wait for a week or longer to start your enteral feeding of these patients. This is another case. We have a 30-year-old male comes with 7 days of illness, acute severe refractory pancreatitis, type 1 respiratory failure, acute kidney injury on dialysis, hypertension, fulminant pancreatitis, multi-organ dysfunction. What do you do in these patients? Such a patient has to be in ICU, on a ventilation, tense abdomen, intra-abdominal pressure is generally high, and CT shows ascites, edematous bowel, and brains are potent. So in such a patient, there is inability to start enteral nutrition, even with NJ, because of very tense abdomen, increased abdominal pressure, hypertension or minotropes. Again, you can't really be giving them a lot of enteral nutrition. So these are the patients who are started on TPN. The problems with TPN are well known: sepsis, hyperglycemia, electrolyte imbalance, and most often we are not able to meet the required calorie and protein requirements of these patients. So sometimes you have a situation like this, you may have to resort to TPN, but most of the times you can get away with tube feeding through NG or NG. What kind of diet should be given? Either elemental or a polymeric nutrition formulation can be given. In fact, in most of our patients, we don't give elemental or semi-elemental. Elemental actually not available. The semi-elemental is available, but that's not required. You can give polymeric diet, there's no problem with that. And meta-analysis, this is an older meta-analysis, but other meta-analysis have shown that type of diet doesn't really matter. In fact, immunonutrition also doesn't matter in improving the outcomes in these patients. So, ladies and gentlemen, I'd like to summarize by saying that we should try and initiate enteral feeding as soon as possible in patients with acute pancreatitis. In mild, there's no problem. In severe pancreatitis, you can wait for 2, 3, 4 days, optimize the patient, and then try enteral tube feeding. Polymeric feeds are okay, most patients tolerate it well. Target calories about 25 to 30 kilocalories per kg with 1.2 grams of protein. Often difficult to achieve in the beginning, but gradually you can build up over a period of time. And we rarely rely on total parenteral nutrition. One of the questions often asked but remain unanswered is whether to add pancreatic enzymes with this diet or not, because if you have patients with necrotizing pancreatitis, there is hardly any secretion of the pancreatic digestive enzymes. Practically speaking, we add pancreatic enzymes to each feed that we give, but we don't have robust data on that. Thank you very much for my attention. I think I've saved 3 minutes to the organizers, so at least give me a chocolate for that.
Thank you, sir, for finishing. It's my pleasure to invite Professor Manoj Ranjan for his next talk on pain management in chronic pancreatitis.
Thank you. I'd like to thank the organizing team, Raisa, Sandeep, being heading the entire team, of course, there are a lot of others, for this privilege of this talk. You just heard 2 nice talks. Anil and Pramod gave a talk on acute pancreatitis. We are now moving on to chronic pancreatitis in this, and I shall be talking on pain management in chronic pancreatitis. Now, pain, as you know, is the most common feature. It's the dominant feature, presenting feature in 80%, and is present in more than 90% of patients. There is no cure for chronic pancreatitis, and all the therapies that we have, be it pharmacotherapy, endotherapy, or surgery, just reduces the pain. Nothing reverses the disease. Multiple mechanisms, I'll come to that later. But this is meant for the postgraduates. We have just 3 clinical situations that you come across in chronic pancreatitis regarding pain. The commonest, and being an endoscopist, the easiest to treat, is ductal hypertension when there is an obstruction either by stricture or by stone. The problems come when you clear this ductal obstruction and there is a recurrence of pain after clearance of the ductal obstruction. And finally, you have that, a little less common in our country, what is called the small duct disease, Cambridge or the Kramer classification you would have read. The ducts are normal, there is parenchymal damage, maybe a little calcification, and pain is the dominant symptom. We had the fortune to publish our own data on various platforms. Mechanisms of pain in chronic pancreatitis must be known. Now, Roop is also going to give a talk. Dr. Roop Jyoti works a lot on this and he's giving a talk, I think, on the last day. There are many factors, they are interdependent, there may be a combination. Ductal hypertension, I told you, is the commonest. A block leading to upstream dilatation, pressure, converting to parenchymal hypertension. Nociception, pain receptors or nociceptors, either in the spine or the pancreatic sensory nerves, they get activated in chronic pancreatitis. You may have ischemic pain, neuropain, and finally, adjacent organs, be it the duodenum, be it the bile duct, all of them can produce pain. I shall not be discussing that part of it in today's talk. I told you Roop is going to give a talk. He published his data from our institute a couple of years back. Now, how do we manage pain in chronic pancreatitis? Lifestyle changes and pharmacotherapy. This, I think, is common to whatever the 3 types of clinical. Remember the 3 clinical syndromes I told you. Irrespective, we start with this. Lifestyle changes, analgesia, role of enzymes and antioxidants, and we take them up one by one. Alcohol and smoking must. Both are independent risk factors, and a combination is even worse. So whether you need your psychiatrist friend or a drug or de-addiction, you must go through it. Role of meals. Now, like Anil just told you, the pancreatic rest theory is gone. The small meals and deep fried food earlier was practiced. I'm not very sure. There are very little evidence on this, but whatever is there does not support any of these old theories of frequent feeds, avoid oil-rich food. There is some evidence that antioxidant-rich foods may help along with folate supplementation, especially if he is an alcoholic. So lifestyle changes other than withdrawal of the offending substance, really nothing much. For analgesia, pharmacotherapy, start by the WHO ladder, NSAIDs, move up gradually. We prefer in our country to use the opioids, tramadol being the commonest drug. Morphia is not often used, but in the West it is a very common drug used. Nothing else, we use a patch, and in exceptional cases, epidural analgesia for a few days or even more, a celiac block is used in chronic pancreatitis. I'll come to that a little later. The role of antioxidants, much in vogue now. Pramod is here, one of the primary workers, and I am going to quote his paper. All of us now know that it's an SNR event, pancreatitis. It is associated with reactive oxidative, excess of reactive oxidative species. And these oxidized compounds, if they are present in the pancreatic duct, they damage both the acinar and the ductal cells. So they have a role in the pathogenesis. And of these compounds, the methyl and the thiol moieties, methyl and thiol, are most important. It is their deficiency which worsens. A lot of antioxidants have been used, number of studies, and I'm just going to quote one for two reasons. It's come from one of our colleagues, Pramod. It's come from our country, and it's very widely quoted. And this was the study about a decade ago where they found that they had a reduction in number of painful days per month and the number of analgesia that was used by these patients on a specific preparation, an antioxidant preparation. I have not gone into the details, but it was there, included selenium, I think, Pramod. No, it had selenium also. We did a study subsequently from our center, who again presented this and found that antioxidants, especially with methionine in the dose of 2 grams per day. I told you methyl and thiol are the most important, so methionine help. After that, we go to the neural modification with tricyclic compounds, the SSRIs or the gabapentin and pregabalin, and this study showed that pregabalin is beneficial in management of pain in chronic pancreatitis, and we subsequently showed that a combination of antioxidants and pregabalin is even better to manage when you have done a ductal clearance and pain persists. This was done in CCP who were morphine naive patients. What about pancreatic enzymes? You heard Pramod talk about their role in nutrition. What about their role in pain management? Lipase is the rate limiting enzyme as far as exocrine hepatitis is concerned. For pain, protease is considered to be the key enzyme. It acts via CCK, and I will come into this. It inhibits CCK and thus inhibits stimulation. Remember Pramod's first slide, where you give rest to the pancreas by preventing its stimulation, and you cut down CCK, you reduce stimulation, and thus to reduce pain, probably a high protease dose and preparation is what is required. But then, what are the results? And I am quoting again one of the few studies that has come from our country, a Cochrane review, which showed that there was really no benefit with these preparations with enzymes in pain, mind you. Then there was meta-analysis, and again quoting just one of them. There was a benefit in 4 of them. Most of them were non-coated preparations, early release in the upper intestine. The rest showed no benefit. So, if anything, and we are doing a study with one of our registrars where we are using a non-coated preparation and seeing the response in pain. So, if anything, the jury is still out. If anything, it's going to be high proteases, non-coated preparation, if the studies in future favor the same. What about endotherapy? This is only used if there is ductal hypertension with a proximal obstruction, and I'm just using 2 indications. There are many where endotherapy is used in chronic pancreatitis, but we'll talk about strictures, because strictures are seen in 20 to 50%. A majority of them are symptomatic. Be careful in chronic pancreatitis, always exclude malignancy, because you know the incidence of malignancy is higher in chronic pancreatitis. Organic strictures with fibrosis generally have a dilatation, and 6 mm is taken as the cutoff. We dilate the stricture, example from our archives and push in a stent. The standard protocol, the ESG guidelines for 2019, initially a single plastic stent. Every 3 months you change, sometimes change on demand. But the results are not very good, and there is a recurrence of 38% at 2 years. So the same guidelines insist that after 1 year of single therapy, if the response is not adequate, Costamania first propagated it. He did it for biliary strictures. He's also done it for pancreatic stricture. Use multiple or maximal pancreatic stenting, as many as you can, either sequentially or simultaneously. Results obviously are much better, but the guidelines are very clear. The ESG are the only clinical guidelines we have. 2018 or 19 is the last one. This is from Costamania's files, multiple 3 stents placed in the biliary duct. The other cause of ductal hypertension in our country, especially stones. I missed the heading, the small pancreatic calculi, nothing. ERCP, extracted, use a balloon or a spiral mini basket. Don't use any big device. For large pancreatic calculi, just 2 ways. Either an extracorporeal shock wave or an intraductal. Using a pancreatic scope, you can use an EHL or a laser lithotripsy. Mind you, the guidelines even till today say that pancreatic lithotripsy is to be used only if ESWL is not available, or if an adequately performed ESWL has failed to crack the calculi. So it is the second line therapy, maybe in the next couple of years, with improvement technique and technology. You know, the diameter of the pancreatic duct and its tortuosity makes it a poor candidate for manipulation of any accessories. We published our data on endotherapy. Large data, we now have 8,000 patients, good clearance, pain relief, short term, and some figures from the same showing complete clearance of the pancreatic duct. People who had pain were relieved. We compared the data with data published internationally and found that relief for varying periods of time varied from 48 to 80%. Since pancreatitis, especially in India, is a disease of the young, a long-term follow-up was needed. We published this a couple of years back. Follow-up is now extended up to 17 years. 60% of the patients are happy. What you should realize is patients who are relieved of significant pain in the first 2 years after the procedure, need any type of lithotripsy, do the best. So if you have early relief of pain, more likely to get a long-lasting relief. The only criteria is the ductal clearance must be complete. So good ductal clearance, good relief in the first 3 years, your patient is a happy man, so are you. Well, pancreatitis has drawbacks, limitations. There's no single mechanism of pain, multiple mechanisms. They could act simultaneously. We don't have a tool to identify which is the dominant mechanism. As there is no cure for pharmacotherapy and for any therapy, there is no limit. It's an indefinite therapy, and really don't have data on combination of various drugs. We just have one study. So summarizing in this last slide, the 3 clinical syndromes, I feel ductal obstruction is the easiest. Anil is sitting here. Anil Agarwal, I meant the surgeon. Either endotherapy or surgery, get rid of the problem. Post-ductal clearance for small duct disease, the stepwise pattern. First, of course, lifestyle changes, NSAID, maybe tramadol, some centers morphine, add antoxid, high-dose methionine, doesn't work, add pregabalin, doesn't work, add central neural modifier, SSRI, nothing works, celiac block. So this is basically the entire gamut of management of pain, either with ductal hypertension or without ductal hypertension and small duct disease. Thank you.
Thank you, sir, for comprehensive talk and completing on time.
Thank you.
Switching from most common to most related pancreatic disorder, may I invite Dr. Kulvinder Dua to talk about biliopancreatic malignancy.
Just a quick announcement. We have our faculty lunch in the open lawn outside. Request our faculty to please attend it. Thank you.
Thank you, chairpersons, moderators. Thank you, Mesh Goenka. Thank you, Sandeep Lakenda, and thank you, Rukraj, for giving me this invitation and honor to come here and speak. Very difficult topic because the whole field of cancer, whether it's pancreas or whatever, lung, colon, is very challenging. I'll only touch on a few areas because there are so much that can be discussed, each in its own way, a full talk. This is our cancer center, which around 10, 12 years ago got one of the US's best architectural design. This big building is only part of our hospital where we treat our cancer patients. And talking about pancreas cancer, as you see, the number of people who die from pancreas cancer is almost the number of people who are diagnosed with pancreas cancer every year. So it's a very bad disease. We are not winning this war at all. Let me start off with this slide, where you see that this is 3 decades of following up the survival of patients with pancreatic cancer. And as you see over here, that the long-term survival after triple surgery for pancreatic cancer, 1980, median 23 years, 1990, median 25 years, 2000s, median 24 years. So 3 decades of doing pancreatic resection in resectable tumors, followed by adjuvant therapy, has done basically nothing. Despite our increase on our new, chemotherapeutic agents, we are not winning at all. Now, why is this happening? This is an interesting study where they did genomic sequencing on pancreas cancer cells acquired at autopsy. And based on the differential accumulation of mutation, what was found that the tumor initiation happens almost 12 years ahead of time. Oval tumor then develops 12 years later, and after another 4 or 5 years is when the person starts complaining of symptoms. So not surprisingly, this process has been going on for almost 11 to 15 years before the patient becomes symptomatic. And in one publication in the journal Cytology, it was considered that pancreas cancer, by the time the patient becomes symptomatic, is a systemic disease. And they are micromets. So one challenging part is, can we do screening and catch these patients earlier? And that may change the paradigm when people are not surviving more than 24 months. And how do we do this? So in terms of pancreatic cancer, early diagnosis and better treatment, can that change the equation? So these are the AIGE guidelines we have been doing. We have been having a robust pancreas cancer screening program at the Medical College of Wisconsin, going on for almost now 6 years. And these are the people whom we try to screen in that earlier part, 11 to 15 years earlier. There are 2 categories, those with genetic predisposition syndromes and those with familial cancer syndrome. Now, familial cancer patients do not have any genetic abnormality, but they have a pair of first-degree relatives who had pancreas cancer. So these are the 2 people we are targeting on our screening program. Don't have to read this slide. As you notice, familial atypical multiple mole melanoma has around 20-fold increased likelihood of developing cancer. Peutz-Jeghers syndrome, 36-fold. Hereditary pancreatitis, 40-fold increase. Now these people are, in your practice, you can catch them before they develop cancer, and all these other conditions, familial adenomatous polyposis. This can be found in any textbook. So these are the people who have the bad gene that can be picked up, and you can keep an eye on them. Now, how do we do the screening program? We use MRI scans, because if we do CT scans, and you do CT scans periodically every year, every 2 years, every 3 years, too much of radiation to the body. So MRI scan is one. The first case that I'm showing you, actually both of these are my cases in 2022, is a cyst on the CT scan that was being followed. It was growing in size. The patient came for EUS. As you will see, it has got a solid component, which on site was positive for ADenoCA. The second is an infectious disease pediatrician from our hospital who had a CT scan for renal stones. A dilated pancreatic duct was found with no mass. We did an EUS, found a mass, and it was positive for ADenoCA. So these are the two modalities. MRIs are easy to do and no radiation. And when there is a suspicion, you can go for EUS. People have been doing both based on which they feel comfortable. As you will see over here, EUS alone, 6 studies, around 300 plus patients, MRI, 5 studies, and a combination of the two. The outcome yield for high-risk lesions was 4% with EUS, 2.4% with MRI, and for resectable lesions, EUS and MRI, but the p-value was not significant. So in our institute, when we started the screening program, we do MRIs alternating with EUSs. In other centers, they just do MRIs, and if there's any change, they send the patients for EUS to find out what else could be going on. So the suggested annual screening for those genetic disorders and the non-genetic disorders, familial syndromes, is starting at the age of 50 or 10 years earlier than the youngest relative. When we have those high fold, 20, 30-fold increased chance of developing pancreatic cancer, we do the screening at a younger age, and we do it at shorter intervals when on screening we find things are changing. They may not have developed cancer, but the cyst has grown in size, or something has happened, patient develops symptoms, we do it more frequently. So what are the outcomes of doing all this? There's a lot of money wasted, but what do we achieve? The cumulative yield of screening is we can pick up in about 3.1% of these patients, catch them much before they become symptomatic. With screening, the shift towards resectable and borderline resectable patients is around 60%. We can pick around 60% of them compared to historical control when they come and show up in a clinic is only 20% resectable or borderline. 3-year survival is better from the cancers that were picked up in the screening program compared to historical control. 85% versus 25%. But there is a problem. You may pick up somebody and send that patient for surgery and it may not be cancer. And that's called the low-yield surgery. So the price you pay for all this is that around 3% of the people underwent surgery when they didn't have cancer because the screening tool is not perfect. But still, the benefits are quite a bit. The other thing that was found out, and this is interesting, that in a psychiatry journal they looked at if you screen them and put them on the screening program, their anxiety level drops quite a bit. And there is a significant relief in cancer-related distress over time. And if the cancer is picked up early, it's also cost-effective compared to when it is picked up late. Now, that is all screening. We do surveillance for lesions that are precancerous. This is because so many people are getting CT scans and MRI scans for various reasons, and incidental cysts are being picked up in the pancreas. We know about the mucinous cystic neoplasms, intraductory pancreatic mucinous neoplasms. All these are being picked up incidentally. It's not that the incidence is rising, more people are getting scanned. Now, these fall under surveillance, not screening. These are another group of people where we can target to achieve something to prevent bad disease developing where the survival is very poor. And I don't have to go through all this. These are all in the textbooks. We use MRI scans for them. If the cyst is less than 1 centimeter, we have all these scanning protocols. As you see, if the cyst grows in size, we scan them sooner. The next part, challenging part, are these indeterminate strictures defined as a stricture seen on imaging studies, and ERCP and brushings are inconclusive. A fair proportion of these do not turn out to be cancer. So putting them to surgery may not be the right answer, But on the other hand, if there is cholangiocarcinoma and it is T1, the 5-year survival is 100%. So we are in the catch-22 situation what to do with these indeterminate strictures, which is another very challenging area in the biliary pancreatic arena that we have, I think, still not achieved the right way to investigate them. I have very limited time, so we do brushings, not very good at all. Then we can do brushings and put a biopsy forceps up into the bile duct. The sensitivity may increase a little bit, but again, not perfect. Combined brushings and biopsies, you can go up a little bit more. Then there is this endoscraper, it's like a cheese grater. You can go into the bile duct and scrape and pick up more cells. And you can see that in 28 out of 58 patients who were not diagnosed by brushings and biopsies, they could pick up cells. Now these cells, you can even send for molecular analysis for fish. You can do whatever you want to do, you get more cells. And the endoscopic scraper sensitivity is up a little bit compared to just brushings, and specificity is also pretty good. As I said, fish is something that we send only for those where we have high pre-test probability of malignant strictures. The rest of the stuff, all what we do in fish is listed here. We have many more molecular and DNA profiling systems that we can do. And then we have all these other areas that we can use, ultrasound, cholangioscopies, and so on. So a lot of indeterminate strictures can be picked up in this way. And last few slides is that I was told that they put up 12 minutes over there, but they're giving me 15 minutes. No, you didn't say that. Okay, so let me just say that the other challenging part is treatment, and the treatment is that when we do this protocol, we find cancer, we do pancreatectomy, and then we give adjuvant therapy. The problem with this is that many of them have micromets, and they undergo triple surgery for no reason, and then some of them are getting adjuvant therapy, but many of them don't get, because after surgery their performance status decreases and they never get adjuvant therapy. So our protocol is to give neoadjuvant therapy. This can be given to everybody before surgery. Since it is given for 3 to 6 months before surgery, the micromets patients will show up and they do not have to go through Whipple, but we need tissue diagnosis over here, and we need a durable biliary drainage. So we follow this protocol. We get a high quality CT scan before we do any procedures that can give the patient pancreatitis. EUS, cytopathologist in the room, positive for cancer, ERCP immediately, and put in a stent. So this is called the one-stop shop. And I will skip forward a little bit over here to show you what our results are. What we found is that in this protocol, where we give neoadjuvant therapy, our R0 resection rate on the top blue line you see is the R0 resection, M0 resection rate is pretty high compared to historical control. If you see on the graph on the left-hand side is the surgery first, and the other one is the neoadjuvant therapy first, and you see the M0 is significantly better in neoadjuvant therapy group and so on compared to the surgery first group. And this is, I think, my last slide, where it shows that in this particular study, this is just recently published, that those who got neoadjuvant therapy compared with those who got adjuvant therapy, surgery first, the 5-year survival rate in those who got neoadjuvant therapy was around 21% compared to those who had surgery up front. So there are a lot of things over here, very challenging, from whom do we screen, does screening work, surveillance to pick up early cancer, and how do we give chemotherapy in relationship to surgery, the sequencing of things. These are all to be still determined. We are not there as yet, but we are now at least thinking outside the box. I'll stop here. Thank you very much.
Thank you, sir. For the next session on endoscopy, thank you, Chairperson, thank you, speakers. For the next session on endoscopy, can I please invite Dr. Dinesh Garg, Dr. Amit Goyal, Dr. Sanjay Jain, Dr. Anil Sharma, and Dr. E.R. Swadeshi to please chair this session. For the moderators, can I please request Dr. Kulvinder Dua and Dr. Jayanti Venkatraman to please be on the stage. For the adjudicators, can I please request Dr. Surendra Sultania and Dr. Manish Gupta. Thank you. Due to the paucity of time, I will also invite the first speaker, Dr. D.N. Reddy. I would also like to inform that we have a working lunch served in the lawn. I request all the delegates and faculty to please grab a quick bite. Thank you.
Okay. So endoscopic management of cholangiocarcinoma involves a wide spectrum of things that we do. The most important thing is the therapy depends upon where the location of cholangiocarcinoma is. For distal tumors, we still do surgery. For intrahepatic tumors, they're treated as they're treated for HCC. It's the hilar tumors which are the target of the endoscopies mainly. And you can see from here that 40 to 60% of cholangiocarcinomas are hilar. And this is where the endoscopy's role comes in, because you can't actually do surgery in many of these patients. But again, very important to remember that surgery is the best treatment. R0 resection is only cure for these patients. And that's why all attempts should be made to see whether it's resectable or not. One of the problems we face when you come across a hilar stricture is we want to know whether it's benign or malignant. And this is very crucial. This is the main answer to what we do in these patients. And you can't actually distinguish just based on imaging in these patients. And you can see that when you finally look at these patients, they have different types of imaging pictures which can be very same. So what we require is a tissue, and tissue is a problem because getting tissue from this area, and as Kulvinder shown earlier, has got very low sensitivity and specificity. And in fact, for distal we use EUS, for hilar we use ERCP. But I think what has dramatically changed is the advent of cholangioskopy. And cholangioskopy has increased our sensitivity to 86 to 87% specificity to almost 100%. So what we're now doing is in most patients who suspected cholangiocarcinoma, before we validate them, we do a cholangioskopy to establish a diagnosis. In fact, we published a study sometime back, a randomized controlled trial, where we actually looked at these tumors and actually tried to see whether cholangioskopy direct or biopsy and cytology should be done first. And you can see from this study that when we did upfront cholangioskopy, it was not only cost effective even in Indian sense, but also our accuracy ratio extremely high. So that's what we suggest to establish the diagnosis. And what of course we're also doing is the ROSE technique, which Shyam and his group advocated, where you do cholangioskopy, take biopsies, imprint smears, and imprint smears will give you a diagnosis right there in the endoscopy room, so you can make a call whether you want to put in SEMS or so on. So this is a very easy thing to do. What about EUS? EUS has a very limited role in these patients. It's predominantly only if you want to do a biopsy of the lymph node. I would not advocate biopsy of the actual tumor because you're doing needle sealing and they can't go for surgery. So finally, when you establish a diagnosis of cholangiocarcinoma, the aim in most of these cases which can't be resected is the palliation. And palliation is very often done by trying to drain different segments of the liver. But there are four important issues that you should know before you palliate these patients. First, what is the distance classifications, type 1, type 2, type 3, so on. Is there an atrophic lobe because you should not drain this? Is there portal or hepatic artery involvement? And is there an abnormal anatomy? These four are extremely important before we start to embark on training these patients. And again, very important, every patient of ours, the hilar carcinoma, has to have an MRCP before we do an ERCP. And without the GPS of an MRCP, one should not embark on an ERCP in these patients. So let's come to some clinical questions that we go about when we're treating these patients. Which stent should we use? How many stents? Which technique? And which different types of endoscopy versus percutaneous? So should we use plastic or self-expanding metal stent? I think here there's been a very clear-cut answer for several years now. Several RCTs have shown that self-expanding metal stents are superior to plastic stents. They last longer, they don't get blocked, they don't have cholangitis as much as plastic stents. So this is what we routinely do in our patients using self-expanding metal stents. But there is a small change here because earlier we used to use only plastic stents for uncertain diagnosis. There is a group of ERCPists, and this is a recent survey that we're involved in internationally, where there is a tendency to come back to plastic stents rather than SEMS in these patients for two reasons. One is these patients are surviving long periods of time, especially with chemotherapy and so on. So I have patients now with cholangiocarcinoma living for 3 years, 4 years, 5 years. So if you put a metal stent, it gets infiltrated and you have to go and each time try and put in another plastic stent inside. So to avoid that, you can put a plastic stent and replace it whenever it gets blocked. The second important reason why we are going back to plastic stents rather than SEMS is that we are doing radiofrequency ablation in these patients, and RFA we can do repeatedly once we put in a plastic stent. Remove it, do an RFA, put another plastic stent and so on. So there seems to be some advantage of using a plastic stents in these individuals rather than self-expanding metal stents. Now, how many stents should you put? Again, this is a very common dilemma that we face when we're doing ERCP. You look at the MRCP picture, we get an idea whether it's Bismuth type 2 or 3A or 3B4, and then we decide how many stents to put in. Is it 1, 2, 3, and so on? To a large extent, this question has been answered by this very elegant study which came from France, which showed that you have to drain 50% of the liver to get good clinical results. So you have to calculate how much of the liver you drain when you put in stents. So it could be 1 stent draining 50% or even 3 stents draining 50%. So this is an important information that we require. And studies have shown that, for example, 3A, you require to put in 2 stents, and this was a famous Korean study, RCT, which showed that compared to 1 stent, 2 stents are better. But what happens is when you have MRCP like this, you're in dilemma what you should do. So what I have done is simplified this very easily for example, residents or those who are doing ERCP. We put this chart up in our ERCP room, and it's very simple. For Bismuth type 1, a single stent is sufficient. For Bismuth type 2, a single stent in the right side is sufficient. For Bismuth type 3A, this is the more complex one, where you require very often to put in 2 stents or both in right and left, or 1 in right and 1 in left. So Bismuth type 3A, remember, it's 2 stents. For type 3B is again 1 stent, and for type 4 is 2 stents. So this is a very simple formula. So you have the MRCP pictures in front of you and quickly know what stents to put. Again, plastic or stents decides depending on the situation there. There are some who attempt complete drainage, and this is one of my Japanese friends put in 10 stents into different areas, but this is not so easy very often. Now, which technique of stenting should we use? So there are several techniques. 2 of them which are commonly followed are putting 1 stent first, another stent on the side. So this is called the side-by-side technique, which is commonly used in the Western world. In Asia Pacific region, we more often use the stent-in-stent technique. You put in 1 stent, and through this stent, you can put in multiple other stents. It's not clear which is a better technique, but now there's some studies to study to show that a stent-in-stent technique has lesser cholangitis and maybe the preferable technique what we use. But new technologies are coming. You can simultaneously put in 2 stents or 3 stents, and 2 stents technique is now where you have 2 5-friend stents which can be passed in the endoscopy channel and then placed simultaneously in different sites. So this is something that's evolving. So if you have a patient who comes to you with different, as I said first, anatomical localization is very important. For type 1, type 2, type 3, we still do endoscopy, but for type 4 patients, there is a tendency now to send these patients for PT/PD, percutaneous drainage, because the radiologist is better at doing this than the endoscopy. But again, there is a little shift in the view here, where the endoscopic ultrasound is slowly taking over the role of a radiologist. So PT/PD drainage in these patients with hilar tumors are now being increasingly done, because you can do it in the same sitting as ERCP if you fail, and also it's in the control of endoscopists to do these things. Now, in addition to plain stenting, what we're doing in these patients, we're now changing a little. We also improve how do you improve palliation? By improving palliation, you mean you're increasing survival, you're increasing the stent patency, increasing the quality of life. Can we do this endoscopically? Yes, there are a variety of local tumor ablation techniques that are coming that are being used in these patients, photodynamic therapy, radiofrequency ablation, and so on. In fact, several years back, Ortner's group in Germany did this very interesting study where they showed that adding PTT for patients with cholangiocarcinoma with a stent dramatically prolonged the lifespan. For example, 98 was 493. They had to stop this study for ethical reasons. The study was duplicated in other centers, but unfortunately, we can't use this in clinical practice because PDT is not only very expensive. In our type of situation, the patients can't go out in the sun for several months together. That's the reason why it's not been widespread use, although it's still used a lot in some parts of the world, like South Korea, for example. So what we now switched on, something which shows equal efficacy, is radiofrequency ablation of these tumors. In fact, this is something reported very long back. You can see in patients cholangiocarcinoma using radiofrequency ablation, you can open the lumen completely. And a recent RCT from a Chinese group showed very clearly that you can prolong stent patency and survival in these patients using a combination of radiofrequency and stenting. In fact, if we add chemotherapy to these patients, we have seen that these patients survive for several years. In our group, I just looked at this also, that we looked at two groups of patients, those who received only self-expanding metal stents, others who received a combination of radiofrequency ablation stents. And they equally matched, and what we found was those patients who had RFA along with stents had a much longer stent patency, much longer survival without a difference in adverse events. So we recommend that all patients with cholangiocarcinoma of hilar type should have a radiofrequency ablation done, and the new radiofrequency machines are not only very effective but very safe. There can be some complications. It's very simple, it's very cost effective. There can be some complications. The most dreaded complication is hemophilia, especially if you're doing radiofrequency ablation on the right hepatic duct. The right hepatic artery is very close, and you can produce a pseudoaneurysm and hemophilia, like what happened in these cases. Of course, you can control this very easily with embolization, but what we now do is we map out these tumors. If it's very in the right hepatic duct, we would in fact do intraductal ultrasound, close to the hepatic artery. In that case, use half the dose of radiofrequency ablation. So this is what we do to avoid this complication. So radiofrequency ablation, I think, is quite effective, especially for locally advanced tumors. When there's contraindication for surgery, when surgical recurrences are there, we would recommend that this should be the technique. So what I conclude by saying that in patients with cholangiocarcinoma, the main target for endoscopy is the hilar cholangiocarcinoma. Majority of these patients require 1 to 2 stents to palliate 50% of the liver, and best way to palliate this currently is self-expanding metal stents. Plastic stents are coming back in fashion, maybe long term that may be better. Radiofrequency ablation is an additional technique that improves survival, improves stent patency, and we'd advocate that all patients with cholangiocarcinoma going for palliation with stenting should also have a radiofrequency ablation done. Thank you very much.
Thank you very much.
Move on to the next topic. We have Dr. Amit Mehdi, who will be speaking to us on endoscopy in morbid obesity. Over to you, Dr. Mehdi.
So, first of all, I'd like to thank the organizers for calling me to talk to you today on this topic. It's a great honor and a privilege. I'm going to talk to you on endoscopic treatment of obesity, not just morbid obesity, because morbid obesity is usually treated by surgery, and endotherapy usually is for class 1 and class 2 obesity. It's a very interesting paper published in 2020. You see here, many of us may not believe, but the overall prevalence of obesity in our own country is almost reaching 50%. And what is most interesting to note is that obesity which we see in people of our country, and that too in Asians, is a little different type of obesity, because this is predominantly central obesity or visceral obesity. So our type of patients tend to develop comorbidities at a much lower BMI. In fact, if you were to see here, even at a BMI anywhere between 23 to 25, there is increased risk of comorbidities, 25 to 30, moderate risk, and even above 30, just above 30, there is a severe risk of developing comorbidities. Treatment of obesity, the various modalities have evolved over the years, starting with simple lifestyle management, dietary control, and major surgical treatments. And of course, more the efficacy of the treatment, more is the risk involved. As you can see here, the least risk involved is in very simple treatments like diet management or lifestyle management. Surgery has been the mainstay of treating obese patients. Surgeons have done a fantastic job, even in our country. The results are very good. You see here, excellent results of weight loss and excess weight loss. But all said and done, even though the complication rate is very low, there is some chance of complications, and if a major complication occurs like a leakage or any other problems like bleeding, it can be a disaster for the patient as well as for the surgeon. So therefore, what happens is very small percentage of patients actually accept to undergo surgery. Overall, the percentage overall the world is less than 1% who accept surgery. In our country is probably even less than 1% or less than 0.5%. What is very interesting to note is that if you were to see all the comorbidities associated with obesity and how much weight loss is actually required to reduce the comorbidities associated with obesity, this was a very interesting paper which was published, which shows that all that you require is a 10 to 15% total body weight loss, by which you can reverse almost 95% chances of comorbidities which can happen in obese patients. Now, can this be done by simpler techniques? Yes, and that is exactly the reason why bariatric endoscopy has evolved and flourished over the last decade or so as an intermediary treatment for patients who are obese and especially class 1, class 2 obese. The first and the easiest method of bariatric endoscopic option is a gastric space occupied therapy, which is a placement of a simple gastric balloon. There are various types of balloons which we can place inside the stomach, and the mechanism is very simple that the balloon is placed in the stomach, it occupies space, and thereby the patient eats less food and therefore the weight reduces. Different types of balloons are there. You see here, three common types of balloons are Orbera balloon, the adjustable sparse type of balloon, and the very recently introduced balloon in our country is the swallowable balloon, which is also called as the Allurium or the ellipse balloon. The most accepted indication for balloon placement is treatment of class 1, class 2 obesity, that is anywhere between a BMI of 26 to 35 or 36. It can be used as a preemptive therapy for sleep apnea, hypertension, bridge therapy before bariatric surgery or liver transplant, if you want to just reverse the fatty liver or NASH. And absolute contraindication, of course, is patient who has got portal hypertension, varices, acute ulcers in the stomach or duodenum, coagulation disorders, pregnancy, or a large hiatus hernia. Different types of balloons are available. Intragastric balloons, you see here, all these three balloons. And from these data, you can see that the average total body weight loss at the end of 6 months to 1 year is anywhere between 10 to 15%, which is reasonably adequate and sufficient for us to reverse the comorbidities in these patients. The only problem is these balloons have to be removed, but you can remove these balloons, some of them after 1 year, give a gap of 1 month, and you can again replace the balloon. And hopefully till that time the patient has adapted to the new lifestyle of eating less food and continues to maintain the weight loss. The second important procedure which we do endoscopically is a gastric restrictive procedure. And the commonest procedure which we perform now and popular all over the world is called as endoscopic sleeve gastroplasty. Now this is a procedure which is done by a flexible endoscope. Patient is under general anesthesia. We pass this instrument inside to which is attached a suturing device. And then in some patients we mark the place where we want to suture on the anterior wall and the posterior wall. And what we are planning to do here is to suture the greater curvature of the stomach, starting just proximal to the incisor angularis, and we keep on suturing the greater curvature. Either we go in a Z shape or a U shape fashion. These are full thickness sutures by using this device, and we stop our suturing just distal to the fundus of the stomach, intentionally leaving the fundus of the stomach intact. And after doing this, we can reduce not only the size of the stomach but also the length of the stomach. Well, again, the most accepted indication is class 1, class 2 obesity, comorbidity treatment like NAFLD, joint pain, hypertension, or other problems, or it is more importantly evolving now as a treatment modality for post-laparoscopic sleeve patients who have again regained weight, where the stomach has again enlarged in size. A very good treatment for this. Absolute contraindication is of course portal hypertension, varices, coagulopathy, and related contraindication like gastritis. These patients can be treated with PPIs and then proceed with the treatment. A little cumbersome device. This is a suturing instrument. You use a double channel scope in our country. This is the instrument is attached to the tip of the scope. And then we have to pull the full thickness of the stomach inside these two arms of this end of the suturing device. This is how the procedure is done. The device is attached to the tip of the scope, and we have passed the scope right till the area of the antrum of the stomach, just proximal to the incisor angularis. This is how now the suture material, the needle is being loaded on this needle driver, and then by going ahead, we start doing the suturing by passing the screw type of device first, pulling the wall of the stomach in between the two arms, and then driving this needle through and through. And thereby we can take a continuous suture starting from the anterior wall, going around the greater curvature, on the posterior wall, taking a U shape, going back again, and thereby we keep on reducing the size as well as the length of the stomach. After we have performed this procedure, usually this looks as if you have performed a lap sleeve gastrectomy, almost as if you have performed a LSG procedure. Well, according to my time, it's only 7 minutes which have been passed. You already rang the bell. Well, I continue this in spite of that, but the hallmarks of endoscopic sleeve gastroplasty is it maintains the anatomic structure, maintains the innervation, maintains the blood supply, potentially reversible, it is reproducible, repeatable if required, safe procedure. Many of these patients will discharge on the same day, we don't even need to admit them, more durable than the balloon, and it can be upgraded by surgery. What is the result of endoscopic sleeve gastroplasty? I directly show you the latest trial which has been published very recently in the United States from 9 centers from USA. It is a prospective multi-center randomized trial where they have shown at the end of after doing endoscopic sleeve gastroplasty, total body weight loss at the end of 1 year was approximately 14%, and which could be maintained over a period of years because these patients very well adapted to these types of change of lifestyle. 2 different procedures that I want to show you is metabolic endoscopic options. One is for foregut bypassing because it has been postulated that the main reason for the insulin resistance which occurs in these patients is because of the abnormal enteroendocrine cells which are in the foregut. So by placing such type of duodenal sleeve or duodenojejunal sleeve, you can actually prevent the nutrients from coming in contact with the foregut abnormal cells, and thereby you can increase the insulin secretion or increase the insulin sensitivity. Well, this device initially launched 2015, a trial was conducted in the United States, but it was stopped preliminary because it was shown to be associated with some major complications like liver abscesses. But this randomized trial continued in UK, you can see here from 2 major centers, and after a period of 2 years they realized that this device really requires to undergo modification because there were no significant benefit in the reduction of HbA1c levels at the end of 2 years. So after modification, probably this device will be launched into the market. Another device which is now being used again in clinical trials is to actually change the abnormal duodenal mucosa, a technique which is called as duodenal mucosal resurfacing by using this catheter. And what is done here is a guide wire is placed endoscopically. Then such type of a device is placed where a balloon is inflated, which is filled with hot water or more almost 90 degrees centigrade, and you ablate the mucosa beyond the ampulla obvator till the DJ flexion. And this has been shown that the abnormal mucosa gets damaged, it gets ablated, new mucosa comes, and thereby you can see that it improves the HbA1c levels. 3 ongoing trials here, you can see here. Still, it is an experimental device, not to be used in clinical practice. But what is probably going to make a big impact is an endoscopic procedure, which is almost akin to surgical procedure, where you actually perform a jejuno-ileal bypass by performing an endoscopic procedure by using an incision-less magnetic anastomosis system. Now here what is done is, by passing an enteroscope from above, a magnet is placed in the jejunum. Similarly, a hexagonal magnet is placed by an enteroscope passed from below into the ileum, and these magnets come into contact with each other naturally, and within a period of 7 days, it causes a natural anastomosis. Now, this is not an end-to-end jejuno-ileal anastomosis, it is a partial jejuno-ileal diversion, so therefore it causes excellent malabsorption and a very good reduction of the HbA1c. You can see here from this initial study of 10 patients, there was an excellent result. So if at all any metabolic procedure is likely to come in there in the future, it will be the incision-less magnetic anastomosis for these patients of obesity. Well, where does bariatric endoscopy stand today in 2022-23? You see here 2 main important procedures is balloon placement and endoscopic sleeve gastroplasty. The 3 procedures on the horizon is the duodenojejunal sleeve. Second is the duodenal mucosal resurfacing, and finally is going to be the incision-less magnetic jejuno-ileal diversion or anastomosis. So, as far as class 1, class 2 obesity is concerned, there is no doubt that a vast majority of patients now who are afraid of surgery, who don't want to continue their lifestyle management and dietary management, are valid and suitable candidates for giving them a potentiating effect by using bariatric endoscopy. Thank you.
Thank you very much, Dr. Amit, for that wonderful coverage on endoscopic management of morbid obesity. We now move on to a different topic away from endoscopy. We request Dr. S.K. Sarin to give his talk on severe alcoholic hepatitis, steroids, and beyond. Over to you, sir.
And thanks the organizing team of ISG for having invited me. It's good that the talk is in the daytime. Can you show my slides, please? Yeah. Greetings from ILBS. I have nothing to disclose. I have a question. I would ask at the end of it. Please read it. I will not. So what are our learning objectives? Steroid non-response and options. So this is the way today the world treats severe alcoholic hepatitis, suppress inflammation, steroids. So a patient comes and you assess him for alcoholic hepatitis using the Maddrey's DF, that is INR, and bilirubin. If the DF is above 32, it is severe alcoholic hepatitis, and then if you don't treat, mortality is 65%. Aggressive nutrition, NG tube, remember NG tube, and IV lipids. Screen for sepsis. If none, then this patient is fit for going for a steroid therapy. And if there is a response using Lille score, if it is less than 0.16, it is very good. Between 16 to 45, it is moderate. But above 0.45, it is certainly no response. If there is no response, then you have to go into the other. If you have a response, you continue. So when do you give steroids? These are absolute updated, so please pay attention. This global study by Arab et al., it highlights that the most significant benefit of steroid is between 25 and 39 med, the dark blue. But the survival benefit is only up to 28 days. So you have a window of 4 weeks. This is important. If you give steroids or you don't, in 30 days, steroids will decrease med score by 4. If you wait 90 days, no difference, and 180 days, maybe no therapy is better. On severe alcoholic hepatitis, which is ACLF, means ascites and jaundice, and high INR, there is no study. This is the first global study from ARC of 5,000, finally having 1,249 patients. Now, please pay attention. Those with no ACLF, 35% are steroid eligible. Once ascites develop, 30% means 1 in 3 is eligible. Then steroid responder in those who have ACLF is just 44%. So 30% eligible, of which 40% are just responders. So the response rate may just come down to about 14-15%. Now you know all the ARC grade. ARC grade is between 5 and 7 and 8 to 10. Those who have ARC grade 1 or 2, they will respond better. ARC grade 3 will not respond. Compare this to MEL or CLIF so far, anything. The ARC grade, both in survival and response, is superior. So please pay attention. You can use this photograph and you can use this. ARC between 5 and 10, there is reduced mortality, minus. ARC between 5 and 10, steroid is response. Very simple. You have INR, you have bilirubin, you have creatinine, encephalopathy, and you have HE. So this is the ARC score: bilirubin, HE, INR, lactate, and creatinine. R up to 10, steroids. What is important is this very important landmark study in hepatology. If you have treated somebody with steroids, you follow for 5 years. Post-hospital infections in steroid treated is about 4.27 times. What are your checklists? A patient has come. What I don't have time enough, but to say at baseline. But what is important is 28 days during the course you have to screen. Screen for CMV, galactomannan every 2 weeks, people forget it, and also do chest x-rays. And remember, steroids on 3rd week and 4th week are the worst. So should we not add antibiotics? So this study in Lancet by the group from Lovett, adding antibiotics is logical, but does it work? No. So in this, those patients who were sick with high MELD were given prednisolone plus amoxi and clavulanic, and compared with prednisolone alone, infections decreased, survival no benefit, response to steroids no benefit. So adding antibiotics does not improve. So let's come to suppressing inflammation. We can't do it well today, except can we prevent infection? Yes, possibly by GCSF. GCSF works by stimulating progenitor cells and also mobilizing from the marrow CD34, CD133 positive cells. There is a very recent paper by Georgi Zamor in hepatology where in the animal model they have shown the benefits. So we thought, why not combine steroid and GCSF? No such trial. This was a plenary this year in ASLD. So one group is prednisolone combined and GCSF alone. Now these are the summary results. Prednisolone response, 90-day survival 64%, GCSF 78%, no difference. But when you compare prednisolone with the combination, there is a survival benefit. Lille score reduction, 28-day survival, infection reduction, and rehospitalization. I therefore think this may be the future. You can also use GCSF in steroid failures, non-responders. Compared to placebo, 28%, GCSF in steroid non-responders can be beneficial. But I don't have time but to say all patients are not good. Selection is the most important part. A European trial did not, because they used not patients with alcoholic liver disease, decompensated advanced. Now, do we have therapies and can you predict beforehand? The first summary is steroid in selected SAH improve 28 but not 60 days. Use this MELD or DS. And ARC is best for ACLF and alcohol. Add GCSF to steroids and define non-responders. What are the new approaches? One is nutrition. You all know it. I want to tell you the benefits of saturated fat. I have told it several times that giving saturated fats increases lactobacilli about 20 times and decreases endotoxins and the gut leakiness decreases. How does the saturated fat or ghee works? This is going to be under review and may get in. Is that alcohol causes many problems and dysbiosis, endotoxemia. When you give saturated fat, which is 20 to 24 acids, fatty acid length, then you improve the adiponectin, nutrition of course, dysbiosis, and very important is fat, F and fat, chief bacterial genes are preferably improved. So saturated fat may help. Now, can you give in a patient with deep jaundice, bilirubin of 30, you can give IV lipids like your soya products, intralipid. What it does, we see here, a negative nitrogen balance is converted to positive nitrogen balance. and nitrogen excretion. So energy is used. So what is our prescription? 30 to 35% of the total calories is fat, which is about 3000 using Blackburn injury factor and NJ tube feeding, and of course many other things. Now the next is, can you do some kind of suppression of immunity, inflammation, infections, and liver regeneration? And FMT, couple of trials has shown there is an advantage. You can prepare it very easily, and this is our FMT lab. This is the first trial where, compared to an anecdotal group, the survival in 8 patients was better. But this could be beginner's luck. This trial just published about a month ago compared FMT to prednisolone neck to neck. And neck to neck it is as good, if not superior, which it shows that FMT can do all what steroids can do, but without side effects. This trial came from PGI, and it also shows compared to FMT, compared to standard of care, FMT is superior. So 2 trials published this year. Now there is another drug called anakinra, which has been used as IL-1 antagonist, and this has not been found to be useful. And the last part, and I want to stress this beautiful study by Apple. What they did was, in a large group of patients, they finally selected 50. 21 patients had flex and 29 patients had standard therapy. What they did was, they gave plasma exchange and added low dose steroid, 20 milligram, not 40, and they showed that there is a survival benefit using this. Now, this is my summary slide. Just to tell you, a patient who has got severe alcoholic hepatitis, identify the golden window, that is in first 48 hours. In ACLR, golden window is 7 days. But that much time you don't have. And you will give nutrition, dietary modulation, omega-3 and branching. Now define in 48 hours, is steroid eligible, then you can give him response. I would assess on day 4. If it doesn't, I will say hold on. And if there is no response at day 7, then of course he goes into the other group. You screen for sepsis at the beginning and then again at day 7. And if there is nothing, then you can proceed to either GCSF. You can certainly, if GCSF doesn't work, go for transplant. You can use shit therapy if it is palatable. You can also use plasma exchange. Now we are regularly using stem cell therapy with very good results. Now this all is done in first week. But after first week, you have to decide whether the patient needs liver transplant or no liver transplant. But I think no one, where is Sandeep? No one drinks in Jaipur. Is that right or wrong? Wrong. Alright, so I have something which I just wrote. Cheers to healthful drinks. This is another approach. Thank you so much.
Thank you very much, sir.
Now we will go on to the next talk, EUS in Hepatology, explained by Dr. Rajesh.
Good afternoon, everyone. Good afternoon, Chairman, sir. Thanks to organizing committee for giving this opportunity, and greetings from Vedanta, the Medicine. The integration of endoscopy in the field of hepatology is known from the long time. A decade before, endoscopy was mainly used for the diagnosis of esophageal varices, gastric varices, diagnosis of portal hypertensive gastropathy. But in the last 1 decade, there is a paradigm shift, and endoscopic ultrasound become the integral part of hepatology. It has a role right from differentiating the NAFLD from the NASH to the early cirrhosis to the advanced cirrhosis to the decompensation, and for diagnosis and treatment of hepatocellular carcinoma. So it has a role in EUS guided liver biopsy, EUS guided coil and tube injection for gastric varices, elastography, contrast, enhanced ultrasound, EUS guided portal pressure measurement, EUS guided paracentesis, and an animal study tips. But because of the scarcity of the time, I am going to discuss EUS elastography, EUS liver biopsy, and EUS guided portal pressure measurement. And I will be happy to give answer to the rest of the techniques. EUS guided portal pressure, conventionally the portal vein HVPG is measured by the transjugular route, but it is invasive, have radiation exposure, IV contrast, difficult to do in the renal failure patient, and it only provides the indirect measurement of the portal vein pressure. And measurement of the portal pressure has therapeutic and the prognostic implication for the titration of the beta blockers. EUS guided technique, you require a linear echo endoscope, 25 G needle, a compact manometer that with a non-compressible tube, which is attached to the hub of the 25 G needle, and an hypernized saline for the flush. So first you put patient in the supine position. Under sedation, the manometer is zeroed at the mid-axillary line. And once you zeroed at the mid-axillary line, with the help of 25 G needle, transgastric, transhepatic, you puncture the middle hepatic vein or the right hepatic vein, and you flush the needle with the 1 to 2 cc of the hypernized saline. And after 30 to 60 seconds of the stabilization, you measure the portal pressure, hepatic vein pressure, and you take around 3 readings. Similarly, you puncture the umbilicated portion of the portal vein or the left branch of the portal vein. Do the same process, flush with the hypernized saline, take 3 readings, and the mean portal vein pressure minus the mean hepatic vein pressure is the portal pressure gradient. And this is the, I'm thankful to Professor Anthony Gio, and this is the 25 G needle in the left hepatic vein. You flush with the hypernized saline. This is the compact manometer which you flush with the saline and you get after 30 seconds the reading. Then you find out the left branch of the portal vein, puncture, again flush, and you take the 3 readings, and the difference between the portal vein pressure minus the hepatic vein pressure is the portal pressure gradient. Now, EUS guided portal vein pressure is real time and it is as accurate as hepatic vein pressure gradient. So this is the first human pilot study in 28 patients with 100% success rate and no adverse event, and it has an excellent correlation with the parameters of the portal hypertension like presence of varices, portal hypertensive gastropathy, and thrombocytopenia. This is another human study in 12 patients with a success of 91%, and it has a correlation with the EUS guided portal vein pressure is equal to the hepatic vein pressure gradient through the transjugular route, and the Pearson correlation coefficient was a high degree of consistency between the two. So EUS guided portal vein pressure is a safe, direct, and accurate method is in comparison to the hepatic venous pressure gradient, which is indirect and it is not accurate in the pre-sinusoidal portal hypertension, and it has a potential to supplement the hepatic venous pressure gradient measurement. I think the slide itself speaks about the advantage of EUS guided liver biopsy. Such a large chunk of the tissue you can get with the help of EUS guided liver biopsy, conventionally done with the percutaneous and transjugular route. Conventionally is traditional, simple, and inexpensive, but has a disadvantage of patient discomfort, high complication, only right lobe can be targeted, and obese in the patient, the ascites cannot be done. While transjugular route can be done in the coagulopathic patients, and HVPG can be measured at the same time, but the disadvantage is it requires an incision, fluoroscopic exposure, expensive, and patient discomfort. But when you talk about the EUS guided liver biopsy, it is safe. It's under real time. You can avoid the blood vessel with the Doppler application. It is clinically effective and reduce the sampling error, and sampling of both the lobe is possible. And what is the technique? You require a therapeutic linear echo endoscope. Desired lobe to be identified, mainly the right and the left lobe. Both the lobe can be, you can take the liver biopsies. But before that, you remove the stylet, prime the needle with the hypernized saline, apply the Doppler and at least puncture the 5 centimeter of the liver parenchyma, and the suction, which is negative suction, can be applied with the heparinized saline for around 15 to 20 cc. Now technical questions, which needle is better? Which technique is better? So when we talk about aspiration versus biopsy needle, there are meta-analysis which shows the biopsy needles are better in comparison to FNAC needles, which gauge 19 gauge is better than 22 or 25 G needles, and which makes, there's the one study which shows the fencing design of the needle is better than the rest of the FNB needles. Regarding the suction, there's a comparison between the no suction, dry suction, and the wet heparinized suction. The wet heparinized suction has a better result in comparison to the dry and the no suction. The number of passes, the best result you can get, one pass of the 3 actuation. Meaning once you pass once and you do a fanning technique 3 times, to and fro movement, and that gives the better in comparison to multiple passes. Make sure that when you withdraw the needle, apply the Doppler. If there is any blood, then wait for 30 seconds and then withdraw the needle. And even if the blood is seen in the path of the needle, then you can eject the small amount of the material from the needle, which act as a blood test technique. So this is the left lobe of the liver, segment 2. You identify the avascular area, puncture with the 19 G needles, and once you puncture, you take the needle at least 5 to 6 centimeter into the liver and pass 3 to 4 times. So one puncture with 3 to 4 actuation is more than sufficient to get the good results. Make sure that when you are withdrawing the needle, apply the Doppler which I said. So this is the 4th, and then you apply the Doppler. If you see this kind of blood vessels, then wait for 30 seconds. Once this disappears, because there is a coagulation happens, once this disappears, then you can withdraw the needle to prevent the EUS guided complication from the liver biopsy. So once the Doppler signal goes away, you can withdraw the needle. When we talk about the specimen adequacy, according to the ASAID, a specimen of 2 to 3 centimeters with 11 portal tracts are important. And these are the 3 studies which shows that EUS guided liver biopsy has adequate length and the portal tracts are more in comparison to the percutaneous and the transular liver biopsy. When we talk about the adverse events, the overall adverse events is same in all 3 techniques, but the bleeding is less in comparison to the percutaneous and the transular in comparison to the percutaneous route. Pain is minimal pain in the liver biopsy group in comparison to percutaneous, where you go through the skin as well as from the liver capsule. Other complications like pneumothorax, biliary peritonitis, or need to make the patient the right decubitus position is not required. So the most important question comes: will you subject the patient for EUS liver biopsy, or who is the best candidate? Because EUS guided liver biopsy is costly. So the patient who require an upper GI scopy, or patient who require an EUS for pancreatic reason, and you require other methods like with the help of EUS, at the time of liver biopsy, you can do the shear wave, you can do the portal pressure measurement also. So those patients who require other concomitant procedure, you can do the EUS guided liver biopsy. So to summarize, it is safe and can be done by NOVA. Provide both histologically and pathologically complete sample in comparison to percutaneous and transnuclear, 19G FNB needle, fencing design, wet suction with heparin, one pass with 3 actuation is better, and ability to evaluate the GI tract and pancreatic system at the time of examination. A few words about the shear wave elastography. What is elastography? Is modality used to visualize the elastic properties of the tissue. And what is elasticity? Is tendency of the tissue to resist deformation with an applied force or to resume its original shape after the removal of the force. So elastography method has an advantage to know the change in the elasticity of tissue, and you find out what is the level of fibrosis patient is having. But the transient elastography has a limitation in obese patient, narrow intercostal space, patient with inflammation, cholestasis, or right-sided heart failure or ascites. So this is a recently published study where they have done 82 patients where they do the simultaneous liver biopsy and transient elastography done within 1 month. And the discordant was the fibrosis, which is defined as F3 and O on transient elastography, but when they see the biopsy, it was 0 or 1.
Same discordance in terms of steatosis. There is a moderate to severe steatosis on the transient elastography, that is the cap was more, but no or mild steatosis in the biopsy, and the reverse of that. So there is a discordance in the liver biopsy and the transient elastography, and what they have seen that around 48% of these patients has a discordance, and out of 48, around 72% has a discordance in fibrosis and 32% in steatosis. And those patients who has a high BMI or the NASH, they have a more discordance in comparison to the rest of the parameters. So all patients with advanced fibrosis and cirrhosis, the liver biopsy are appropriately diagnosed the transient elastography. Detection of the steatosis is less sensitive as 19% of the patients with a moderate to severe steatosis. Transient elastography overestimates the fibrosis in 35% of the population. So what is the mechanism? Is instead of measuring the longitudinal propagated wave which you see in the vibration transient elastography, while in the shear wave elastography you see the profile wave. So the wave which are perpendicular to the ultrasound wave you measure, that is the EUS guided shear wave elastography. And this is the study which is presented as an oral paper in the DDW. And what they have shown, 44 patients in the same session, they have done the EUS shear wave elastography and the liver biopsy, and what they found that the EUS shear wave elastography of more than 12.5 kPa has 88 or 81% correlation with F3 and F4 fibrosis. And when they compare when they find out the left lobe shear wave elastography with the spleen elastography, and it has the highest operating characteristic of predicting the fibrosis with the positive predictive value of 80% and the negative predictive value of 93%. This is another study, 42 patients underwent EUS shear wave elastography, transient elastography, that is fibroscan and the liver biopsy, and what they have seen, there is no statistically significant difference between the area under the curve where the EUS shear wave elastography and the transient elastography. But transient elastography was unreliable in 8 patients who were successfully underwent shear wave elastography. So to summarize, EUS shear wave elastography is an advantage over transient elastography, that is fibroscan in obese patients and patients with the steatosis. Shear wave elastography correlate well with the histology in comparison to the transient elastography. It is safe and reliable diagnostic test for assessing liver fibrosis with the accuracy comparable with the transient elastography, and more data is needed. Thank you for the patient hearing, and I welcome you for the Interventional Pancreatic Biliary Congress 2023 in the month of May 27 and 28. Thank you.
Thank you. Thank you, Dr. Rajesh, for that wonderful talk, and we conclude this session. With permission of the chairs. Thank you.
Thank you, ma'am. Thank you, chairpersons. For the next session on Imaging EUS, can I please invite Dr. Rajneesh Gulati, Dr. Naresh Bansal, Dr. Mahendra Agarwal, Dr. Sanjay Kumar, Dr. S.P. Saxena, Dr. Vipin Mathur to please chair this session. I would also request Dr. T.S. Chandrasekhar and Dr. Subhash Nepalia to be the moderator for this session. The adjudicators are Dr. Anil Jangeet and Dr. Pankaj Jain. For the first session, may I please invite Dr. Sandeep Lakhatia, the speaker of this session.
We are going to have a very, very interesting session today. Many postcards will be benefited. Endosonography. And we have a first speaker, Dr. Sandeep Lakhatia. He is a special interest in endosonography. He has been the president of SGA, and now I think he's a past honorary secretary fellow, and now without wasting time, and he is so popular and well known. May I request the permission of the chairperson start the topic?
I think the chairperson needs some seats.
You need some more chairs, please come.
We invite Sandeep for the first talk. Everybody knows Sandeep is a wonderful speaker. Thank you and good afternoon, everybody. At the outset, I would like to thank ISG and the organizers for inviting me here for this prestigious our national conference. I'll be speaking on the topic imaging of pancreas. Is EUS complementary or can it stand alone? So when we speak about imaging of pancreas, these four investigations come in our mind. Transabdominal ultrasound is foremost, which is the commonest investigation ordered by most gastroenterologists who deal with pancreas. And if problem is found or even not found, we follow with either a CT scan or an MRI with MRCP. And if something is still confusing or needs to be clarified further, we follow often with an EUS or endoscopic ultrasound as it's called. When we do EUS, not only we do diagnostic part of it, but we also have some more arms attached to EUS which can help us in clarifying the problem further. For example, elastography, as Rajesh was speaking just now, or contrast enhanced EUS, where we inject contrast intravenously, something quite similar to CT scan or MRI, and that contrast then goes into the various organs through the blood circulation. At different phases of the blood circulation, we objectively see in the real time the problem or the pathology enhancing and then disenhancing later on. Not only that, we can perform a very important part of EUS procedure is getting a tissue from the suspected pathology, that is EUS FNA or FN biopsy. Sometimes we can do through the needle biopsy forceps, through the 19-gauge needle pass a mini biopsy forceps to the lumen of the FNA needle, especially a large caliber needle, and get real chunks, especially in cystic neoplasms, and also do confocal laser under microscopy, just like to do the luminal aspect of it. Last but not the least is also used for intervention, which is not part of the talk, but nevertheless to complete the whole thing. We can do EUS guided interventions, for example, drainage procedures of pancreatic fluid collection, pancreatic duct drainage, or the bile duct drainage if it's because of pancreatic malignancy and so on. And rarely tumor aberrations and sometimes relief of pain because of pancreatic malignancies, we do select plexus neurolysis. So there are some pancreatic diseases which often require imaging to confirm the diagnosis, and these diseases are commonest is pancreatitis in our country, both acute and chronic pancreatitis. Pancreatic masses and their evaluation, the space of the pancreas, whether they are cancer, they are neuroendocrine tumors, or SPEN, or cystic neoplasm, and so on and so forth. Among the pancreatic cyst, I spoke about the pancreatic fluid collection drainage, but also whether they are mature enough, they have debris enough, classifying them as true pseudocyst or actually a ward of necrosis, where EUS largely helps. And also in true cyst of pancreas, whether the likely diagnosis on imaging is mucinous cystic neoplasm or a serous cyst adenoma or an IPMN or a SPEN. I will show these things in the subsequent talk. Also, evaluation of unexplained dilated ducts, whether it's unexplained common bile duct which traverses through the head of the pancreas, and there can be pathology not picked up by other cross-sectional imaging, or even unexplained dilated pancreatic duct, even in an asymptomatic patients. These need to be looked into because sometimes a small malignancy can be harboring there. And last but not the least, in patients who have unexplained pain, and all investigations have come to naught. So these are the investigations or diseases which lead us to imaging of pancreas, which includes all four which I mentioned in the beginning. I'll touch upon a few of them. The pancreatic space of a lesion is the most often required investigation where EUS is demanded. Let me show an example of a 60-year-old maid who presented obstructive jaundice. And as rightly asked by the first physician who saw the patient on ultrasound, and this was what was seen, are dilated intrahepatic ducts and dilated upper CBD, and also a dilated pancreatic duct. Often these are difficult to see. A dilated common bile duct and intrahepatic will be better seen, but dilated common bile PD will be difficult. And if it is seen, then it points to something which is a problem line where both the ducts converge, that is near the ampulla of the head of pancreas. Another example, patient with now a mass found in the pancreatic head, as you see it here, which is at the convergence of superior mesenteric vein and the splenic vein, and also the dilate upstream PD. So sometimes ultrasound can pick up. It also is very observer dependent, and a good sonologist can help you make all efforts to find the diagnosis and help you with the next one if required. And this is the next investigation often asked by most gastroenterologists, that is the contrast enhanced CT scan. Another patient who had similar kind of presentation, pain, abdomen, weight loss, and jaundice. In cross-section shows IHBR in the liver. And as we see the reconstructed coronal image, you see a grossly dilated bile duct and a hypoenhancing mass or non-enhancing mass lower end of CPD, which is very suggestive of a cancer head of pancreas. So when we do a CT scan, our aim is to look, it's a triphasic CT scan to look at the vascular and the lymph node involvement and rule out any metastasis, especially liver metastasis. So this is a patient with a pancreatic head mass, same patient. You see the superior mesenteric artery, and this is little away from the margin of the tumor. Can this image guide to a resection? A second image shows the superior mesenteric vein, the venous phase, still away from the margin of the tumor. But in the conjugal phase, in the reconstruction, you see the jejunal branch are very close to the inferior part of the mass, which makes it inoperable. So CT helps us in describing the entire part of it. So you get this. So what all do we see in a CT scan? All that's an EUS talk, but still for a postgraduate, it's worth to know what are the particular parameters we're looking at on a CT scan for staging, size, the site, and the relationship to adjacent vital structures, the vascular involvement, the nodal status, presence of ascites or peritoneal involvement, any distant metastasis. If any of these things are found, then we act accordingly, or we downstage the tumor with chemoradiotherapy upfront after getting a tissue acquisition. So this is a flow chart of an imaging of a patient who has a suspected pancreatic mass. If it's a dilated duct, we do a pancreatic protocol CT, mass is found, and depending on the metastatic stage, we decide about the further getting a tissue acquisition by EUS, which is the most preferred method of getting tissue from any pancreatic mass, not percutaneous, either by ultrasound or CT scan. If there is no mass seen and clinical suspicion is still high, then we can consider an MR or a PET, or again an EUS. So EUS comes in both sides of the algorithm. Let me show you a video. Little lighted up, maybe you've not seen, but I'll point my arrow. This is the pancreatic head mass. This is the dilated pancreatic duct upstream to the mass in the bed body. You turn around, you see a dilated bile duct here, and the lower end of the mass is compressing the lower bile duct. You can take a measurements of the dimensions of the bile duct. Also see that the portal vein is invaded here, which was not very well seen, or it's actually infiltrating the margin, the fat planes are gone. And most important part is get a tissue acquisition. So we get FNA or FNB. Most likely now people do FNB because you get core and you can do immunohistochemistry in the acquired specimen. Moving forward, the other diagnosis which is often requiring EUS is pancreatic cyst. An example here, a young lady on an annual health checkup was found to have a pancreatic cystic lesion in the head. No other symptoms. That's how most pancreatic cysts are encountered. They get imaging for something else and they come up with an incidental pancreatic lesion. It can be incidentalloma as we call them. MRI then subsequently shows a bilocular cyst. CBD is normal and so is the PD. So whether this is an IPMN or a serous cystadenoma, it now becomes a question. And both patient is anxious and the doctor is anxious too to go to a diagnosis. And that's where EUS comes into picture. So this was the EUS, which is quite suggestive of a cystic lesion. Most likely it's a serous cystadenoma, where the larger locules, the peripheral ones are bigger and the central ones are microlocules, microcystic lesions. Another example of a different patient who had an MRI after ultrasound showed multicystic lesions. And the EUS of some of these would look like this. These are classical images, videos of serous cystadenoma, multiple cysts, with central calcification. When you have a central calcification, almost sign and this is a microcystic adenoma. Sometimes you have very large lesions, but the patient is symptomatic still, and EUS tells that there are large cystic areas and solid areas, and the biopsy from this showed a serous heterocytoma. So, serous heterocytoma can be large in size, but still can be asymptomatic. IPMNs are important differential diagnosis of cystic neoplasms, and this is a grape-like structure hanging from the main pancreatic duct towards the uncellate and the inferior part of the head. And this is the main duct IPMN, where the main PD is quite dilated and filled with large soft tissues inside with little dilated CBD and PD upstream to it. Another patient, similar type, who had a small cystic lesion, elderly male, picked up on ultrasound, very surprising, and then he had an EUS, and this EUS showed that the duct, main pancreatic duct near the papilla is normal, but there's a small diverticulum type thing appearing from the communicating with the main PD, and this is a small side branch IPMN. So sometimes we can be lucky in picking up the communication, but it may sometimes be difficult also. Young females coming with pancreatic masses, incident of some pain abdomen, like this one, had an MR and CT both, and we had to do an EUS, showed a large hypoechoic mass with central cystic area, small cystic area. FNB was done, and it was confirmed as PEN, which is common in young females. So that's how EUS helps. Another example of a patient with a cystic neoplasm in a complex type of thing, which is more cystic and also a solid element, not clear on cross-sectional imaging, and EUS was done, which showed a mucin coming out from the main papilla, which is very sine qua non of a main duct IPMN. Main duct is quite dilated too, and also one part of it has a solid part attached to it. So this is main duct IPM, which is going into the side branch, also causing a mass. Very small isoepileutic masses, which may be incidental or sometimes just come with pain, but other imaging are missing it out. You see a dilated duct, which should make you stand up and think, what's causing this dilated duct? And they should never be left alone like that, even if you don't see a mass. They should be interrogated further, and EUS comes here, apart from MR, CP, and MRI, and this was confirmed to be small adenocarcinomas. So EUS is quite useful for diagnosing both periampullary tumors and suspected small tumors, and they're quite useful and effective compared to CT scan when the tumor size is less than 2 centimeters. Not only that, in patients who have the evidence of chronic pancreatitis and a mass is there, whether it's an inflammatory mass or a neoplastic mass, it's sometimes difficult to say, and tissue becomes an issue, but sometimes we can get some clues from these imaging, both on CT and by EUS. These masses can be large in malignancies, they have irregular dilated duct upstream, vascularity of the mass will suggest, and presence of lymph node invasion, lymph node involvement and vascular invasion will suggest that these are malignancies. I think the time looks to be up, and I'll probably sum it up by skipping some of my slides and skip chronic pancreatitis, which we can take up later if required. So the take-home points would be that is EUS complementary or standalone? The answer is that EUS is complementary and not standalone. It adds to the overall information which has been achieved by other cross-sectional imaging. And not only that, it also adds by doing some intervention and beyond. Transabdominal ultrasound is still quite useful. It's very operator dependent, and the initial detection can give us either direct evidence or sometimes indirect evidence of pathology lying underneath, and which should be interrogated further by CT, MR, MRCP for staging and diagnosis. With EUS, you can do tissue acquisition, you can solve the problem of finding small tumors which are missed by other cross-sectional imaging, and you can detect small periampullary mass, and even differential diagnosis and follow-up of patients who have pancreatic cystic neoplasms and in chronic pancreatitis evaluation. Thank you very much for your kind attention.
Thank you, Dr. Good news from the organizers. Hereafter we can take one or two questions. Sandeep will be allowed to answer the question.
Of course.
So, do you routinely perform elastography or the
Elastography in EUS is still a debatable area. It's not a foolproof method. So I do it as a part of completion of process, but I don't confirm my diagnosis just based on elastography. Tissue still remains the main issue of getting the answer for that problem.
Suppose elastography is negative, I mean it's not supporting. Will you stop from biopsy or still go with the biopsy?
If elastography is supportive of my diagnosis, still I'll follow with biopsy to confirm because that's the most objective way. Just like in ultrasound, a person can say there's a mass there or may not be visible. I think it has to be without biopsy. We haven't reached the stage where we can do away with biopsy and say the diagnosis is made just by imaging itself.
Any questions from the audience?
Sandeep, in pancreatic cystic lesions, imaging alone, imaging alone or the cyst aspiration is more useful?
That's a great question. Cyst alone imaging would give us an answer in about 2/3. It's just imaging alone. That's the literature says. 1/3 the time the diagnosis can be wrong even by an expert operator. And these 2/3 are one which are the classical imaging, where you can see a duct communicating with the cyst, then you can confidently say this is an IPMN. Or you find a cystic lesion with a central calcification, the sunburst classification for serious carcinoma. That's very classical. Or if you have a neural nodules which are highlighting up on the Doppler. If not, then you can do a contrast enhanced use in the same setting and see if they're enhancing well, then it is a soft tissue mass and not a mucin plug. If not, then we do, if nothing is fitting to diagnosis and it needs to be established, then it's worthwhile doing puncturing the cyst and taking the fluid and the tissue from the solid element. But if patient is asymptomatic and likely to go for surgery, then I will probably not fiddle with this intervention and directly send for surgeons and not cause any leak or cause a tissue crack.
Right, thank you.
I think if no more question, thank you Sandeep for the energy talk and taking up questions. I will hand over the mic to
Thank you very much for your
moderator, Dr. Vipin.
Thank you, sir. Now I invite Professor Anthony Tho for his talk on expanding the scope of therapeutic EUS. Dr. Tho works in the Prince of Wales Hospital, Chinese University of Hong Kong. Dr. Tho, please.
Thank you for your kind introduction. So it's great to be back to India after almost 3 years now. So last time I was here in 2019. So today I'll be talking about expanding the scope of therapeutic EUS. These are my disclosures. Before I go over my talk, I'd just like to introduce this book, which is all on interventional EUS. It's a case strategy on interventional EUS, 61 cases. So all my collaborators are leaders in the world of this field. So happy to introduce this book to you. So in terms of expanding the scope of interventional EUS, of course, in the past few years we have seen many new dedicated devices for interventional EUS, and I think these are very important because these devices allow performance of normal procedures, reduces the difficulty of the procedures, reduces the learning curve, and also complications. Regarding stents, this is a device that we need constantly. And apart from the dumbbell-shaped stent, which has dramatically changed the way we do EUS procedures, there are also tubular type of stents. And apart from Axios and non-stent, now we have also other choices. And these new devices keep on coming because and as an endoscopist, we are very excited because we have so many new toys to be playing with. But of course, we need to look at indications. In terms of USPD drainage, we know that USPD has been shown to be associated with many advantages over percutaneous drainage. And in centers where USPD is practiced, this should be preferred over percutaneous drainage. Recent years, we've seen a lot of talk on whether USPD would be comparable to primary ERCP. And the rationale is that the stent is placed away from the tumor, so potentially The stand patency will be prolonged, procedural time will be reduced, and there's no risk of pancreatitis. But of course, ESBD requires technical expertise. There is some complications associated with, and the devices are of course expensive. So this study we completed and submitted to various journals. This is in review. The idea is to compare US CDS versus ERCP as a primary method for drainage for malignant distal urinary obstruction. So Gallbladder trial. And in this study, we found that the technical success was significantly better with the CDS group, mainly due to failure cannulation as well as due to obstruction in patients with the ERCP group. Procedural time was also significantly shorter. But in terms of stent patency, we couldn't show any difference. The 1 year stent patency was similar between two groups. And in terms of CDS, there were other causes of dysfunctions. So tumor group was slightly lower. So in centers where US CDS is practiced, the main idea is if you anticipate it to be a difficult ERCP, particularly if it's a very bulky tumor or if there is any duodenal obstruction, CDS may be considered as a primary drainage procedure. In terms of gallbladder drainage, I'm sure you've heard me talk a lot about this procedure to be performed in the US. And we have established this as a way to perform drainage in those that are at very high risk for surgery. So in patients where they have multiple comorbidities, where NAFLD is not considered, yes, GBD has been shown to be associated with many benefits over percutaneous drainage. Particularly in terms of 1 year adverse events, recurrent cholestasis, and also adverse 30-day adverse events, yes, GBD has many advantages. The next step is, of course, as a surgeon myself, to see if ES-GBD has any role in patients that are surgically candidates. So this is a study which is ongoing. It's a very controversial topic, but we thought we should study it. We recruited 30 patients, all are surgical candidates. We aim to follow them for 3 years, and we want to see their outcomes, particularly how many of these 30 patients that are supposed to receive cholecystectomy ultimately did not require the cystectomy. So most of them have completed a 3-year follow-up, and we have compared it to a surgical arm. And as you can see, in terms of, we submitted this to the DW 2023, blood loss, significantly lower in the ERCP group. Procedural time, 70 minutes versus 138 minutes. Time to resumption of diet, almost the same day for US gallbladder drainage. For surgery, it's around 1.25 days. Analgesic requirements, of course, significantly lower. And now of these 30 patients so far, up to 2 years follow-up, only 2 patients ultimately required cholecystectomy due to various reasons, either symptomatic persistent symptoms or recurrent cholestasis. And with US-GBD, we also see some new devices coming into the market. This is the Suez IT stent. It's a endoscopy controlled new coronary enhancement with a posing stent. So you can see me advancing the delivery system right there. And it operates very similar to other devices on the market. You burn inside into the stent, and the endoscopist would control the opening of the distal and proximal flange. Just by turning this knob around, it unlocks it, and then we can open the distal flange. And then opening of the distal flange in the US and X-ray guidance. And then you turn it again 180 degrees, and then you can open the proximal flange, which is usually in the channel, and then we would push it out from the channel within the ecosystem. So this is the appearance after complete deployment. So adding another choice, hopefully cheaper than available devices to the market. In terms of US gastroenteroscopy, I know in India many sonographers are performing this procedure right now. There are various variations in which we perform EUS gastroenterostomies. Now, the most common technique is a direct puncture technique. This is a patient who was quite interesting, had a duodenostat at the D3-4 junction in Sweden. So we did this with a freehand technique, inserted a nasal duodenal tube for distension of the small bowel, and then we wanted to see if we could have any window to do a gastroenterostomy. So after distension of the small bowel, you can see this part of the bowel is close to the stomach. The duodenostat is here in another segment of the small bowel. So this segment of small bowel is distal to the duodenostat. So we have a small window right there. So even after placement of a D3-4 stent, sometimes you can find a good window for puncture, distal in the distal jejunum as well. And with good distension, then we can perform direct puncture just as per usual. And usually we will perform this using a 20 millimeter stent, and this has been shown to be associated with better clinical outcomes. And again, this year in DDW, we have just submitted this randomized trial. The technique is a little bit different. You know, I am very good friends with Takao Tori, Vinay, as well as some people also participated in this trial. This is called Drago study, drainage for GOO. Again, showing some very interesting outcomes. Technical and clinical success, time to resumption of diet a little bit faster with the EPAS group. The 1 month GOO score, so the ability to tolerate better diet, was significantly better with the EPAS group. Reintervention significantly lower, stent patency longer, and the 6 month stent patency rate is significantly higher. So really favoring the use of a gastroenterostomy, which simulates a kind of surgical bypass over duodenal stent. So hopefully we could write this up pretty soon and submit it to the major journal. In terms of hepatology, I think Dr. Rajesh has covered this area very well just now. So for me, the most interesting part is whether measuring all the portal pressure gradient would change practice. So we are now performing a study to see if we could control the use of beta blocker by titrating according to the portal pressure gradient. So if the patient has a high portal pressure gradient, we would increase the beta blocker dosage and see if it would affect the outcomes of recurrent bleeding as well as mortality. And the last area, but not least, is EUS tumor ablation. This is a very interesting area to many people. It has been studied extensively in the past, but so far, in terms of penetration, I think it's only so-so. So there are several agents that we could use: alcohol and chemo therapy, RFA, and most recently microwave, as well as a new device called Oncos. This is a P32 fluid. It carries around 100 grays of radiation. So basically, it's an injectable radiotherapy. So in terms of EUS ethanol ablation, I think many studies have published, mainly for pancreatic tumors, showing a very good response as well as the efficacy. In terms of thermal ablation, I think Sandeep is an expert in this area, looking at the use of RFA. There are some advantages and disadvantages. RFA works by thermal conduction. So areas close to the probe would be more burnt, but areas more far away from the probe are less well burned. So kind of like a steak. So you get a well-done area and it's sort of like a medium rare area. So you don't want the medium rare area in the tumor area because you will still have some viable cells. So in terms of microablation, you imagine your home microwave. It causes a very synchronous movement of the cell, so it will have a more thorough ablation around the ablation zone. So maybe some potential advantages. So this is a usual device that we are using now, the EUS device from StarMed. And this is one of the procedures for a patient with pancreatic cancer. I think so far for cancer, still none of the groups have been able to show that USRFA could alter much of a clinical progress. So you can see the needle going in here. During ablation, we will see bubbles around the needle. Just now we did a contrast study because after ablation we wouldn't want to perform a contrast to see the area of ablation, and we will do this in the fan-like technique to cover the entire tumor. And then afterwards, another contrast study showing normal vessels within the tumor. So in terms of this study by the French group, this is mainly for pancreatic endocrine tumors as well as cystic neoplasms, showing a fairly good response, around 70 to 85% significant response up to 12 months. And in terms of microwave, we are looking to start human trials. This is the device from Frio Medical. Sandeep is also part of the group, so we look forward to starting this trial soon. The Achalasia is a very interesting area for me. We started using this procedure. It's a very easy procedure. It's similar to FNA. You're injecting a radioactive liquid into a tumor. You need to calculate the tumor volume before the procedure and give it to the company and see how much fluid that will cover the entire tumor. So it's an injectable radiotherapy. So the advantage over radiotherapy is the patient only needs one injection and doesn't need to come back repeatedly for the radiotherapy during a neoadjuvant course. So from now, the PANCO study showed that around 70 to 80% patient can have no tumor progression during a 24-week course, and then around 25 patients were able to downstage the tumor. So in conclusion, I think we are still in the period of growth for interventional EUS. New devices continue to come up to the market and opening exciting opportunities. But as a physician, of course, we need data from randomized trials to confirm the efficacy. And finally, in Hong Kong, we will be organizing the Asian EUS Congress this year in June. So it's been delayed many times since before COVID. And now the quarantine rules are completely relaxed in Hong Kong. So we look forward to welcoming you in Hong Kong in June. So thank you for your attention.
Now the topic is open for discussion. Dr. You gave a very nice explanation on the loose talk on interventional EUS. Any questions from or comments from the chairperson? And questions from the audience? We can take up one or two questions. While they are getting organized, in your institute, you have a malignant outlet obstruction inoperable. Routinely you perform dural stenting or you go for the EUS guided GG.
Yeah, I think our practice is changing now. So we are changing more towards the EUS guided restriction. In Hong Kong, we are lucky because most of the sets can be covered by the government. So in terms of cost, this could cover the cost much better. But of course, for the dural stent, it's an easy procedure. It's much cheaper. Even our residents to perform it confidently. So of course, it's a very safe procedure. So, but for us, we are slowly changing up.
The reason why I ask this question is, if you do dural stenting, you need to do more re-intervention. But if you do the EUS GJ, and it will be long lasting and it is much more. So nowadays they go proximal to the stricture approach. That's the reason why. If no more question, can you move on to the last topic in the session? We have a Mediastinal EUS clinical relevance by Dr. Malay Sharma. Malay Sharma is very popularly known in this part of the country, and he has done a lot of version work in Mediastinal EUS. He has written a book on Mediastinal EUS also. Over to Malay Sharma.
The mediastinal EUS what is the clinical relevance? Are we flirting? Because this is a field for pulmonologists. But till we have the time, till the pulmonologists do not come fully into their own, we have time to flirt, and we have time to diagnose mediastinal diseases, we have time to treat benign diseases, malignancy, we have time to do staging, and the tools we use are EUS and EBUS scopes. Sometimes we can do diagnosis, like in this case, patient is breathless, bronchoscopy cannot be done. We were able to do a EUS guided FNAC of a mass invading the IVC and make histological diagnosis. So what are the routes? When we do mediastinal EUS, there are two routes, trachea and esophagus. You can use both. By chance, I've been using endobronchial ultrasound, so I'm familiar with both the routes, trachea and esophagus. And the aim of using these routes is to compartmentalize the disease. Which compartment the disease is. Because unless we understand the compartments, we are not able to properly state the disease. The three compartments adjacent to mediastinum are neck and abdomen. So disease can be neck, thoracic cavity or the abdomen. And we are thinking when we are talking of the thoracic cavity as one compartment, it is again divided into two, the central compartment and the peripheral compartment. So whether the disease is in the central compartment or whether the disease is in the peripheral compartment, that's the important. Explaining very simply, very simple explanation. A lung cancer which has got a lymph node in the central compartment is inoperable. Or an esophageal cancer which has got a metastatic or a lymph node in the peripheral compartment is inoperable. So it is a change of compartment. You start thinking of mediastinum as a compartmental disease, from where the disease goes from one compartment to another compartment, and depending on the extension of the compartment, you have identified that this is the severity of the disease. The central compartment of mediastinum lies between two pleural sacs, and it is divided into superior mediastinum, anterior, middle, posterior mediastinum, and the mediastinum central to peripheral is connected by lung root. So this is the hilum of the lung, which is important. We have to understand in the hilum that there is a pulmonary artery, there is a bronchus, and there is a pulmonary vein. Arteries branches are above, there is the bronchus and the vein in this order. And why has God placed arteries above the veins? Because the pressure in pulmonary arteries is higher. They have to supply the entire lung, and the blood has to reach. And the veins collect the blood from below, and that is why veins are generally placed below the level of artery, evolutionary. So this is the connection. You have to understand a little bit about the hilum, the connection, left lung, hilum of the lung, the artery, vein, and all this. And that is what we have to see. The central compartment, what do we see? People see nodes. No, we see the central mediastinum as well as the spaces. And when we see the central mediastinum, we must be able to divide in our mind, okay, this is esophagus above, this is upper esophagus, this is mid esophagus, thoracic esophagus, this is lower esophagus, and this is abdominal esophagus. Because when we are dividing the central compartment again into several parts, we have to know where exactly is the disease limited, and that is why we have to be more precise with our anatomy while we are trying to define. In mediastinum, there are not many ligaments, hardly two ligaments, ligamentum arteriosum and pulmonary ligament in mediastinum. The abdominal cavity is full of ligaments, but in mediastinum there are spaces. Not only two, there are 10 spaces on the right, left of trachea, below trachea, above trachea, and the main space is subcarinal space bounded on one side by the bronchus, on the other side by the bronchus, and the lower side by an oblique line joining the bronchus, the two origin of the left bronchus. So these are the subcarinal area, subcarinal spaces, and these are the boundaries because you try and understand this is anterior, posterior, right and left boundary of subcarinal spaces. Because the disease will be within the spaces, disease will be within the lymph node, disease will be involving the compartment, the central compartment. It will be spreading, and in central compartment it will have an upper stent and lower stent, and the disease will involve the nodes in terms of tuberculosis, sarcoid or malignancy, tumor, abscess, and then we talk of vessels. So this is a node. This is a node in the neck, we can see, which is unapproachable by percutaneous route. But then you can do an EUS guided puncture of this node being very close to the common carotid artery. This is a node close to the arch of aorta, and you can puncture this node. And then there are nodes you have to classify which node, upper, middle, lower, which compartment. I'm not going into the details of this compartment, merely trying to emphasize that with proper modification, with proper technique, you can identify each and every compartment of the node. And sometimes when you identify the nodes are beyond your approach, like in this case, the node is beyond the aorta and pulmonary artery, you can be aggressive, you can go through the aorta and puncture this node for histological sampling to make a diagnosis. So coming back, basically what we're trying simply is diagnose tubercular or sarcoid. Basically tuberculosis is a destructive disease. When the lymph nodes enlarges, it is not allowed to enlarge, it liquefies and it coalesces, whereas sarcoidosis is an infiltrative disease. In the upper figure, the lymph node is big, 3, 4, 5 centimeters, and it continues to receive the blood supply, whereas in tubercular lymph nodes remain small, liquefy, coalesce, and that is how they are diagnosed, by their coalescence. And not only they liquefy to that extent that they create mediastinal abscesses, and when these abscesses are very large, they can be drained, they rupture into esophagus. You don't need to fear, sometimes because they are within the central compartment and they are within a limited space. All you have to do is open up the esophagus. If you want, if there is a need, wait, you can create a space, you can create a fistula, you can place a stent, and these abscesses will be cured, and they mediastinal abscesses large enough. If contained, can be treated. When we're talking of benign disease of the compartment, how do you see whether you see lumps? In the case of thymolipoma, EUS and EBUS, you can see, and then you can go puncture it. So this is not the only thing that the heart wants more. When there is a mediastinal sonographer, you want more. You want to puncture. You want to puncture. You are flirting. You are already flirting. Why not flirt more with the vessel? And when you puncture with the vessel, when you flirt with the vessel, this is the case of pulmonary artery thrombus. You are in your chamber. Once upon a time, as a mediastinal sonographer, you will be called to ICU. We will find the thrombus in the right pulmonary artery. Patient dying, imminent death, pulmonary artery thrombosis. Put in the scope, 15 seconds. See the thrombus and be prepared, because sometimes you can save the life. Sometimes you may not have facility to take the patient to pulmonary artery thrombolysis. And in this case, it was done. We published it. This is a case of right pulmonary artery thrombus, anticoagulant within the first, streptokinase within the thrombus, and then outside the thrombus. Not only because within the thrombus it will dissolve the patient, then outside the thrombus, the right pulmonary artery thrombus. The right pulmonary artery is almost looking at it, can go through. And this is what happens after 48 hours after this pulmonary artery thrombus disruption. Coming to the last part, last slide. The histological diagnosis requires EUS, EBUS. But start thinking in terms of compartment. Start thinking in terms of anatomy. Sometimes we have therapeutic options are available. Vessels can be punctured, should be punctured. If there is a need, if there is an indication, then there is no contraindication. And flirt while you can, while you have the time. Thank you.
Very nice question of Mediastinal EUS Malay. Whose territory this is? EUS Mediastinal. is going to be gastroenterologist, pulmonologist, or radiologist.
See, it is to each his own. The problem is there needs to be a passion in doing endoscopic ultrasound. I seldom find the passion in the pulmonologist. Like Eureka! They are not crying. Oh, I identified this structure. I've done this. Or I'm willing to do this. To tell them this prominent thrombolysis can be done. It should be done. But how many are willing to do it? So, let us do it for as long as possible, as long as we don't have any legal problems, but to each his own.
So it's predominantly subcarinal lymph node, aortopulmonary window lymph node, and paraesophageal lymph node biopsy, predominantly. To confirm whether a secondary metastasis or tuberculosis is there.
TB sarcoid malignant.
So if you try them to identify subcarinal, aortopulmonary, and paraesophageal, and that will be practical training for the gastroenterologist.
No, training for gastroenterologist goes much more. In mediastinal esophagus, there is a big bomb part. You have to how to do EUS in esophagus. No, in your mind, no cancer can be operated without endoscopic ultrasound.
Yeah, I think that point I want to drive home that particularly even if you have a growth in upper esophagus, you should look for the celiac lymph node also. Sometimes maybe involvement may be there. I think you told the point very well. Sanjay, you have some comment?
Yeah, you do. Is only linear or both linear and radial?
See, once I'm looking at this hall, this is my linear view. I can look at this. Once I learn to see this, radial is obsolete. Saying is, if you have money, buy 2 linear. More money, buy 3 linear. Don't buy radial. It is obsolete.
Even for staging of cancer?
You can do every staging. You rotate. You rotate the scope. You can do all the staging possible.
Well, can you pick a vascular embolisms of carotid artery, carotid artery for this thing?
The anesthetologist, the anesthetist, puncturing vessels right and left. They are making blind punctures. We are making puncture under vision. What is the problem? Press, just up till the probe. Press that site of puncture. The bleeding will stop.
Any scope of putting stents for vascular embolism rupturing in the esophagus also?
Oh, you have the heart. Have the heart and do it. Just don't even do it. Just do it.
Okay, I think we have come to the end of the thing. The signal has come. The organizers are ready with the next thing. And I must congratulate Dr. Malay and other speakers, Dr. Sandeep and Anthony, and my co-moderator, Dr. Nikhil, and my dear chairperson, Sulati, Sanjay, and others. Okay, thank you very much for this wonderful session.
Thank you, sir. Thank you so much. For the next session, can I please invite Dr. S.S. Sharma, Dr. Sunil Jain, Dr. Sanjay Rajput, Dr. Sandeep Vaishnav, and Dr. R.T. Gupta to please chair this session. Can I also request Dr. Pramod Garg and Dr. Setu Babu to please be the moderators for this session. The adjudicators, Dr. Zubin Sharma and Dr. Naveen Yadav. I will also take the honor to invite the first speaker, Dr. S.P. Singh. I request you to please be on the stage.
I think the most interesting talk would be that non-pharmacological management of NAFLD.
So I'm going to speak on non-pharmacological intervention in NAFLD. I'm happy that this subject is there because today, most of the things are pharma-driven, and here there are no takers for this. The global prevalence of NAFLD is 25%, about 1.9 billion. And if you rely on this meta-analysis from AIM, they say that in India is almost 39%. What does it amount to? Today, we have around 0.54 billion. 0. Out of around 1.5 billion. 1/3 of it is in India. We need to wake up. 55 crores, oh my God. What we had is a pandemic and most people are not bothered and people are after those pharmacological molecules which are only probably meant for a very, very small minuscule of this NAFLD patients. So what do? We must get pandemic ready and take the bull by the horn. How do we manage these patients? Management of NAFLD, one is through improving the underlying risk factors. We will identify what the risk factors in the patient, and next is ameliorating the insulin resistance and oxidative stress. And for improving underlying risk factors, we have to take steps to correct the metabolic syndrome and lifestyle changes. These take care of both insulin resistance and non-insulin resistance pathophysiology. The risk factors are basically be categorized into two categories. One is the non-modifiable one, the age, race, gender, everything. We can't do it anymore. But the modifiable risk factors include obesity, hypertension, type 2 diabetes, dyslipidemia, and lifestyle or sedentary lifestyle. Now, this is a very old recommendation from Mayo Clinic, and this is just to give a background of my talk. And these are the different molecules, medications which are there in our armamentarium. Obeticholic acid has not got approval, and in India we have Gallbladder, which is not recommended anywhere else in the world, it's only there in India. So you don't have much as far as drugs are concerned for management of NAFLD or NASH. And all currently recommended pharmacological treatments of NASH require histological diagnosis before initiation of therapy. Yes, many of us dilute that by using NITs or non-invasive markers like FibroScan and other FIB4 and other things, but still recommendations are not clear. Now, if you look at the various comparisons of the key NASH therapies, the newer ones which have come up and the old ones as well, look at the figures. Look at the percentage, that's so low, so poor. And this also, you see, actually only roughly 7.7% of the NAFLD patients you and I see have significant fibrosis, and it's only in these patients that all this jugglery has been done. If you look at again, the improvement in steroids, the figures are very low. Same thing, improvement in fibrosis, very poor results. Doesn't it give you a sense of the deja vu? Haven't I seen such bars earlier? The interferon era, when we didn't have all these molecules of hepatitis C, the good one, with so many molecules which are now there in the market for us. In 3 months we are curing the disease. But before that, it was like this. Unfortunately, if we take into consideration the different drugs we have, there is very little to choose between the placebo and we are looking at p-value. Somehow or the other we have to, make the p-value. So, in non-hormonal treatment, what do we have? Number one, most important thing is awareness and education. Awareness and education are the key, everything else is secondary. Next, your dietary modification and physical activity. Why I say awareness? See, earlier, even the physicians were not aware. They thought, fatty liver, this radiologist is just giving everyone fatty liver. What the hell is it doing? They're all artifacts. I read a very senior gastroenterologist, who is currently director of a central institute, used to say, this is the, sort of IBS like typically boldo. But now, everyone wants to be in the forefront of NAFLD research, NAFLD treatment. It's only if people understand, the physicians understand, the patient understand the implications of NAFLD. What is NAFLD? It's an iceberg, like the tip of the iceberg or the red flag, marker of metabolic syndrome, resistance, and so many things going on in the body.
It's like high fever, another fever. It can be so many things. You are, however, in this patient, you have increased mortality, you have increased cardiovascular morbidity, liver-related morbidity, chronic kidney disease, neoplasm, and so on. These are the list of the different diseases that are associated or the extrahepatic manifestations of those associations of NAFLD. So most importantly, it's a red flag, and we must confront this global, not epidemic, pandemic, and for this we need better awareness. And here comes, we have this problem. What is the right date? Are we obese? Are we okay? But if you tell someone obese, it is fashionable. Stop this body shaming. I've been to Washington. There's a hero in hepatology. He just goes on the podium and says, yesterday someone called me and said, you are a fat bastard. And they steal the show. You can't do body shaming. See, and if you have obesity, you have obesity. Obesity is not a good thing to have. How will this message go to people? Unless you tell them what is obesity, what is overweight, whether you like it or not, that is up to you. And we have to look at all the gods. All our gods are little obese, all the babies, devtas in India, they are all obese. In India, they have a special problem. खाते पीते घर के अगर हो तो your waist must be oversized. Otherwise, you are a lean fellow, you look unhealthy. We have done this study way back in 2014, and what we came to know that a third of NAFLD patients are ignorant about the harmful effects of obesity. 1/3. 2/5 of obese NAFLD felt that they were not obese. And 2/3 of NAFLD patients were neither educated by their physicians about effects of obesity nor advised to reduce weight. So how are they going to improve? And this is not the case in India only, even in the West, the same thing, majority of respondents in the study, the West, 75% believe that the prevalence of NAFLD in the general population in the country was less than 10%. Another study, only 1/5 report awareness of NAFLD. So most people are not aware of NAFLD. And this is a study from USA. Half of the primary care physicians reported being unfamiliar with the NAFLD and NASH differences, and more than half of the specialists use non-invasive diagnostic tests to confirm NASH. So America may be there, don't worry. So see, awareness and driving home the simple things, very simple things are there, which can prevent NAFLD. Forget about treating NAFLD. And it should start from school. Do you ask a NAFLD patient to do exercise? Exactly, most of them are not asked. And even if they are there, it's very sort of mild sort of thing. In my training, it's very simple. If you don't exercise, unless you have some morbidity, something, you will not come to me again to go to another physician and tell them, I'm not bothered about your feet. What is the advice regarding exercise? It's very clearly shown that subjects with suspected NAFLD reported a lower weekly duration of exercise than did those without suspected NAFLD. And adults with suspected NAFLD had a lower cardiorespiratory fitness level than those without suspected NAFLD. So it is beyond doubt that exercise has a huge effect on NAFLD as far as improving ALT, in reducing the fat in the liver. Different studies, this is a study of Suzuki et al., who showed the changes which occur when you do exercise and lose weight. The more the weight you lose, people who don't lose weight, their ALT remains elevated, they continue to have fatty liver. And if there is more than 5% reduction, there is a dramatic change in their liver appearance as well as their ALT. The same thing has been shown in a Korean study, Indian study from SGPGI, and this is again from Hong Kong. So it's very clear that exercise has a huge effect and it is associated with remission of NAFLD in a dose-dependent manner. Depends on how much body weight you lose. Weight loss is the primary therapy for most people with NAFLD. This is very important. I won't go into detail. This is a very important slide. That if your weight loss is 3%, not much,
then only steatosis gets affected, and the weight loss increases to 5%. The ballooning inflammation gets less and less. With weight loss of more than 7%, you have NASH resolution, and with that higher, you have a weight loss. So basically, you need to have a 7% to 10% of body weight loss and about half a kg per week. Regarding diet, there are lots of diets. But if you ask me, I don't go into all the details of diets. The diet has to be, now you can order weigh your food and do it. Diet has to be reduced gradually. I don't advise any change in sugar or anything, but the amount should gradually be reduced until the patient starts losing half a kg per week. Exercise is very important, but less important than diet again. You can do exercise only for 1 hour, not more than that. Which exercise is better, aerobic or resistance exercise? There are studies which have compared, and both are almost equal. But if you have a combination of the two, that is better. If you do a combination of both aerobic and resistance exercise, weightlifting and other muscle building, plus running or jogging, that's the best thing to do. And how much should you do it? At least 150 minutes a week. You can take 2 days of leave. And in diet, one of the most important thing is, NAFLD, the soft drinks. People who take, especially children, has been seen that children who take a lot of soft drinks are bound to get NAFLD and they have NASH. So it is very important that this consumption is reduced. And now this is the most important thing. Now, if you see a patient, you have to give them a target. So, how much weight should I reduce? Now, this target weight should be 22 into height in meters square. If you have, you can calculate this for a patient, or the patient can do his own calculation. It's very easy. Then definitely the fat, almost 99% of the fat will disappear. The other simple thing is target weight. How much should the waist be? Half of the height. Just measure the height. If it is 180, then it is 90. But if the patient is short, say 150, then his waist should be still less. You don't have absolute value. So this is very important. Two things: target waist and target weight. There have been some studies in yoga, but they have not been very fruitful and they have not been well conducted. You need more studies on that. High quality RCTs are oriented in yoga. There are adverse effects in yoga also. And alcohol, there is complete they are clearly shown that even small amounts of alcohol in patients with NASH produces more fibrosis, more chance of cirrhosis, more HCC. It is better to abstain from alcohol in NAFLD. The same thing goes for smoking. Smoking is also an effect of a NASH and fibrosis especially. So no smoking. The take-home message is awareness, education, regular exercise, control on calories, soft restriction, target body weight which I mentioned, and avoid alcohol and smoking. Thank you.
Thank you, Professor Singh, for an emotional talk. I'll include the next talk because you have conveyed your message. LSM, that is the lifestyle modification, is the most important level 1 treatment. Can we request Professor Anita to speak on endoscopic grading?
Thank you so much. Thank you, Dr. Mahesh, Dr. Sandeep, to all the course organizers. What an honor it is to be here. This is my 3rd visit, and Mahesh knows that Jaipur is my favorite city, so truly an honor to be here among all of you. So what I'm going to do in the next 15 minutes is talk about endoscopy, specifically inflammatory bowel disease. I'd like for us to be able to be familiar with the features that we look for in order to ensure that we have a quality report in IBD, and then to be able to distinguish and appropriately assess disease activity. And we'll also look at post-surgical anatomy and some of the anastomoses, and specifically the J pouch and our familiarity with that. So you're in clinic, it's a busy day, you've already seen multiple patients, and you get a new referral. And this referral, all it reads for you in that piece of paper that you have is that you have a 33-year-old patient who has Crohn's disease on adalimumab with active inflammation in the colon and the ileum, has been on therapy for 2 months, and basically they're asking you for help. They give you some labs, the CRP is 13, the fecal calprotectin is 200, and there's only one colonoscopy report, and this is what you get. Okay, so this is the frustration when we talk about endoscopy and specifically for inflammatory bowel disease, because we don't have good reports for us to be able to share among colleagues and be able to evaluate appropriately what our next steps should be for our patients. So what are the 5 Ds in endoscopy when we talk about inflammatory bowel disease? It's to diagnose. You take your biopsy, you're able to differentiate between Crohn's disease and ulcerative colitis. It provides details, that initial colonoscopy, of course, that thereafter, the ongoing colonoscopies you perform. It helps being able to appropriately document what you see, and then helps you determine what your next steps should be, whether you want to change therapy or regardless of what steps you'd like to take. So I urge each of us that when we perform our endoscopy, specifically for patients with inflammatory bowel disease, we should incorporate some standardized components to that. And specifically, we should incorporate the disease phenotype, whether we're talking about ulcerative colitis, described to yourself and to others who may see this referral as far as what is the distribution of the disease. Is it limited to the rectum, left-sided, pancreatitis, that's E1, E2, and E3 respectively. And for Crohn's disease, the same. We use the Montreal classification to be able to determine the disease distribution, the onset of the disease, specifically the age, and then the behavior of the disease. Is it inflammatory, stricturing, penetrating, etc.? So this should be included in your endoscopy report when you're performing and evaluating each individual patient. So again, being able to emphasize that we want to better understand the extent of the disease. We want to be able to describe, is it continuous inflammation? Is it patchy inflammation? Is the terminal ileum involved? And then being able to appropriately describe what you see at the time of your colonoscopy. Is there erythema, friability, bleeding, ulcerations, etc.? All of these are excellent descriptors to include in your endoscopy report for yourself, for the patient, and then of course if you send a referral to another colleague, they need to be able to see this. So unfortunately, there's no standardized endoscopy report or disease activity score that we all use consistently. In fact, there's so much variety and variability among which ones we use. And therefore, there's no consensus over which is superior. So I urge each of you to find a scoring system that you're familiar with and incorporate it consistently in each of your endoscopy reports. And in fact, we've emphasized the importance of this even when we talk about how we're evaluating disease activity. For ulcerative colitis, we've now included the endoscopic assessment and specifically an endoscopy scoring system, whether it's the Mayo score or the UC-EIS, which I'll describe as well, as far as how we evaluate the disease activity as well as treatment response. And so for ulcerative colitis, there are different endoscopy reports the scoring systems you could use. The UC-EIS, which is the UC Endoscopic Index Severity, the Mayo Endoscopic Subscore, and then a less commonly used one, which is the UC Colonoscopic Index of Severity. The UC-EIS, as you can see, is based off of an 8-point scoring tool. It grades 3 basic endoscopic findings: vascular pattern, bleeding, and the presence or absence of erosions and ulcers. Now, notably, friability is not part of this scoring system, and then also the limitation is it's based off of the worst segment of the colon. So really being able to determine as far as the entire colon it's not really appropriate for that. Certainly, it's based off of the worst section. The Mayo score is based off of a 4-point scale, and accordingly, you grade it from a 0 to a 3. Mucosal healing, and we define mucosal healing as far as having a Mayo score of 0, which is ideal, or 1. And then this is the most commonly used scoring system, especially for clinical trials, recognizing that it's probably a little bit easier for us to perform, and also we use a modified Mayo score that we could evaluate each individual segment. Now, notably, the modified Mayo score now includes friability and says friability is a Mayo score of 2. So we've become a little bit more stringent as far as defining mucosal healing. So here for your familiarity is the Mayo 0, 1, 2, and 3. And again, it's based mostly off of the presence or absence of those ulcerations. And then, of course, if there's spontaneous bleeding or just limited to friability in and of itself. If we were to compare the UC-EIS to the Mayo score, you can see as far as what they're mostly based off of, but quite similar overall as far as the endoscopic features that are being reported or described, and then you can see respectively whether it's the UC-EIS score or the Mayo score, they pretty much work alongside each other as far as those variables that I mentioned earlier. So let's switch gears to Crohn's disease. Again, different scoring systems. There's the CD-EIS, which is this Crohn's disease endoscopic index of severity score, and then the simple CD-EIS, really, so the simple endoscopic score for Crohn's disease, and then Richter's score, which I will describe as part of a post-operative scoring system that can be used as well. Now, the CD-EIS, you can see, is quite cumbersome. Lots of variables, lots of numbers, lots of math. And so because of all of this, it's been modified. So rather than using the CD-EIS, we've now switched to the simple endoscopy score in Crohn's disease. Again, I urge you to become familiar with the scoring system and use this for every Crohn's patient when you perform your ileocolonoscopy. It's based off of 5 bowel segments: the rectum, the left colon, the transverse colon, the right colon, as well as the ileum. A sum of all the variables, and again, these variables are scored from a 0 to a 3 based off of each, and it's much more simpler, less math, less calculation, and also less inter and intra variability compared to the CD-EIS scoring system. So here's an example of how you would use this score as far as incorporating those variables I mentioned to you, and then whether it's a score 0 or up to a 3, based off of presence of ulcers, the extent of the ulcerated surface as well as the affected surface, is there any presence of narrowing or strictures, and then on each of those 5 segments I described. So let's switch gears a little bit to ileocolonic anastomosis. This is something our surgeons perform for us for Crohn's disease. And then at the time of your ileocolonoscopy, you're a little not sure what our surgeons performed. Was it an end-to-end? Was it an end-to-side? Or a side-to-side ileocolonic anastomosis? What we know is with the Richter score, using this score helps us determine what's the chance that our patient will require an additional surgery if we don't initiate or continue with appropriate therapy. So the Richter scores mostly differentiate on the I2A, which is ulcers at the anastomosis, compared to the I2B, which is ulcers before the anastomosis or the neoterminal ileum. This differentiator really is the strongest predictor of whether our patients are at a higher risk for disease progression, as well as a higher risk for needing a reoperation, more surgeries, and additional complications. So here, based off of the Richter scoring system on the ileocolonoscopy you perform, you're evaluating the anastomosis, you're looking for the presence of ulcers. Is it limited to the anastomosis alone, or is there terminal or neoterminal involvement? And if there is, you can see respectively, that's a higher score, and this predicts that your patient will have more complications to come. So familiarizing ourselves with a different type of anastomosis, sometimes our surgeons tell us exactly what kind of anastomosis was performed, sometimes they don't, so it becomes a little bit of a guessing game for us. The end-to-end anastomosis is probably our most simple and our most preferred one because it's a straight shot. You go from the colon into the neoterminal ileum. The side-to-side anastomosis is a little bit more complex in a sense where you have 2 blind ends. And based off of that, in order to evaluate the neoterminal ileum, what you need to do is retroflex to be able to enter into the neoterminal ileum. Sometimes I get a referral and it says that the patient has a stenosis, but they weren't really familiar with the fact that this, in fact, was a side-to-side anastomosis, and as such, it goes two blind ends, and then you need to retroflex in order to pop into that neo-terminal ileum. So this is your first blind end that you're seeing, and then here's your second one, and then as you advance and you're seeing both of those, now you're basically doing that retroflexion in order to enter through into that neo-terminal ileum. And with this, you're able to evaluate and now see that, in fact, the neo-TI has and is involved with ulcerations. The end-to-side anastomosis, this is another type of anastomosis our patients may have, and based off of that end-to-side anastomosis, in order to be able to evaluate that neo-terminal ileum and perform your Rutgers score, it's basically a big wheel sharp up in order to determine what you're seeing. So again, familiarizing yourself with those anastomoses, is it a side-to-side, is it an end-to-side, this helps us determine whether our patients are doing well post-operatively or what we're seeing. So here's that big wheel up in order to enter and traverse into that neo-terminal ileum and be able to appropriately evaluate the neo-TI to see, again, if you're performing that rigorous score and you're evaluating to see if there's any ulcerations or other problems within that neo-TI. Let's switch gears to the pouches. There's different pouches. There's the S pouch, the J pouch, the W pouch, the K pouch. There's multiple different pouches, and perhaps the most common is the J pouch. And the J pouch, again, when you're performing your pouchoscopy, it's important to be able to appropriately define your landmarks. And here I've listed out, and you can familiarize yourself with these landmarks, but it's important to be able to know exactly what you're looking at the time of your pouchoscopy. And so then you look, based off of your pouchoscopy, is there active inflammation or not? And so on the left is normal mucosa, and on the right what you're seeing is ulcerated, whether it's the pouch, you're evaluating for pouchitis, whether it's the afferent limb, or whether you're dealing with cuphitis. So this is also important. There is a scoring report that's also used for evaluation of the pouch, and then more recently there's been a modified scoring report that really specifically informs us that we need to look at the body of the pouch, we need to look at that inlet, the pouch inlet, which is that distal ileum, as well as the pre-pouch ileum, to evaluate whether a patient has potentially newer complications of their pouch, and perhaps it's even Crohn's disease of the pouch. So back to our patient, remember that initial report, not good enough. We need to be able to evaluate a little bit further. So what I would urge each of you when you're performing your ileocolonoscopies is to, again, have all those appropriate descriptors so you and your referring consultants know exactly what you're looking at, and we're all speaking the same language. And this brings me to my take-home points in the sense of it's very important in order to have a quality IBD endoscopy report, include your Montreal classifications, include your endoscopic descriptors, remember the 5 Ds. Be able to find a scoring system you're familiar with, use it consistently, and use it not just for every single patient at the initial, but also thereafter, after you've initiated therapy, to determine whether you need to continue therapy or change therapy or what. And then again, familiarize yourself with pouch anatomy as well as the ileocolonic anastomoses. Don't assume that your patient has a stricture or stenosis just because you can't get into that neo-terminal ileum. Be able to appropriately familiarize yourself on the evaluation. And with that, I thank you so much for your attention. Again, truly an honor to be here. Thank you.
Thank you very much, madam. I think it's a wonderful talk. Before you leave, I thought I'd just ask you a question. What is the endoscopic and clinical correlation? You have different endoscopic, which are actually dynamic events, depending on the intervention. So what is the clinical correlation?
So the clinical correlation absolutely is that if we don't see endoscopic improvement, mucosal healing, and response, then clinically we're also seeing that with active inflammation, we're seeing elevated C-reactive protein, we're seeing elevated fecal calprotectin, we're seeing more anemia, etc. So more complications, which goes hand in hand with what we're seeing on the mucosal assessment as well.
Thank you very much, ma'am. Now I request Dr. Naresh to speak on the difference between the white light and color light. I think RGB is actually makes the white light, the red, green, blue.
Thanks, Setu and the ISG for having me here. I'm actually not going to speak about the differences in white light endoscopy and other techniques, but basically to address certain tricks and tips which I think we should go back home and practice.
Yeah.
We all know that there are quality indicators for colonoscopy, our breath, the ideal intubation rate, the withdrawal time, we have the ADR and so on and so forth. But do we have something for the upper endoscopy? Or is it time that we have something for that? It's a given that a sedated patient would make things easier for you to assess the mucosa. If you use better quality endoscopes, which are high definition endoscopes and monitors, you get better quality images, and that will make a difference. The use of digital chromoendoscopy and appropriate biopsy protocols will definitely improve your outcomes and pickup rates. So that's a given. Let's try and focus on something a little different as well. The first thing is quality of preparation. Most of us don't follow this religiously, but it's important to have a patient who is adequately fasted. The idea of taking a patient who comes to your OPD in the morning and say, come back 2 hours later, you had breakfast, all right, come back 2 hours later and I'll do an endoscopy for you before you go home, I don't think is very appropriate. A pre-endoscopy rate of cybeticol versus cysteine does seem to make a difference, both in our own experience as well as some small published data. Obviously, we've discussed sedation and use of an anticholinergic thing of relaxant like Buscopan again adds to the comfort of examination. So I think if you want good quality endoscopy, we must have a patient who's in fasting long enough and maybe use a cybeticol and acetylcysteine to clear away the mucus. The use of a water jet will also help you get a better feel. We know that endoscopy is fraught with potential blind areas, and there are several of them. And we need, therefore, to minimize these blind areas and examine as much as the mucosa as is possible so that we do not miss a lesion. And for that, we need to have a systematic approach at looking at the mucosa and not only look at it but also document. The Japanese have their own SSS protocol, but this is a more simplified one that I picked up from the Korean group, that they look at least 3 images in the esophagus, several images in the stomach, in the duodenum, in the D2, and also of the ampulla, which is also taken as a quality indicator of upper GI endoscopy. Another quality indicator of upper GI endoscopy is the pickup of the inlet patch. We all know that we miss that very often. And if you pick up inlet patch more often, that means your examination, the proximal esophagus, is of a good quality. So examination and documentation is very important. The next thing is this very simple thing which we often forget. Any lesion here, obviously you can't see anything much, but once you inflate, you find that the gastric folds separate out and you can recognize these lesions. And if you add chromoendoscopy to it, you find that this patient actually has 3 lesions. This was actually a martum of the stomach that had multiple lesions, and if you did not insufflate and sort of look at the mucosa carefully, interrogate it, you can easily miss these lesions. So adequate insufflation is an absolute must for good quality upper GI endoscopy.
The next issue is how much time do we spend. In colonoscopy, we have certain definitions. But I picked up 4 studies, one at Barrett's from the United States, where they said that you need to spend at least 1 minute per centimeter of Barrett's epithelium and you pick up more dysplasia or cancer. A study from Singapore showed that endoscopists who were slow, who spent more than 7 minutes, picked up double the lesions than the fast endoscopists. A Japanese study showed that again slow endoscopists picked up more cancers. And the Korean study showed us that a withdrawal time, that is from the D2 back to the cricopharynx, a withdrawal time of 3 minutes or more picked up more adenomas and cancer. So we have data here guiding us that we do need to spend more time. There is no alternative to this. If you look at how many gastric cancers we can miss, I just picked up one study, there are several to this. About 9.1% of gastric cancers were missed in the previous OGD. These are patients who had gastric cancers in second endoscopy. They looked at their previous endoscopy and they found that at least in 9% of them, they could identify some lesions that were there. And the quality indicators that were missing in these endoscopies were the time spent, which we have discussed, the imaging documentation, we've discussed that again, and of course, the importance of a biopsy protocol. You must biopsy anything that is suspicious, and must also target the biopsy appropriately. The number of biopsies also needs to be appropriate. So it's important to spend time, and I purposely put up the Japanese meal on the left, because they are the guys who taught us so much about these quality indicators, and the time that they spend and their patience is something that we really need to learn about compared to the one on the right. The 2-minute endoscopies need to be banned. There are other techniques that we can use to pick up these lesions. And this is an interesting technology that comes from Fuji, which is called the linked color imaging, where you have this pinkish ones as compared to the purple, which is pink or reddish ones, is showing that is possibly neoplasia, while the information comes up more is purple. So this kind of gives us a red flag technique to pick up suspicious areas. Now look at this, it's very interesting. If you look at the first frame, just see minor abnormality, easily missed. If you go closer to it, you can pick up that morphologically it looks abnormal. And if you do chromoendoscopy, you can make out the lesion very clearly. All of us know that the Japanese endoscopists pick up these lesions very well. We say, oh, they've got fantastic endoscopes. They have a great deal of magnification and zoom endoscopy and so on and so forth. But remember that they were picking up these patients even 30 years ago when they didn't have any of those scopes. So what is the difference? The difference was patience, a passion to pick up and look at it closely, and of course the use of chromoendoscopy. Even for those of us who do not have access to great quality of technology and high-end endoscopes, nothing is stopping us from spending more time and using chromoendoscopy, dye-based chromoendoscopy to interrogate the lesions. Another cheap technique that we have used, this is from the work of Dr. Pradeep Bhandari that published. He showed that in Barrett's that you could use acetic acid endoscopy. We have used this in the colon as well. And here you see a little chunk of Barrett's there standing up on NBI. And when we spray acetic acid, which is nothing but vinegar that I picked up from my kitchen, and sprayed it over the mucosa, you can find out such fantastic details on the surface that you can really pick up these lesions very well. And this is an example of that, where we picked up an early
a high-grade dysplasia or a plasma in situ with this loss of acetyl-whitening reaction. The reddish areas are the suspicious areas, and that we could easily do an EMR and resect it. So simple techniques like this can go a long way in improving your detection rates and outcomes. We have other devices like caps for magnifying observation, and you can just apply this at the distal end and just allow it to project just a wee bit out of the tip of the endoscope, and it helps you to get a steady field and look at that surface very clearly. Here you can see that if you don't use the cap, you get a very kind of distorted view because you're not seeing it off fast. So if you can get an off-fast view, you can make out better details as we see on the right picture. And the tricks to do that is not directly go and hit the mucosa, but to first suck so that the mucosa comes and opposes the scope tip, and then again inflates a little air so that it gets the right distance with the tip of the scope and the mucosa. That's where you get great quality images for you to integrate appropriately. This is a patient that we actually did a resection of a adenomatous lesion, and when we saw 3 months later, it looked pretty good. And see what we found when we just did a scar assessment underwater. And you can clearly make out that there is a residual lesion there, which we finally resected. So just using water, which brings out the surface much better and also provides magnification, is an excellent way that you can improve your images in your endoscopy room, and believe me, it doesn't cost anything, obviously. You have very expensive endoscopes, great images. If you have access to them, great. You're lucky. You can pick up these things. This is a picture that Dr. Mohan Ramchandani shared with me a little some time ago. You're lucky if you have this. What if you don't have? Do we go in for artificial intelligence? No. Artificial intelligence is not the way to go, but just get more familiar with whatever techniques are available, practice, learn, get someone to demonstrate these things for you. And once you pick up these skills, you'll find that you don't have to depend on that much of technology, but you can use whatever resources you have to get good outcomes. So finally, what should a referring clinician expect from the endoscopist today is first is intelligent endoscopy, which starts before you pick up the endoscope, that is understanding the patient's problems and risk factors. Use your endoscope to its maximum capability with some of the techniques that I have spoken about. A meticulous assessment, good endoscopic interrogation, and as Dr. Anita also emphasized, an accurate description of the lesions, excellent documentation, and appropriate endotherapy. I'll stop here, and I take this opportunity to invite you later this year the conference at Bangalore.
Thank you, Dr. Naresh. I think you emphasized the point. The time taken to pick up a lesion is more important than how fast you did the scopy or how much time you spent on picking up the lesion and suspecting the lesion. One small question: how often you need to use NBI? Or do you give a clear-cut indication? These are the places where I use NBI. Otherwise, okay, I'm like.
I think it's a great question. See, if NBI is available at the tip of your button, so you don't have to do anything different. So when we do an endoscopy, we always do white light endoscopy. And if I find something that I'm uncomfortable with, and maybe a little change in color, maybe a little depression, maybe something raised, I will put an NPI and interrogate. So NPI is only to interrogate something that is suspicious, but not, you don't go around with NPI looking at the entire surface of the.
Fortunately, all the current endoscopes are coming with Yes, sir.
How do you differentiate between an NBI coming with another company with a BLI coming with another company? Do they service being the same or they're different?
Thank you, PK, for the question. Remember that the entire basis of advanced imaging that we are doing with chromo is looking at the microsurface and the microvessels. Whether you use NBI or BLI, you're getting the same kind of information. You can virtually use the same classifications. So if you're good in one, you can switch over to the other without any problem. There's no great learning curve. You just have to know what the vessels look like normally, what are the abnormal, what the surface morphology is.
Thank you, Dr. Naresh. I think we have the last topic for the day. I invite Professor Guru to talk on it. Something which is difficult to talk on a new syndrome of IgG4, multiple syndromes in fact.
Good afternoon, everybody. I would like to thank Indian Society of Gastroenterology for this wonderful opportunity for me to present on this topic, IgG4 related disorder, diagnosis and management. The following are my disclosures, none of them is relevant to this talk. My agenda for today is to take you through the diagnostic modalities involved in diagnosis of IgG4 related disease. I would like to focus on autoimmune pancreatitis, as you can see in this picture, that's central to all the IgG4 related disease, and also touch a little bit about the other organ involvement as well. Then discuss about how to induce remission and also strategies to maintain remission once it has been achieved. As I already mentioned, IgG4 related disease is a spectrum which could involve IgG4 related pancreatitis, or what we call as type 1 autoimmune pancreatitis. It also includes IgG4 associated cholangitis, or then IgG4 associated cytidinitis, then tubulointerstitial nephritis from IgG4, and mediastinal fibrosis and retroperitoneal fibrosis, to name the diseases in the spectrum. The clinical presentation depends on the organ which is involved. It could be anywhere between dry eyes and swollen upper eyelids in case of IgG4 dactyradenitis. It could be swollen submandibular gland and dry mouth in case of IgG4 associated cytidinitis. Very often we come across obstructive jaundice and new onset endocrine insufficiency. That's the manifestation of type 1 autoimmune pancreatitis. We get just biliary tract obstruction and obstructive jaundice and IgG4 associated cholangiopathy, and fever malaise is a presentation for IgG4 associated retroperitoneal fibrosis. There are several diagnostic guidelines. Each of them have their own merits. The Japanese, and most of them are for type 1 autoimmune pancreatitis. The Japanese Pancreas Society guidelines requires diagnostic ERCP. We do not perform diagnostic ERCP anymore in the United States, so it's kind of not favored. We have the ICDC guidelines, which is complex, algorithmic, but it's very sensitive and accurate, and it's mostly used for study purposes. The most common and the most straightforward diagnostic guideline is the HISOT criteria. This was published by Suresh Shari from Mayo way back in 2006, and it's easy to use, easy to remember, and this is it's best for autoimmune pancreatitis and IgG4 associated cholangiopathy. So HISOT, as all of you know, is an acronym wherein H stands for histology, I stands for imaging, S for serology, O for other organ involvement, and RE for response to treatment. One or more of these features suggest autoimmune pancreatitis. Again, this was initially proposed by Suresh Shari from Mayo Clinic. As far as histology is concerned, the buzzwords we are looking out on the pathology report is dense lymphoplasmacytic infiltrate, and in autoimmune pancreatitis, it's just periductal, and there should not be any granulocytic infiltrate. Remember, granulocytic infiltrate comes in type 2 autoimmune pancreatitis, which is clinically and distinct from type 1 autoimmune pancreatitis. In addition to lymphoplasmacytic infiltrate, we also expect two of the following: obliterative phlebitis or storiform fibrosis, and abundant IgG4 cells. By abundant, I mean greater than 10 IgG4 cells per microfield. If only one is present, it's a low grade level 2 as per ICGC criteria. So how do we obtain this histology? Previously we used to be performing ampullary biopsies. And again, I want to warn, ampullary biopsy is associated with pancreatitis risk, and the sensitivity is just 64%. There are false negative in case of ampullary biopsies, and two of the 6 patients in a study had a pancreatic adenocarcinoma, and 7 of the 18 had celiac disease. So ampullary biopsy is not perfect. What we do in the United States is more EUS guided biopsy, and the Mayo had an enormous series where they used a true cut type needle. Unfortunately, the true cut type needle is no longer available in the United States, and also it was associated with post-EUS pancreatitis and bleeding. Now we are, in my clinical practice, I am using more the Francine or the Coke type needle. And these newer needles, there are some case series published out there, but more studies need to be performed. But these give really good chunks of tissue, and it satisfies our pathologists. Moving on to imaging, the classical parenchymal imaging we see is diffuse enlargement of the pancreas with delayed enhancement. Sometimes we also notice the rim-like halo. Again, these are the 3 buzzwords we are looking out for. This is a typical manifestation or a radiological feature of autoimmune pancreatitis. Occasionally, we get biliary enhancement, but we also need to be cognizant of some of the atypical radiological findings. Instead of diffuse, we may just get segmental enlargement and just segmental delayed enhancement. And again, the abnormal imaging is probably the most common of the HISOT criteria, and it's seen in 85% of the patients. Pancreatogram, again, in the United States, we know we have moved away from diagnostic pancreatogram or diagnostic ERCPs, but we can see these features on MRCP as well. One of them is the diffusely irregular narrow pancreatic duct. But what is important is the strictures involve more than 1/3 of the duct, and sometimes we do notice multiple strictures, as you see in this picture, but classically they do not have any upstream dilation. And also what I found was interesting was sometimes side branches arise from the strictured segment in autoimmune pancreatopathy. So how do we differentiate pancreatic cancer from autoimmune pancreatitis? This is a question which comes up often. Focal mass with pancreatic ductal dilation favors malignancy, whereas factors favoring autoimmune pancreatitis are if you just have diffuse sausage-like enlargement or low attenuation halo and with a non-dilated pancreatic duct, then these are factors which favor autoimmune pancreatitis. And the enhancing bile duct wall is seen only in 50% of the autoimmune pancreatitis patient. And remember, cholangitis and cholangiocarcinoma can also have enhancing bile duct wall. This was a study published by Mike Levy and his colleagues at Mayo Clinic, published last year in Gut. This study looked at EUS versus artificial intelligence in making a diagnosis of autoimmune pancreatitis. Unfortunately, there was only 50%, or the kappa was only 0.5 as far as inter-observer agreeability among 7 endosonographers were concerned. And also the sensitivity on EUS was only 54% and the specificity was only 82%. However, when they included this EUS and they loaded it and they created an AI algorithm, the sensitivity and specificity was around 88.2%. So this is where we are heading, AI to diagnose autoimmune pancreatitis. Moving on to serology, IgG4 is elevated, and anytime it's elevated greater than 2 times upper normal limit, that forms a part of HISOT classification as well. But unfortunately, only half the patients meet the IgG4 criteria, and elevation does not definitively exclude malignancy. Also, what we should be looking out on peripheral smears or on the complete blood count with differential is eosinophilia. Nearly 25 to 50% of the patients can have eosinophilia. There are other autoantibodies, including antibodies to ANA, rheumatoid factor, lactoferrin, and carbonic anhydrase, which could also be elevated, but these are all non-specific. Moving on to other organ involvement, this is where the clinician should be really aware of other organ involvement. Unless we know what to look for, our eyes won't look at it. So typically, this is very classical. This is a picture of a biliary stricture on EUS. This lady has a swollen lacrimal gland, which indicates lacrimal gland involvement. This patient probably has pulmonary involvement. But this is a picture which everybody should be familiar with as far as CT scans are concerned. This represents aortitis, and this could be seen in other organ involvement as far as autoimmune pancreatitis is concerned. And this picture depicts retroperitoneal fibrosis. And this picture represents the classic wedge-shaped infarcts you see in autoimmune involvement of the kidneys. This patient had tubular interstitial nephritis. With just 2 weeks of treatment, the kidneys, all the wedge-shaped infarcts disappeared. Again, that was diagnostic for autoimmune pancreatitis. If the clinical judgment favors autoimmune pancreatitis, and if all the other criteria are negative, after a negative biopsy, we can subject patients to a prednisone trial. And by this, I mean prednisone of 40 milligrams once daily for a check CT or imaging after 2 weeks. And if there is an improvement in symptoms along with radiographic findings, that is also a diagnostic criteria for autoimmune pancreatitis. Again, CA19-9 improvement is not sufficient alone. I'm going to switch gears a little bit and discuss about management of IgG4 related disease. The first question which comes to mind is what happens if patients are not treated? If patients are not treated, they will have persistent jaundice or pseudocyst, or they may have a persistent biliary stricture, or in terms of kidney disease, they could have hydronephrosis or persistent tubular interstitial nephritis. Also, it's not clear, but we do know that there is risk of diabetes, but also we need to know that nearly 10 to 25% of the patients, they improve spontaneously without treatment. So when do we really treat? As per the guidelines, we treat symptomatic or asymptomatic patients. Symptomatic is quite obvious, but in asymptomatic patients, we treat them if there is persistent abnormal imaging on the scans, or if there are other organ involvement, or if there are persistently elevated liver function tests in IgG4 related sclerosing cholangiopathy. So the treatment involves use of steroids if there is no contraindication. The dosage is usually 40 milligrams once daily, and we do it for at least 4 weeks. If the patient requires a little bit more, the weight-based dosing is 0.6 to 1 milligram per kilogram. And we usually treat them for 2 to 4 weeks and then assess for clinical imaging and labs and see if they are responding. Once they have achieved remission, we taper the steroids 5 milligrams. Typically, the taper starts at week 5, and we do an 8-week taper. And if a patient has contraindications to steroids, then we use rituximab often. So nearly 30% of the patients with autoimmune pancreatitis, they could have a relapse. And fortunately, there are studies which help us to predict these relapse. If the pre-treatment IgG4 is greater than 4 times the upper normal limit, or if IgG4 is persistently elevated after steroid treatment, or if a patient has diffusely enlarged pancreas or proximal biliary tree involvement or multiple other organ involvement, then they are likely to relapse, and we do need to consider maintenance therapy right away. The maintenance therapy, the options are, the Japanese usually favor no-dose 5 milligrams prednisone indefinitely, but in the United States, we use the immunomodulators. The immunomodulators which we have used are azathioprine 6-MP and the Cellcept as well. But the new kid in the block is rituximab. Rituximab is useful both for induction and maintenance. I'm going to summarize in a couple of slides. This is the management algorithm. Once we can diagnose autoimmune pancreatitis based on the classical clinical symptoms, and also look for other organ involvement, including retroperitoneal fibrosis and salivary glands. involvement. If a patient's we do check their blood sugar, make sure that their blood sugar is optimized. If they are jaundiced, we do perform ERCP. Then the next decision point is, can they tolerate steroids? If they can tolerate steroids, then we initiate steroid therapy, as I mentioned. If they cannot, we start rituximab. And again, we hope to achieve remission. But in patients, as I said, who are at risk for relapse, so 30% of the patients with diffuse enlarged pancreas, elevated IgG4 levels, multiple organ involvement, then we start maintenance therapy as well. And if there is relapse, we then consider retreatment. This is the ICTC algorithm. So to summarize, diagnosing autoimmune pancreatitis or any of the IgG4 related disease is challenging. IgG4 is often not elevated. Tissue diagnosis is often not possible. Diagnosis requires astute clinical judgment and a vigorous adherence to the guidelines. Extreme vigilance is needed to exclude pancreatic cancer. I typically see these patients in clinic and counsel them that pancreatic cancer could be missed in several situations. Initial treatment is steroids. If steroids is not possible, rituximab is an option. Relapse is common in type 1 and with biliary involvement. Treatment of relapse is controversial. Again, I would like to thank the organizers for this wonderful opportunity and their warm hospitality. And this is now University of Minnesota. Thank you.
Thank you, Dr. Guru. I think it's a nice awakening topic. I was actually wondering, if you have a clinical situation, non-alcoholic pancreatitis, and the IgG4 is not elevated, what do you want me to do?
So then, again, autoimmune pancreatitis is a zebra. IgG4 may not be elevated in a non-alcoholic pancreatitis because, again, pancreatitis is not the presenting symptom of autoimmune pancreatitis. Autoimmune pancreatitis presents as a jaundice rather than pancreatitis. Pancreatitis is seen in less than 20% of the patients. So typically, we do not even check IgG4 levels. But if IgG4 levels, you check for an idiopathic recurrent pancreatitis. If it's not elevated, you look for other causes like hereditary cause for pancreatitis.
We also have an entity called IgG4 hepatitis.
Yes.
Not amounting to sclerosis.
Right.
I think there histopathology is the best. But ultimately, it's the histology which makes before you start and see. Why is calcification peculiarly absent in autoimmune?
No, you could get calcification after 5 or 6 years of treatment as well, but it's not as common as in alcoholic pancreatitis.
Thank you very much. If there is any comment for the day, I'm sure the organizers would say that we are concluded.
Can I ask a question, sir?
Yeah.
There are few studies about IgG4 related disease or the IgG4 deposition in the celiac disease. So what are celiac disease in the gut due to D3? So what is your opinion?
Sorry, I did not hear the last part.
In the celiac disease, which is quite common in India,
right.
There are few studies in the last 2-3 years that there is a role of IgG4. And do you have any opinion about
yes.
that?
Yes, I also showed IgG4 could be elevated in celiac disease. It's one of those false negative findings. So celiac disease is also it could be elevated in pancreatic cancer as well. So that's why we need to go by the HISOC criteria and not one criteria in isolation. Because if you just look for IgG4, you could see them in celiac disease and pancreatic cancer as well.
Because one study was done in our center and we found that IgG4 levels were raised in around 60% cases of celiac disease in children.
Right.
Okay, thank you very much. I think we close. I request Sandeep and
thank you, everyone. At the outset, I'd like to thank Dr. Dadi for conducting the CME seamlessly. We had actually 9 grilling hours of academics. There were 35 talks, and it was a continual type of method we used, no question answers. So a big thank to all the speakers, moderators, chairpersons, and adjudicators for their hard work for making this CME program a success. And there's no success without the delegates, and they were attending till the last so seriously. after so much of grilling talks. Sorry for some glitches which we had in food section, because we underestimated. We thought we'll have 400, 500 delegates for CME, but actually it went over 1200. So big thank to all the delegates who attended the CME program. So it had actually shooted 3 times more. There are a few announcements. I will like Dr. Dadi to announce them. Dr. Dadi.
Good evening, everyone. So tomorrow morning we will start at 8 a.m. So we'll be starting at Hall A, Hall B and C, 8 a.m. to 9 a.m. We'll have breakfast sessions in Hall B on NAFLD and in Hall C on GIT. And in this hall, we'll start at 9 a.m. with the prestigious ISG orisons, Young Investigator Award sessions, and plenary sessions. Post lunch, again, all the 3 halls will be functioning. So Hall B and C will be functioning 8 a.m. to 9 a.m. This hall will start functioning from 9 a.m. onwards, and post lunch, all the 3 halls will be functioning in parallel. So, requesting everyone to reach at 8 a.m. to Hall B or C, depending upon your requests.
Now everyone is requested to reach the Dome 2 for inaugural function at 6 o'clock. They can have tea in between, which is outside Hall A, and in the Dome 1 opposite Hall B. So see you all at inaugural function. Thank you very much.